Everybody ready? Close. Good morning, everybody. Welcome. Good morning. All right, we are so excited to see all of you this morning. For those of you online, know that we have over 100 people in the room here today as well, and we have hundreds of you online. We're so excited that you're joining us for the next couple of days. We have an action-packed program. It's so exciting this year to think about where we are, and we'll talk about that as we go through the next 2 days. If you don't know me, I'm Patty Keating. I'm the Executive Director of the HypoPARA Association, and I'm also a post-surgical patient of 10 years myself, so I understand what it's like to live our lives, and I'm here to advocate and support for all of us. So first of all, before we get rolling, I just need to say some thank yous because, you know, a production like this doesn't come since yesterday. It takes all year to get it going on. So our amazing team, we found this team a couple of years ago that helped us with our PFDD. They've helped us with the last conference and this conference, and they certainly make us look good. So thank you, John and the Dudley team, for all that they do to put this production together, and for you guys online to have a really great show as well. We are super excited, and our agenda became very action-packed because we have 5 biopharmas that'll be speaking to you over the next few days. Can you imagine all the options that we are potentially going to have in the future for us as patients? So we're happy to have them. Our medical advisory team is here. They are steadfast with us all the time. Anything we need, they're saying, yep, we're there to help you. So we thank you, our medical advisory team. And then this year, Michelle and I have taken on leadership of the organization and are doing this more full-time now, as you can see all the different stuff that we're doing. So I wanted to recognize Michelle as my right-hand man here and partner in crime in running the organization. And we have Bob Sanders in the room, our chairman of the board. We all know and love Bob. Katie Gillick, our newest member, she's our secretary for HPA. And we have Barry, who couldn't be with us. She's online, so Barry is a board member as well. And our biggest reason for being here is all of you, right? All of the patients and caregivers. So if you are a patient or a caregiver, if you could just give a little wave. We're so happy to have you here, and we welcome you with open arms. All right, so people online, you're going to have the opportunity to ask some questions. You'll need to use the submit form when you do that as we go through. Q&A, we'll have Q&A after every presentation, so we'll be able to do that. Videos are going to be available in the next week or so. Give us a little time to take a breath afterwards, and you'll be able to see those online if you're a registered participant. Let's see, what else? When you are asking your questions online, please make sure that you're not disclosing your personal information. And doctors can only answer broad questions. They can't answer like your medical questions on there. But we will do our best to get back to all of them that we don't get to within the next week if we can't do that. So people in the room, if you've got your cell phone, if you could take a peek at that, make sure that that's off. For people online, the agenda is on our website, as you've seen probably already. We'll be following that agenda pretty tightly. People in the room, it was in your bag, so you'll follow that agenda there. And we'll have scheduled breaks throughout. We'll have nice food and all that kind of stuff for the people in the room. But we do have a full day ahead. So this year, we learned and we grew a lot as an organization. But we also know that this organization wouldn't be here without James Sanders. And unfortunately, we lost him this year. So we wanted to take a little moment this morning to really talk about James and the impact that he made with the organization. So Michelle, would you like to join me?
Good morning, everyone. I'm Michelle Reyes, the Associate Director of the Association, and I am excited to tell you about our founder, James Sanders. For those of you who don't know, James Sanders was a genetic hypopara patient and the father of 5 sons, all of whom also had the disorder. In 1994, after meeting another patient while participating in a study at the NIH, James had an inspiring idea. He started this association. That included a newsletter for patients, caregivers, and doctors to raise awareness about a rare disease that had no treatment options. In 1998, he and his wife, Carol, incorporated the association, and by 2003, it became an official 501c3 organization. Now, let's hear about our founder and his vision from this video.
I think all of us intellectually understand that there are 100,000, 150,000 people in the United States that have hypoparathyroidism. But until you can actually meet somebody, shake their hands, hug someone, cry with them, compare experiences. I know that, or when that happened to me, this is what I did. It's hard to realize completely that you aren't really alone, that you do have someone else who understands.
In the early 2000s, James hosted the first HypoPARAthyroid conference. We are incredibly grateful to him for creating an opportunity for all of us to finally meet others who understood our experiences. I attended my first HypoPara conference in Chicago in 2017, which is also the year James retired. I will always be thankful for the chance to meet him. Under his leadership, we reached a significant milestone with our first approved treatment, evolving from a simple patient support group into something much greater. Earlier this year, we lost James, but what we will not lose is the sight of his vision and purpose to improve the lives of individuals impacted by hypopara through education, support, research, and advocacy. Please cue the next video.
We would like our association and our website to be a home that members can come to for information. They can talk to each other, share information. We just want to make a difference.
So to continue his legacy and to make a difference, we are proud to announce we are establishing the launch of the James Sanders Legacy Award. Here is Patty to explain more.
All right, thank you so much. So our Legacy Award, we're going to honor somebody this year for that. But first of all, I'd like to ask Bob, can you come up for a second? So I told Bob at our last board meeting, I'm like, hey, you're going to have a special project for 2025. I'll tell you about it later. It's a little bit of a surprise. So your surprise is you get to lead this absolutely fabulous, you know I'm good at delegating, right? So you get to lead this, and I know you'll be super proud to lead this Legacy Award. The award is we're going to honor, we put away some money to be able to do a scholarship fund so that we can send 3 patients to this conference every year, all expenses paid. We didn't want to go this year without awarding somebody, so there is somebody in this room that is here because they won the award. Michelle and I, we were like, oh my gosh, there's going to be a process. I'm sure he'll create all the process and everything that goes with it. But this year, we just wanted to think about somebody who really had a lot of courage, somebody who interacts with our patients on a daily basis, and while they suffer through hypoparathyroidism, they also acknowledge and help and lift people up. And we see them doing this on a daily basis on our social media sites. The other piece is this person took on a big project this year, and they had to do a video with Dr. Kohlmeyer for Medscape, and it's a continuing education class. So we were really excited to put her up for this, and she stood up and she took on the challenge. She accepted all of our coaching and feedback. She had me first, and then she got Dr. Kohlmeyer, and she just worked through it and created a wonderful thing. So we would like to introduce you to the James Sanders Legacy Award first-time winner, Heather Menken. All of this, and she lives as a hypopara patient, stage 3 kidney disease, but she keeps that positive attitude, keeps the courage going, and really uplifts her fellow patients out there. So congratulations. Do you want to say something?
If I'm going to just stand here and cry. I just want to say thank you. There's my big supporter right there. I just want to say thank you. James Sanders was wonderful, and I appreciate him making this for us, and so we can come together, because when I walk in this room, I don't have to make excuses, and you guys understand, and we can just be who we are for 2 days, and I just appreciate it. Thank you so much, and I will try to honor it.
Dr. Kohlmeyer's dying to give you a hug, so there you go. All right. Anything you want to share?
I just,
Putting you on the spot.
yeah, it's fine. It's been a hard year, and I want to thank everybody that reached out after my dad passed and all the kind of words that you saw, that I was able to see online and share with my family and whatnot, and I really, really appreciate all that. But I can't do this without these two amazing ladies standing next beside me between Patty and Michelle, and I just want to thank them for all that you guys do, because this last year we wouldn't be here without the work that they've been able to do, and then being able to work full-time pushing this organization forward and moving it in that direction has made all the difference in the world, and I just want to thank them from the bottom of my heart. And thank you for this. That kind of snuck some of these videos up on me. That was very touching.
Oh, yeah.
And so,
Very good. Well, I'm
Thank you.
excited about your new project, so. Very good. All right, well, that was wonderful, and we do thank Mr. Sanders so much for everything. I remember my first conference as well, and if I don't know where I would be if I didn't go to that conference and really learn what I needed to learn and land where I needed to land. So let's give it up one more time for James Sanders. All right, so big deep breath in, smile on our face, let's get rolling. So today we're setting up, our first presenter is going to talk about HypoPARA 101 to make sure we've got grounded in our basics. We know that every time we hear something, we may hear it a couple different times throughout the next couple of days, but you may hear it a little differently and it'll connect with you. So we're excited to have Dr. Mark Warren with us this morning from Greenville, North Carolina. Welcome aboard, Dr. Warren.
All right, good morning. So I get to set the stage for the rest of the conference. And so what is a 101 course? It's introduction. A lot of you are probably at the graduate level. It doesn't hurt to hear it again, and maybe you'll hear it several times this weekend. So we're going to discuss several things. All right. Advance the slides. Advance the slides, please. Didn't seem to go. There we go. So we're going to talk about several things. We're going to set the stage again for the weekend. Let's get the definition of hypopara, what's acute, what's considered chronic, what are the causes. We'll look at both the normal and the abnormal parathyroid physiology, the signs and the symptoms of hypopara, some of the risk factors for post-surgical hypopara. How do we monitor hypopara? What are some of the complications? We'll look at the conventional therapy. We'll talk about that. And we'll look at some of the unmet needs. So let's start with the definition. It's a rare Hypopara is a rare endocrine disease. It results in either absent or inappropriately low concentration of parathyroid hormone in the setting of low calcium or hypocalcemia. Now, this is probably 8-year-old data now as far as a prevalence of 77,115 in the U.S. It's probably much more than that, so Dr. Manstat, we probably need to update this study. It's probably close to 150,000 at this point in the U.S. And anterior neck surgery is the most common cause of hypopara. So etiology is a fancy medical term for causes. Post-surgical is 78% of it. Other secondary things like you can have radiation therapy, you can have other things that you can have metastatic cancer, other things can damage the parathyroid glands. There's familial, about 7%. And idiopathic is another fancy medical term for we don't know, or I like to say we're not smart enough to figure out yet. So that's what, most of it, 78% of it is post-surgical. There are other, so looking at some of the genetic causes, there's disorders of parathyroid formation. The most common is the George and Charge syndrome, but there's at least 15 others, and I couldn't possibly list them all and get through the lecture in time if I did that. So there's at least 15 others. There's also destruction of the parathyroid glands, autoimmune disorders, and polyglandular syndromes. And there are disorders of parathyroid secretion, such as autosomal dominant hypocalcemia type 1 and 2. We'll hear about that later on today. And there's also, you can also have a autoimmune syndrome where the antibody activates the calcium sensing receptor. There's familial dominant hypopara and hypomagnesemia syndrome, there's Gittleman syndrome, and many, many, many others. So I was going to put a slide with all of them up there. I couldn't even possibly see the letters, so I couldn't do them all. But just as you know, there are many other causes of hypoparathyroidism genetically. Okay, so let's look at the normal function of parathyroid hormone. In response to a lower calcium, the parathyroid hormones, which are of parathyroid glands, which are 4 little glands at the behind the thyroid. They're about the size of a grain of rice, and they secrete parathyroid hormone. And so in response to low calcium, it activates, has several actions. One, it works on the bone to cause bone resorption, to release calcium from the bones. The bones are storehouses of calcium. And it also works on the kidney. It helps with the calcium resorption. So when the kidneys, they're filters, so they filter the blood, and calcium comes out very easily. And if you don't reabsorb it from the tubules, you'll end up with excess calcium in the urine. And it also helps with phosphorus excretion. And in the kidneys, it helps regulate the activation of vitamin D from 25-hydroxy to the dihydroxy, 125-dihydroxy vitamin D. And that acts to cause calcium absorption in the gut. So by increasing calcium reabsorption in the kidneys, help the calcium absorption in the gut, and help with bone reabsorption and releasing calcium, it causes an increased calcium. And that in turn feeds back to the calcium sensing receptor. And then that regulates the parathyroid hormone release. So there's always this feedback mechanism. It's important to keep calcium in a good range because calcium is important for a lot of things, muscle, muscle function, nerve function, etc. So in the absence of parathyroid hormone, you don't have that calcium reabsorption. You end up having too much calcium in the urine, which can cause kidney stones and calcification of the kidneys. It also increases the phosphorus reabsorption, so you end up could have increased phosphorus levels. And because you're not activating the vitamin D, you have a decreased calcium absorption, and you're not absorbing calcium from the bone, there's not resorption from the bone. All this leads to a decreased calcium and the problems thereof. So let's look at how do you identify, diagnose, treating, and monitoring hypopara. Well, these are the symptoms. Signs are things we measure, and symptoms are things you feel in medical parlance. The severity can be from no symptoms at all to very severe, and it really depends on how quickly it got there, how severe the calcium is, how low it is, and the chronicity. So you could have, if it's chronic and you've developed it slowly over time, you may have no symptoms despite a very low calcium. I've seen people come in with calcium of 6.5 presenting with just cardiac failure. Their heart wasn't functioning very well, but they had no symptoms of paresthesias. And once we corrected it, their heart function went back to normal. That spoke to chronicity. But if you had it immediately after surgery, it happens very quickly, and you can have very low calcium levels. So that can lead to more severe things like heart arrhythmias and laryngospasm, where you can't feel like you can't breathe because your throat's closing up. And you can have seizures as well with very low calcium. But most of the symptoms we have are paresthesias, muscle cramps. Those are the things we have. We'll talk about some of the other symptoms in a moment. So who's at risk for developing post-surgical hypopara? Well, if you happen to have low preoperative levels of vitamin D and calcium, that's a problem. And you also, if you have a low intraoperative parathyroid hormone level, sometimes they'll measure that after parathyroidectomy or thyroidectomy. And then we used to do a lot of parathyroid autotransplantation, hoping that the gland that's transplanted would start working. That turned out not to work very well, so we don't recommend that anymore. And if you have to have reoperation for your thyroid for bleeding, that can be a problem or a risk factor. And if you have pre-existing Graves' disease and failure to identify at least 2 parathyroid glands during surgery, and if you happen to have PTH levels less than 10, 12 to 24 hours after surgery, again, at reoperation for bleeding or heavier thyroid specimens, for example, if they're trying to be a very aggressive surgery for large thyroid cancer or a complicated thyroid cancer. So those are risk factors for developing post-surgical hypopara. So how do we define transient versus chronic? These are the newest guidelines. So transient is defined as less than 12 months, and chronic is defined as lasting more than 12 months. Now, you can also have intermittent hypopara, where you have sort of a partial parathyroid deficiency, where you feel fine until you do something, perhaps overdo something physically, and you have symptoms. And also, post-surgical hypopara may resolve within days, weeks, months. Usually about 12 months it would have resolved if it's going to, but sometimes we even have it resolve even beyond the 12 months. But the current guidelines recommendations are for the chronic is defined as greater than 12 months. Our conventional therapy is to start with calcium carbonate or calcium citrate plus active vitamin D analog, and we titrate or we adjust those doses to maintain the calcium in the lower half of normal, lower half of the normal range or just below the normal range. Well, I like to keep it between 8 and 8.5. Normal range usually 8.4 to 10.5. We adjust the vitamin D otherwise to keep the 25-hydroxyvitamin D in a normal range. Additional therapy might be needed if you have excessive calcium in the urine, we call hypercalciuria, or if you're having problems with elevated phosphate levels. So these are the medications we currently have. So calcium carbonate or calcium citrate, that's available over the counter, of course. Calcium carbonate is the most common one. Calcium citrate has less calcium per pill. You have to take more of it, but it's less constipating. The range is anywhere from 500 to 3,000 milligrams per day, given 3 times daily with meals, because it enhances absorption. But certainly I've seen folks needing 12 grams a day in more severe cases. That's a lot of pills, and a lot of you know what I'm talking about. And then we'd like to supplement with some vitamin D, 1,000 units a day, usually 1,000 to 2,000 is what I recommend, to maintain a normal 25-hydroxyvitamin D level. We can also use ergocalciferol, which is a prescription strength vitamin D, 50,000 units weekly, if necessary. We actually used to use that before we had less expensive calcitriol to treat, but we don't recommend that as a way to monitor or to adjust the calcium levels, because it's long-acting. You can get long-term toxicity from it if you were to get toxic from it. Calcitriol is the active vitamin D, and that's what we typically use to help maintain a normal calcium level. And it can be given 0.25 micrograms to 3 micrograms a day Again, we adjust it based on the calcium level. Alpha-calcidol is used not in the U.S., so it's mostly European and other countries. So that's not a U.S. Medication. And then thiazide diuretics are used to control hypercalciuria, or the calcium in your urine. We monitor you looking at the calcium and magnesium, phosphorus. We do that every 3 to 12 months, depending on how stable someone is. Once they're stable, every 6 months is fine. But if they're not stable, we may have to come even more frequently. We'll check their creatinine or kidney function. We'll look at their vitamin D every 6 to 12 months. And we'll do 24-hour urines as necessary, around anywhere from 6 months to every 24 months, depending on how they're doing. If they've had a normal one, we probably go at 24 months. Ultrasounds of the kidneys to look at nephrocalcinosis, which is calcium in the kidneys, and kidney stones can be done after you've had it after hypoparathyroid's you've had it for a couple years maybe, or if you're having uncontrolled hypercalciuria or too much calcium in the urine. And patients with visual symptoms may need to see their eye doctor to look for cataracts, et cetera. But it's also look at not just their numbers, but the physical functioning and well-being, because over 40% of folks with hypopara report interferences with work productivity that they attribute to either physical or cognitive symptoms experienced with hypopara. And 33%, or a good third of them, reported no longer being able to work due to their hypoparathyroid symptoms. And 60% of the participants reported they're less physically active than they used to be. And I think that as a clinician, it's important to ask beyond what the levels are, look beyond that and ask how they're doing through these other symptoms and beyond just the numbers. So what are the complications and then some of the problems with conventional therapy? Well, it can affect basically every system. We're going to have a lecture dealing with all of this, specifically about the complications of hypoparathyroidism. But we'll look at a few of these, but we'll look at kidney and we'll look at CNS and the cardiovascular system as well. I'll say in the dental, it's not an issue unless you had it during your formative years as a genetic hypopara. So let's look at the renal complications. Up to 40% of patients who had nephrocalcinosis. These are people who had it for a while, and 36% had kidney stones. But again, these are folks that probably have had it for several years. And there's about a 3 times risk of developing chronic kidney disease and about 1.6 times risk of progression to a higher chronic kidney disease stage, and a 2-fold risk of progression to end-stage kidney disease requiring dialysis. So once you have it, there's a higher risk for it progressing. As far as cardiovascular complications, there is a higher risk of what we call arrhythmias, which atrial fibrillation, for example, is a very common one. There's also a higher risk of having cardiovascular disease like coronary disease, myocardial infarctions, strokes, and peripheral vascular disease. So there's a higher risk of that as well. As far as the CNS complications, so the central nervous system, that's a fairly broad subject, but here's a patient says, I just don't think clearly anymore. I just don't feel smart. That causes an onset of anxiety and depression. It just wears you down. That probably sounds familiar to a lot of you. So hypocalcemia and low parathyroid hormone levels have been suggested as factors that may induce central nervous system disturbances. It's been estimated at least half of folks with post-surgical hypopara exhibit psychiatric symptoms, and folks with hypopara have a higher incidence of depression and bipolar affective disorders compared to the general population. And folks with hypopara have significantly more cognitive effects, reduced inhibitory control, psychomotor retardation, which means you're not moving as well, and compared to control populations. There are still some unmet needs in hypoparathyroidism. 72% of patients experienced more than 10 symptoms in the last year despite management regimens. And 79% of patients required hospital stays or emergency department visits due to hypopara. 75% of patients felt concerned about their long-term complications of their current medications or managing hypopara. So there's a lot of concern. And 67% of them required multiple medication regimens with calcium and active vitamin D. So there's a significant burden of illness. And 34% of patients required taking at least 6 or more blood tests over a 12-month period to check their serum calcium. And they saw their physicians at least on average around 4 to 5 times per year. So there is a significant burden of illness of having to take pills, getting your blood tests, and seeing your provider more frequently than you otherwise would need to. So even with normal calcium levels, or the best thing, getting our calcium level where we want, people still don't feel well in general. In fact, look at the big blue there, the big blue piece of the pie. 48% of patients did not feel well despite having recommended serum calcium. Despite this, they had low well-being. In fact, only 22% of folks had the recommended serum calcium and had a high well-being. So we're missing the mark 4 out of 5 times. Only 1 in 5 patients has the recommended calcium level and feel well. We also know there's an impaired quality of life. There is a questionnaire called the SF-36. This is a questionnaire with 36 questions, and it has domains of physical functioning, bodily pain, general health, social functioning, emotional health, and mental health. And you want, like on most tests at school, you want to score high here. So you have no impairment, you put 100. If you have severe impairment, you put 0. So in the light gray are the normal controls, and in the darker line is folks with hypopara. As you can see on every domain, they score lower. So there is an impairment in the physical, the bodily pain. You can see really in that role physical, that second one, they're much lower than normals, than their comparators. And social function is impaired, mental health is impaired. In fact, one patient said, I just get worn out quicker and my muscles start hurting and they're sore. So there's a quality of life issue, and hopefully if we, with better therapy, we'll be able to address the quality of life. So conventional therapies fail to restore normal parathyroid physiology. Currently addresses just the serum calcium. It doesn't address the active vitamin D formation in the kidney, the poor absorption of the calcium from the intestines, the calcium reabsorption issue in the kidneys, and the calcium resorption in the bone, and it doesn't do anything to address the quality of life. So what are the indications that the hypoparathyroidism may not be fully managed? Well, if you're having problems with hypocalcemia despite taking the conventional therapy, despite using 2 grams a day of calcium or more, 2 micrograms with the active vitamin D, or if you're having intercurrent problems, you're getting hypocalcemia symptoms and issues with malabsorption, that could be an issue. If you're having hyperphosphatemia despite the therapy you have, it could be affecting the calcium deposition or deposit of calcium in the brain, or the blood vessels in the kidneys, or if you have kidney insufficiency with reduced what we call EGFR or glomerular filtration rate, or if you're having problems with hypercalciuria, because this may increase your risk of developing kidney stones and calcium deposits in the kidney. And finally, poor quality of life. And this is where you have it has negative impacts on relationships, employment, and daily activity and mental health. And why that's important is that the other ones are those are things we can measure. Quality of life is something that you're telling us about. And I think insurers typically use guidelines to decide how to pay for medications. So I think now we have some guidelines here that determine when your calcium may not, your hypoparathyroidism may not be fully managed. So these may be used, we don't know yet, but by the insurers to determine if you would be an appropriate candidate for expensive medications. So some of the unsolved problems, hypopara is the only classical endocrine deficiency without a currently available hormone replacement therapy, only one. Now hopefully in a couple months, this will no longer be the case, But right now, that is the case, and I find that's most incredible. And even if a patient's on calcium and vitamin D, symptomatic hypocalcemia or hypercalcemia occur in the setting of acute illness, dehydration, or stress. And some patients with hypopara have disease that is refractory to conventional therapy. Even with close monitoring, patients can continue to have elevated phosphorus levels and hypercalciuria. And we can still have problems with reduced physical functioning and well-being. So to summarize, hypopara is an endocrine disease that can impact every organ, essentially. Understanding the diagnosis and symptoms of hypopara can help us to improve the quality of life and long-term disease outcomes. Conventional therapy does not address parathyroid hormone deficiency and may increase the risk of long-term complications. The burden of chronic hypopara negatively impacts the physical functioning, well-being, irrespective of serum calcium levels, and providing biochemical control, high quality of life, and to minimize the potential risk of long-term complication remains a challenge today. And I'll leave you with this. One of my medical students rotating through asked me why I was so excited to participate in the clinical trials of hypopara, and I said, you know, being told that being thanked for finally getting their life back never gets old. Thank you.
All right. Thank you, Dr. Warren. That was wonderful. We're going to take some question and answers from the room, and we have a bunch online. Anybody in the room have a question for Dr. Warren? And we have Katie has a microphone, and Bob has a microphone. Is there anybody in the room that has a question? All right.
Hello, doctor. In one of your slides, you were explaining, right over here. In one of your slides, you were showing some ancillary symptoms that might come along with this disease, and it mentioned seizures as a potentiality. Seizures, as I understand them, is an issue of the brain that is affected physically. Is there some difference to what seizures are when it comes to this issue?
All right, so some people have a predilection to having seizures anyway. So having a low calcium lowers your seizure threshold, we call that. And sometimes if you don't have a predilection for seizures, just having a severely low calcium will cause a seizure because the neurons start firing on their own. So you can have that just from a very low calcium. And I've seen that, unfortunately, several times.
Okay. Over here?
Thank you. Doctor, could you explain maybe a little bit more in detail the effects of calcium on the cardiovascular system, just the pathophysiology of that?
The effects of calcium in the cardiovascular system. Well, so you have to have calcium for normal muscle functioning. Is involved in the contraction of the muscle. And so the heart's a very big muscle, and it requires calcium. And if you don't have enough calcium, you're going to not have proper contractility of the heart, so it's just not going to work as well. And it also affects the electrical system of the heart. So, so that's where you have some of the arrhythmias. And then it can also cause issues with depositing calcium in blood vessels, causing issues as well. And sometimes that's when your phosphorus and calcium levels, your phosphorus is high and your calcium, what we call calcium phosphorus product, is too high. So we'd like to keep that phosphorus in normal range.
Okay, Michelle.
Yeah, we have one online that's related to that question, and it says, how would I know if it's affecting my heart? Is there a test I should be getting?
There's nothing specifically that we recommend for screening purposes other than what you would ordinarily do for just regular health. So there's really no issues unless you're feeling as your pulse is irregular or abnormal, then get checked out. But there's nothing preemptively you need to do.
Unless you're having a symptom.
Yes,
Of the heart
unless you're
fluttering.
having symptoms.
Okay, question over here.
Dr. Warren, is having coronary vasospasms, is that a normal symptom to be having?
You can have that because, again, the calcium levels are low and there's muscles in the vasculature, and it can cause vasospasm as well, or spasm of the blood vessel. Fortunately, it's not very common.
We have a question in the back. Bob?
Hey, I just had a question. I saw a thing about ocular complications. I was just asking about the symptoms that comes with hypoparathyroidism patients.
It's mostly cataract formation, can be more common.
Michelle, anything else online?
Yes. Are there any specific recommendations for increasing your calcium supplementation when being more active than usual?
Well, that's a tough question. And basically, for folks that are become more physically active, typically the calcium levels get a little lower, and you require a little bit more calcium supplementation. That's going to be a little trial and error, taking a little more calcium than usual.
Next, they ask, does consuming caffeine affect my calcium absorption?
Not that I'm aware.
Hi, that was fantastic. I always learn something. Can you say something about calcium safety and what you recommend to your patients when they're worried about a calcium crisis?
If they're worried about calcium crisis, obviously contact your provider ASAP, but in the meantime, what can you do about it? The problem is the symptoms may not be very specific, right? So you start worrying about it, you get anxious. The symptoms are very similar to having a low calcium. So that's part of the issues with cognitive issues, you get anxious. So there's a lot more anxiety with this condition. So I think that's really talking with your provider and discussing how often this is happening, and perhaps getting a little more calcium, more frequently calcium tests to show that you're having a stable level. And I think if you're having some issues, discuss with maybe taking an extra calcitriol and extra calcium would be reasonable. But again, most of those symptoms are probably anxiety related and not related to a lower calcium. It's hard to know, isn't it? It's really, it depends on the person, and I think that's a discussion with the provider and making sure their calcium levels have been relatively stable.
Bob?
So I noticed on the form that the Parkinson-like disease symptoms can be part of this. Can you explain what those symptoms would kind of look like?
So Parkinsonism occurs more commonly in hypopara, especially those who have had issues with higher phosphorus levels and having hypoglycemia for many, many years, because you get calcium deposition in what we call the basal ganglia. It's a part of the brain that's involved in Parkinson's. Often these symptoms get better if you correct the hypocalcemia. So Parkinson's the syndrome is, you're having slower gait, you're moving slower, you're having tremors, and those are the symptoms of Parkinson's. And we're going to have a lecture about Dr. Schoback later about complications. I think she'll deal with that a little bit more.
One more, Bob?
Yes, I'm hearing, because I'm still learning about being hypopara, but there's always sort of like a debate between citrate and carbonate. Some people say take the carbonate because carbonate binds with phosphorus, which keeps it better in range. So I'm just wondering your opinion or your expertise, like which one is really better to take, the citrate or the carbonate?
The calcium carbonate is a better phosphorus binder, but they both can bind phosphorus. I prefer calcium, I prefer not doing calcium citrate because you're having to take so many. But if you're having issue with calcium carbonate with constipation, you can always take calcium citrate, but you got to take about twice as many pills. So if you're already taking, 6 pills of 500 milligrams of calcium carbonate, then you're going to have to take 13, 14 pills of calcium citrate, and I think that gets to be more cumbersome. It's really up to the person.
Okay, Bob?
Hi, you had mentioned the SF-36 Quality of Life Survey. In preparation for Yorvipath coming on the market and people needing to argue with their insurance companies, are there any other medically accepted quality of life, mental health, cognitive surveys we should look at completing with our endocrinologists ahead of time to support getting the medication approved?
Oh, that's a good question. I think you're better off not having it, because if you have something, they're going to hold you to it. So I think more of a discussion of quality of life, how they're feeling, and just really having that in the medical records. I don't think SF-36 is it's really for clinical trial purposes. But I think if you had that, they may help direct the questions from the provider. So it's something you could certainly develop, and there are some specific surveys of hypoparathyroidism and quality of life there you could use as well. But in a busy practice, it'd be hard to really give that survey and involve the provider. But that's something we can certainly discuss and talk about. It's intriguing.
Okay, Michelle?
Yes, I have one that says, does Hypopara affect our immune system?
I don't know the answer to that question. I suspect it does, but I don't have any specific evidence for that.
Okay. And you mentioned calcifications of the kidney. If we have those, is there any way they can be reversed?
And once it happens, it's hard to reverse it. You can slow it down. To my knowledge, there's no way to reverse it.
And another person online asks, can it affect our liver?
Not to my knowledge. We can ask Dr. Schoback.
Yeah.
Marisol?
Hi, my question is about treatment. Would you recommend using calcitriol at the same time of high doses of vitamin D, like 15,000 units?
Well, I think that I used to use high doses of vitamin D to treat folks with hypoparathyroidism. That's before calcitriol was generic and the other was very expensive. So we no longer do that because the calcitriol is shorter acting. It's quicker to get your calcium levels up, and if you're having problems with you overtreat, it's quicker for it to go away. So I don't recommend using just the vitamin D as your primary therapy. So I recommend 1 to 2,000 units of vitamin. It just depends on what your vitamin D level is in the blood. That's what I would monitor.
In instances where your hypocalcemia requires an ER visit, are there helpful tips and tricks to work with doctors who aren't experienced in this rare disease so that they skip some of the more common checks of things firsthand and get to the immediate issue?
I'm sure you've had a lot of your people have these experiences, I think. I think grab him by the tie or her by the coat and say, I have hypocalcemia, I'm in crisis, check my calcium, give me some IV calcium right away, please. I think you have to be very proactive. Said, I know what my issue is, I've had it before, I have hypocalcemia, please, I'm really having a crisis here. And I think that if you can go ahead and get some calcium ordered and while the calcium level's cooking, I think that's, you just have to be really proactive and let them know you know what you're talking about, you've done this before, and so it may be helpful.
And hopefully it'll get through. And you have your emergency cards that are in your bags that you got. Carry those everywhere. Keep them in your car, keep them in your purse, keep them in your pocket. Do they work? Sometimes they work, sometimes they don't, but have every piece of something that you can have to help calmly explain to the doctors after we grab them by the coats to say, help me, give me calcium. So Bob?
Good morning. My question is life expectancy. I remember at one point they had no idea what our life expectancy was. And I'm just wondering now that there have been some biological drugs, like there was Hypopara for a while, now there's other ones. Is that affecting anything? Or have you looked at people when insulin came around, which I realize is over 100 years ago, but how getting that changed their life expectancy, or if there might be any correlation? Or we still know nothing?
I don't know of any studies of life expectancy or decreased life expectancy with hypopara, but of course if you're having chronic kidney issues, that increases your risk of cardiovascular disease, and also if you have hypopara, you have a higher risk of cardiovascular disease as well. So I suspect it affects it, but I just don't know to what degree. I think managing the issues and knowing what the issues are, managing the hypopara and the hypocalcemia effectively and not overtreating will help that, but I don't know any data looking long-term outcomes with longevity.
Okay, and I'm going to ask your final question. You got one more.
One more.
This may be the first we can't answer that question. So I'm curious because you've done all the trials for all the different hypopara drugs that are going on. In your experience, have you noticed a difference in kind of the levels on versus symptoms? Can people tend to be at a little bit lower level and be okay and not have symptoms where before they had to be at a higher level? Any kind of experience that you could share?
I don't know that I've seen that. I think that when they get to the, usually in the blinded section, we know who's on placebo because their calcium and calcitriol requirements didn't really change. But in the open label, for sure, we know. And people just feel so much better that I just don't get many complaints. They're just happy to be normal.
Yeah, because we're treating the hormone.
Yeah.
Yeah, very good.
Thank you.
Well, let's give it up for Dr. Warren. Thank you so much. Thank you so much. All right, so wow, gosh, we put him on the fire in there. He had a bunch of questions. So we are getting ready to move on to our next presenter. And this is our first biopharma for the 2 days that we're excited to have on board. And they're going to be talking about genetics. And it's really interesting because they say that 25% of hypopara patients are genetic, but I have to tell you, I believe that there's a lot more out there. We believe there's a lot more out there because they may be running a little low on calcium, but never get that PTH checked, and they don't understand like the symptoms that tingling lips or whatever. As a kid, Bobby, Sue, and Joe doesn't have the same thing, so they don't understand that maybe they are having symptoms and they don't get it checked. So our mission, one of our missions at Hypo Association is to really be able to try to find more patients that need our help, especially in the genetic category. So we're excited to bring to you today first is Arun Matthew. He's the head of medical affairs at Calcilytic Therapeutics for Bridge Biopharma and a new daddy. Welcome over.
All right, thank you, everyone. Before I get started, just a quick public service announcement to set your clocks back an hour before you go to bed tonight. Otherwise, you might end up here an hour earlier than you need to tomorrow. So with that being said, thank you so much for the introduction. My name is Arun, and today I'll be talking to you about some genetic causes of hypoparathyroidism. Oh, sorry. All right, before we begin, a few disclaimers. Today I will be talking to you about an investigational study drug called encaleret. I just wanted to note that it is under clinical development and its safety and efficacy has not yet been evaluated by any regulatory authority, and there are no guarantees that it will be approved or be available in any countries. So, there are really only two certainties in this life. Does anyone know what those two are? That's right. Benjamin Franklin, that's right. So with that being said, I'm here on behalf of Bridge Biopharma. We're a biotech company based out of San Francisco, California. And our mission really is to discover, create, test, and deliver transformative medications for patients who suffer from genetic diseases and cancers with clear genetic drivers, of which that one I'll be speaking to you today about is called autosomal dominant hypocalcemia type 1, or ADH1 for short. So I won't go into what is hypoparathyroidism, mostly because the great Dr. Warren just covered that just a moment ago, and also you as being the patient, you're very aware, so you already know. However, what you may not know is that there are different causes of hypoparathyroidism, of which post-surgical causes being the most prominent, 70 to 80% of cases, genetic, autoimmune, unknown, or idiopathic. So today I'll be focusing my talk on genetic causes of hypoparathyroidism, which we believe represents about 10 to 12.5% of all cases of hypoparathyroidism. So I know Dr. Warren, he had some genes listed on his slide on the previous presentation. Here I've been a bit more comprehensive with listing all of the genes, but thankfully I won't be reading through all of this. My main takeaway is that I want you to take away from this slide is there are a number of genes on the left-hand column associated with a number of conditions in the middle column, and there are a variety of ways to inherit these sort of genes. So one thing to note is AR stands for autosomal recessive, AD autosomal dominant, and XLR on the bottom is X-linked recessive, and I'll be going over all three of these inheritance patterns in just a few slides. So the genes listed on this slide are associated with disorders of how the parathyroid gland is formed. Now, if we move on, you can see another list of genes here, and these genes are associated with both damage to the parathyroid glands as well as disorders of how parathyroid hormone is secreted. And tomorrow, Dr. Gaffney will be going into more detail about different patient cases with specific conditions, so I'll leave that to her tomorrow. So you'll learn more about this tomorrow in more detail. In regards to examples of inheritance patterns, the first example I'd like to review with you is autosomal recessive inheritance. And the word recessive means that you would need 2 copies of an affected variant to be able to exhibit symptoms of the condition. So in this example, both parents are carriers of an autosomal recessive condition, and the illustration does a good job of really depicting the percent chances of having affected children. So we can see there's a 25% chance of having an affected son and a 50% chance of having a child who is also a carrier. When we talk about an autosomal dominant inheritance pattern, because it is dominant, you only need 1 copy of the affected variant to be exhibiting symptoms of a condition. So here we can see that out of the 4 children represented, 2 of them are affected or have this condition. But I just want to note that it's essentially each child has a 50% chance of having this condition. So there could be a family with 4 children where all of them are affected because each child had a 50% chance of receiving or not receiving that affected gene, or it could be 4 children that are unaffected. So I've heard both cases being true. All right, so this is also X-linked recessive inheritance, a bit more complicated. So this is where the affected variant is on the X chromosome. And here on the example on the left, as you know, men have an X and Y chromosome, females X and X. You can see that if there's an affected father and they have a son, he would have to pass on the Y chromosome. So the son would be unaffected. However, if they do have a daughter, the daughter would be a carrier for that condition. And on the right-hand side, if their mom is affected and is a carrier, then there is a 25% chance that there will be there'll be a 25% chance there'll be affected son, 25% chance of being a carrier for a daughter, and a 50% chance of not being affected. So if you are a patient with non-surgical hypoparathyroidism, there might be some value in genetic testing. And that's because genetic testing might actually uncover what the precise gene is, which might help your healthcare provider understand what the actual condition is that's leading to hypoparathyroidism. So genetic testing can help confirm a clinical diagnosis. Also, it can help guide medical management. Perhaps a condition that you actually have might require closer monitoring, so that helps your physician understand a bit more about how to monitor for symptoms and ultimately could help with management. Also with genetic testing, you're able to identify additional family members who might also be affected, who carry that same genetic variant. As you remember in my previous slides, you saw the inheritance pattern. So typically, there might be multiple folks in the family that might be carrying this sort of gene. Also, it could help in family planning. It's important to understand what the likelihood is of passing on this affected gene or not passing on this affected gene if you were to have children would be. Moreover, especially with the advent of technology and medicine and clinical trial development, there are studies coming out that enroll patients with specific genetic conditions. So if you were to receive genetic testing and confirmation, perhaps it could also help facilitate in making more informed decisions regarding the potential participation in ongoing and upcoming clinical studies. So we at BridgeBio, we do understand that there are several barriers when it comes to genetic testing, whether it be cost or access. And so we do have a sponsored genetic testing program that's available to patients and physicians in the US and Canada. We provide access to no-cost genetic testing. And the genes that I had listed on the first initial couple of slides, they're all listed here. So the panel involves those 26 different genes. And patients are eligible for genetic testing who have a diagnosis of non-surgical or idiopathic hypoparathyroidism, or who have a diagnosis of low calcium levels that's suspected to be of genetic origin, or they have a relative who has a confirmed diagnosis of genetic hypoparathyroidism. So when we take a look at the data from our sponsored testing program, we could see over a period of 3 years, we've had 242 samples come through. The mean age of these participants were 26.7 years old. And out of the 26 genes and of the 242 samples, we found 135 variants in those 26 genes amongst the participants, amongst 106 participants. So typically that's 44%, or from a better way to explain it would be 2 out of every 5 patients. And we actually did have a variant in one of those 26 genes that have been known to cause hypoparathyroidism. When we double click on that and take a closer look to see the dispersion of what the results looked like, we can see that greater than 50% of these patients actually had a variant in the CASR gene, which causes ADH1. So from our program results, we found that ADH1 was a leading cause, or the leading cause of non-surgical hypoparathyroidism. So what is ADH1? It is a genetic condition that causes patients with ADH1 have calcium sensing receptors, which are predominantly on the parathyroid gland as well as the kidneys. But these calcium sensing receptors, as from the name implies, it senses calcium, but it's become overly sensitive. So let's say, for example, a patient with ADH1, they're in a normal calcium range. The body perceives normal blood calcium to be too high. So the body says, whoa, it's way too high, we need to get rid of it, and the body will excrete it through the urine. So in ADH1 patients, low blood calcium is what the calcium sensing receptor perceives as normal. And it does this because of the oversensitive calcium sensing receptors, and it causes dysregulation of calcium homeostasis. So it's what causes this, and it's a decrease in parathyroid hormone secretion, a decrease in blood calcium levels, as well as increased calcium in the urine. When we look at the clinical manifestations of ADH1, they're fog to laryngospasms, muscle cramps, muscle twitching. So I have listed these symptoms up on the slide for your reference. And when we talk about increased urinary excretion of calcium, especially over the long term, you can imagine that there are some calcium deposits that end up in the kidneys and ends up calcifying some of the tissue, could result in kidney stones, and ultimately over time could result in renal injury or chronic kidney disease. So when we did a systematic literature review of patient cases that have been described in literature, we saw that about greater than 70% of patients presenting with mild, moderate, or severe symptoms. So currently, how is ADH1 treated? The recent guidelines suggest that standard of care includes supplementation of calcium and activated vitamin D. However, the standard of care that's available does not really address what's the real underlying cause of ADH1, which is those overactive calcium sensing receptors. And moreover, for a patient with ADH1, if they continue to take increased calcium supplements, there is a potential to worsen or induce increased calcium excretion in the urine. So when we looked at the literature and what it showed from patients who are on these supplements, we found that 22% of these patients were able to normalize their blood calcium levels. 29% of these individuals were able to normalize their urine calcium levels. But really the goal here is to live with normal blood calcium levels and normal urine calcium levels, of which only 2% of patients were able to achieve. So currently, as of now, there are no FDA-approved treatments that are specifically indicated for ADH1. So encaleret is an investigational oral calcilytic agent that we're studying for a potential treatment for ADH1. An investigational drug means that it's a medicine that's being studied in a clinical trial, and we're trying to investigate its safety and efficacy. An oral medication means it's an oral tablet. And the word calcilytic, it's a class of drugs that actually target the calcium sensing receptor. And calcilytics, we've seen to decrease the calcium sensing receptor sensitivity, target the calcium sensing receptor in patients with ADH1 with the calcilytic. We perhaps can normalize that oversensitivity and then perhaps normalize everything downstream. So encaleret, it's really being studied to evaluate its effects on low PTH, low blood calcium, and high urine calcium in adults with ADH1. We currently have a phase 3 study that is ongoing, as you can see in the schema up here, and tomorrow, Drs. Gaffney and Drs. Roscoe will go over this in more detail. However, I just want to point, big picture, patients will be randomized 2-to-1 to the encaleret or the supplementation arm. So that means if there are 3 patients, 2 would be randomized to encaleret, 1 to standard of care for a period of 24 weeks in total, after which patients have the option of joining a long-term extension where they can continue to receive study drug. And if patients on the standard of care supplement arm have the option of also joining the long-term extension and transitioning over to the study drug encaleret. And what are we looking at? It's really the proportion of individuals who have a blood calcium within the target range and normal 24-hour urine calcium levels. So this is a global study. We do have clinical study sites around the world, predominantly in the US. We also have sites in the UK, Europe, Australia, Japan, and Canada. And we anticipate being able to share results from this study with you in 2025, so next year. So with that being said, I could really stand up here and talk about ADH1 for many hours. However, the real teacher of what living with a rare condition is the actual patient themselves. So here we have a video of Jessica. If you could cue up the video, please. We have a short video of Jessica who's actually talks about living with this genetic condition and how it feels to live with ADH1.
Is that so good? Yeah. You want your water? Sure.
Yeah.
No, don't throw it.
You trying to share?
Thank you.
Hey, buddy. Cheers.
I actually was diagnosed minutes after I was born. I was already showing low calcium symptoms. I'm not sure if I was in tetany or my blood work was flagged because they already had like the neonatal doctor team involved because I was born a month early. So they were doing more of the panels and things like that, checking, and they saw that my calcium was dangerously low. They called the endo team immediately over. She pretty much diagnosed me without even like seeing me because she saw like the parathyroid hormone level and then the calcium, which were both non-existent. Pretty much my mom was getting stitched up and she was being told that, yeah, your daughter has this condition. She's gonna be in the NICU probably for 6 weeks because there was so much not known about ADH1 in babies. And at that time, they thought it was just hypopara. So they're like, this is all that we know right now. I did not have a drop. I was born with a drop. So my calcium levels were so low that my body was pretty much in shock. And I was in tetany, which is where all the muscles in my body like lock up, where my hands and feet turn in, my bones become stiff. It's pretty much like all over my body Charlie horses. So a little baby couldn't even move like her arms, like I was just stiff. Up until that point, my mom had a very healthy pregnancy. I was almost 10 pounds when I was born a month early, so I was healthy. My lungs were fully developed, everything was good. They really weren't expecting anything to do with that. She knew what to do, and she said, I'm not leaving my daughter's side. Like, I'm down there with her. I don't care if I have to sleep on the floor. And I'm pretty sure she did at some point. She did not leave the NICU. So I know once I was home, I had to go back to All Children's every day for probably the first year of my life and get labs done for calcium. So my mom was constantly having to make the trek, which is why she eventually just became a stay-at-home mom because jobs were not understanding that she was having to take off. So I was constantly getting labs done, and then I was on the World Caltrol orally, which is just to help increase my calcium. And I was on that at pretty large doses as a baby, and that worked out really well up until about like 2 or 3. And then that's when I passed my first kidney stone, And then that's when my endocrinologist ordered a scan and saw that the sensor also on my kidneys, as well as the sensor on my parathyroid, is gone, which is what prompted the ADH1 testing. Because she didn't even think to check the kidneys, because all my levels, like through blood work, the kidneys were doing fine. So it was just overloading my kidneys to the point where they were just creating stones. And I remember my mom telling me that during an ultrasound, the first one, it lit up like a Christmas tree from the crystals. And I remember her looking panicked, and she looked at me and she's like, "Look, it's just diamonds. You're just bejeweled. It's okay. God made you sparkly." That's really what prompted kind of more intensive care for the ADH1 is after that, because my doctor realized it's not just the normal hypopara. It's not just the blood calcium that we gotta be worried about now. I would refuse to eat to the point where I would have to have like those boost shakes because I couldn't handle anything. With any sickness, I'd be out of school for 2-3 weeks, possibly go into the hospital with a high fever. It would be like a roller coaster. Because sometimes they would drop, and then sometimes they would go too high. Which, I mean, technically if they're low, but then if they're too high, I would pretty much go into a horrible migraine episode where I couldn't even open my eyes because the pain in my head would be so bad. The kidney doctor, she pretty much told my mom that there's nothing we can do. She's not eligible for a transplant. You might as well just prepare to say goodbye because there's nothing that we can do. Which, if you know my mom, she does not take no lightly. She became crazy mom, and that is how I pretty much got into the NIH protocol at age 6. Because she's like, "I'm not giving up on my daughter. There's no way that this is it." She was willing to do everything, anything and everything, to make sure that I was getting the proper care. Thankfully, the NIH called, and within like 2 weeks after getting the call, I was flown up to Maryland, and I had to stay there for about 3 weeks inpatient at the hospital. And I remember I thought I was really cool flying into Maryland every 2 weeks, like they knew us. And the NIH, is just an amazing place, and the history and all the innovations that are happening. And plus the endocrinologist that was doing the study at NIH, I mean, she was phenomenal, and I honestly owe her so much of just my well-being, because if it wasn't for her, I don't even know where I would be now. So thinking about there being a specific treatment for ADH1, I think gives me so much hope. It finally feels like there is like a light at the end of the tunnel. I think it would allow all of us to have normalcy and to actually put the puzzle pieces back that we've been missing with treatment. So I think that gives me hope.
I hope you enjoyed that story of Jessica sharing her perspective of living with a rare disease called ADH1. I had the opportunity to meet Jessica and her very sweet family in Erie, Pennsylvania this past August. And Jessica, I know you're watching at home, so thank you so much for sharing your story of living with ADH1. My name is Deb Howes, and I am the Director of Global Patient Advocacy at CalCylytics, a BridgeBio company, and I have the opportunity to hear many patient stories of living with a rare disease. And one story I want to share quickly with you is I too am living with a rare disease. About 20 years ago, I was first diagnosed with thyroid cancer, papillary carcinoma, and then shortly thereafter, I was diagnosed with a rare disease called neuroendocrine cancer. And so I did what any person does. What you're not supposed to do, I went online and started to Google everything. And then I did the smart thing. I found a patient advocacy group. And I went to a conference 20 years ago. And I remember when I first went to the conference, I walked in, and actually I say conference, but it was more of a well-organized patient gathering. It was not like this. But one of the conference organizers, one of the patient advocacy leaders, she came up to me, and we did our introductions, and you tell your story. And then she said something that has stuck with me for over the last 20 years. And she said, "You are not alone." And that gave me so much comfort, because at the time I was very scared. I was going in for my first of 2 liver resection surgeries, and I wanted to find out more information. And going to that well-organized gathering, that helped. And I have a feeling that's what James Sanders and Bob were thinking when they organized HPA, and what Patty and Michelle have done so wonderfully now is they have created a community where you can come, you can share your story, you can learn, and you can learn about new programs. And so thank you for giving me the opportunity to share a new program with all of you. So one of the things Arun had talked about was ADH1, and an ADH1 diagnosis is confirmed through a genetic testing. And if you don't know if you have ADH1, you can request a referral for a genetic test from your doctor. And the next step, talking to your doctor before genetic testing, can help you understand what tests mean for your health and your family. So getting an ADH1 diagnosis comes through genetic testing. It involves looking at possibly your blood, saliva, or other tissues to find changes in an individual's genes. And these genetic changes may cause an increased chance of certain medical conditions. So to diagnose ADH1, you do need to have a genetic test. And Arun talked about the provider or the doctor-initiated genetic testing program. I'm going to talk to you about the patient-initiated genetic testing program and counseling. We also provide counseling, and this is a no-cost program for people living in the United States. And so the first step, this is going to be a quick overview of this, but the first step is having that initial consult, and you talk with a genetic counselor by phone to review eligibility criteria. So one of the things I will show at the end of my presentation is how the patients will contact the genetic testing company. And for this specific no-cost genetic testing program, this is the eligibility criteria. You need to live in the United States. You need to be 18 years or older, or if your parents and your children are younger than 18 years of age, and then have any one of the following: a diagnosis of non-surgical hypoparathyroidism, hypocalcemia suspected to be of genetic cause, or a relative diagnosed with a genetic hypoparathyroidism. And then the second step, once you find out if you meet the criteria, then you're going to talk with a genetic counselor, and they're going to figure out, and with you, if you will do the blood draw or the saliva. If it's the blood draw, you can go to a lab and get that done, or with the saliva, they can also mail you the kit to your home. And the best part is they'll use prepaid packaging, so you can mail it back then, once the sampling is taken care of. And then a couple weeks later, this usually takes 2 to 4 weeks, then that gives enough time for them to do the analyzing of the sample, and then they're going to pull together a summary report of this. And they will then send it to you, so you will have time to look at it. And then they will also schedule an appointment with a genetic counselor. And this is the last step. So once you have that appointment with the genetic counselor, they will go over the summary with you. And please remember, sometimes these summaries are very detailed, and so you're going to need to think those questions. I know when I see these reports, they can be overwhelming. So really, really take time to look at this and then ask those questions with that genetic counselor. And they will use plain language. And if you have to call back a second time, they will. And they can also send that summary to your provider if you choose to do so. So that was a quick overview of the patient-initiated no-cost genetic testing program. There's a couple ways in which you can find the program. There is, on the third bullet down, there's a website, and on that website, there's a lot of different information on there. We have videos, we have a Q&A section, and all the contact information is there. On BridgeBio's page on HPA's website. They also have the Arun's program that he mentioned, the provider-initiated program, and then the no-cost patient-initiated program as well. You can contact me. My email address is there, or you can contact medinfo@bridgebio.com. So that was a quick summary of that. I also have handouts with me, and thank you so much for letting us talk today. I look forward to meeting all of you. We have a booth out there, and you're more than welcome to stop by and grab some literature. So thank you.
All right, let's give it up for Deb and Arun. All right, we have a few minutes for questions for either one of these guys. Anybody have any questions in the room first? Then we'll move on to online. I know we have some online, right?
Yeah.
Okay, let's go with Michelle.
Does the genetic testing you offer cover more than what has typically been done in the past? Is it worth repeating a genetic test if you've already had one done?
Yeah, so it may be worth repeating if the panel that the person first was initially tested on was some other panel of genes outside of the 26 that have been described in literature to cause hypoparathyroidism, so perhaps it might be worth getting another test. And also, over time, these variants that are classified or detected, might be potentially additional literature or evidence behind moving these variants along the spectrum. So variants could be identified in a couple of ways. Variants could be identified as benign or likely benign, variant of uncertain significance, likely pathogenic or pathogenic. So that's pretty much the entire scale of what a variant could be defined as. And that definition could move based off of the clinical information and evidence that perhaps could be published or even found in the clinical setting. So if this individual was tested before and it was a different panel, perhaps it might be beneficial to get retested, but I would definitely consult their healthcare provider.
Do you have a recommendation, like, is there a certain amount of time? Like, obviously, if you just had one done within the last year, might not be worth retesting, but is there a time, like 5 years, if you had it 5 years ago, 10 years ago, would you recommend, just because science has changed, that they get it redone?
Yeah, I wouldn't necessarily put a time limit on it per se, but I would note that medicine and research is continuously evolving, and Dr. Manstead can especially attest to this. There are new genes that are being discovered that can cause hypoparathyroidism, so perhaps I would certainly keep my eyes and ears out to go see if there's any new novel genes that have been identified, and then perhaps at that point consider getting retested.
And the next online question we have is, why, as an ADH1 patient, should I choose encaleret over possibly one of the PTH therapies coming out?
Yeah, that is a good question, and really I can't really answer that in terms of why you should choose encaleret, other than the mechanism of action that we kind of went through, the mechanism of disease of ADH1, and kind of what we're thinking about where encaleret kind of fits the picture of targeting those receptors that are overly sensitive. So we'd really have to wait till next year when we have data to show, so where we can help kind of further answer that question.
All right, very good. And Bob, Dr. Manstead?
Yeah, thank you very much. Arun, we share the excitement about encaleret, and we are involved in this clinical trial, which is really an amazing personalized medicine for this rare genetic disease. My question for you is, in addition to this potential new treatment for ADH1, can you tell us a little more about what research is being done that might actually be relevant for other, like post-surgical hypoparathyroidism?
Yes, so tomorrow Dr. Hartley will be talking exactly about that. She is conducting a small proof of principle study at the NIH in post-surgical patients. And I promised NIH that I would not overlap with any of their topics. So Dr. Hartley tomorrow will be covering that, as well as the initial data that she has gotten from that program.
I have another online question
Yes.
that asks, is there ever any reason why a post-surgical patient should consider genetic testing?
Yeah, that is a good question. And, perhaps, post-surgical patient really depends on the origin of hypoparathyroidism and why they're post-surgical. There is a chance that they could have had a genetic condition and then had some sort of surgery on the neck after the fact. So there is a small likelihood, but I would definitely consult with the healthcare provider before.
Okay, Bob?
Yeah, I have a question. Just curious, when you say clinical trial, what's the difference between a clinical trial versus an FDA phase 1, 2, and 3 trials for approval of a drug? Is there a difference between the two?
Sorry, so your question is what is the difference between a
Yeah,
clinical-
when you're saying clinical
yeah,
trial,
sure.
okay?
Sure.
And we have a clinical trial. What is the difference between just a clinical trial versus the FDA's phase 1, 2, and 3 trials where you get approval for a medication?
Yes.
What's the difference?
So there are different phases towards clinical development. So initially, a molecule would need to be tested in, perhaps animals or in a healthy population to go see exactly what the pharmacodynamics, pharmacokinetics are of the medication, if there's any adverse events that are flagged. That's typically early clinical development. If that's proven to be safe, they typically advance that molecule to a phase 2 studies where they initially study the study medication in the population of patients who have that condition, and they kind of go see what the data looks like. And if that looks positive, then they advance to what they refer to as a phase 3, or almost like a pivotal or registrational study. That is typically a study where it's compared. There's another comparator to compare the study drug to. And if the data looks good, then the FDA has the potential to give you an approved therapy or an indication for that disease state that you're studying the medication in. So it's.
This is phase 3?
Yes, that's right.
And actually, Patty and Michelle on their website, they have a great video of just understanding clinical trials and the different phases that you have when you're developing a drug that you have to go through. And so check out their website. They have a really good video on there.
Okay, we have one more question in the back.
Hi, and maybe you don't know the answer, maybe one of the doctors has to answer this, but I'm just wondering, how can someone who has hypoparathyroidism from birth, maybe they function better than I do, and I'm on a parathyroid replacement at this point, so I do better with that, but without that, I could never follow a kid around. The kid would stick its finger in the electrical out and be electrocuted, and I'd go to jail, but how come she's so much healthier and has so much energy and stuff?
So that's a good question. So these patients with genetic hypoparathyroidism, it's not like they had normal PTH up until a certain point. They had a surgery, so they know how it felt to have normal PTH before the surgery. They're really born with it. And if you're incurring symptoms, you really don't have a normal to compare your life to. So perhaps that might help answer your question. And through our sponsored genetic testing program, we've had a sample or a Nova patient who's at least 81 years old who received a genetic test and actually came back with having a variant. So for over 8 decades, they were living life until they were able to receive that confirmatory genetic diagnosis.
All right, thank you so much. Sorry. Oh, yeah. We can have, so thank you so much. Great presentation. We're happy. All right. So now we are going to take a 15-minute break till 10:45. So for you online, join us back at 10:45. Everybody in the room, if you could get back just a few minutes before that, that would be great. Thank you. Welcome back, everybody. I hope you had a really great break. How many of you ran up there and grabbed your little blankies? All right, last year, it's hard in the meeting rooms because, you know, you have to keep it cooler because so many people. Is everybody with me? It's hard in these meeting rooms because you have to keep it cool, so we ordered the blankets this year, so if you got too cold, you could bundle yourself up. So, all right. Okay, everybody, can we have a little quiet in the room? Shh. Okay, so here we go. We are off to our next presenter. As we know, earlier this year, Amulet was sold to Alexion AstraZeneca. And we're going to have them present today, and they are they originated the Calypso trial. So that trial still is in its blinded phase, so we won't be able to answer any questions around the Calypso trial to follow the rules and regulations of everything. But we wanted to talk to you a little bit about, you know, the transition from Amulet to a new organization. So we're really excited to have a new presenter here. Ms. Wendy Erler is the Vice President of Patient Experience, Patient Advocacy, and Patient Insights at Alexion AstraZeneca Rare Disease. So please welcome to the stage Ms. Wendy. Thank you.
Good morning, everyone, and thank you to everyone that's joining online. As you heard, my name is Wendy. It's a complete privilege and honor to be here. I really want to start with thanking the amazing people I got to spend time with last night, and to each of you who shared your story and what your hopes and dreams are for living with this condition. I really want you to hear how much that means to us. For those of us that are here that aren't living with Hypopara or are not a caregiver, being able to understand and listen to what actually matters is going to change the way this condition is treated. So thank you, thank you, thank you. I really want to thank, obviously, the association for creating such an important venue. When we talk about the definition of community, and I'm going to read it, it's a group of people living with a particular characteristic in common, a feeling of fellowship, and an immediate connection to others. And I think we can all agree that happens in this room and with the community online, and it's thanks to Patty and Michelle for creating such an environment. When I look at this, I don't know what it means to each and every one of you, but this is hope. There are a lot of rare diseases where they don't have a tent card like this that shows the number of companies and researchers and physicians committed to a condition. So this is pretty exciting. We're really excited to meet you. I lead the patient experience team at Alexion, and you'll hear a little bit about who we are, how we work, and our why, and that's the purpose of this time today. I know most of you know Amulet and Blandine and Nicole who are here. We are so thrilled that they've come into the Alexion fold. Our goal is to really assure you that we're not looking to make changes in how this program moves forward and how we serve this community. We're here to amplify and accelerate the opportunity, and we look to each and every one of you to make sure we're doing the right job. This is who we are at Alexion. So we're inspired every day. And when I talk about this, it doesn't mean we're just saying it and we're standing on the stage. You look at the people on the right-hand side of this slide, and Kendall, who's living with a condition called neurofibromatosis type 1. This is Kendall swimming in her backyard pool. Her mom is a fierce advocate for NF1. NF1 is a really challenging condition to grow up with. A lot of the patients have tumors that show up on their skin, and they're called cutaneous fibromas, and they can have 100 removed at a time. And so it's a really challenging condition. Kim in the middle is living with a condition called NMOSD. NMOSD is a rare neurological condition. I had a patient tell me once that she was visiting her grandmother in an apartment building in New York City, and they were on the 34th floor, and they walked out of their apartment and pushed the elevator button, and when she got to the lobby, she'd had her first attack from NMOSD. She didn't know what she had at the time, but she was paralyzed and couldn't see. So in that elevator ride, that was how fast it came on. Alyssa on the left is living with a condition called AHUS, and Alyssa's started connecting with Alexion, and we got to know her as a young girl. Her dad started a patient advocacy group, and today she's very involved in advocating for the community. For over 3 decades, more than 30 years, Alexion has been focused on rare disease. We really think about patients and their caregivers. We say that they're center of everything we do, and how do we demonstrate that is what I want to share with you today. But we're really inspired to think differently about science, about the research process, and all of this is focused on better outcomes for families. Our mission is driven by a real sincere understanding that each and every person with a rare disease is unique and their experience is unique. So by the numbers, I mentioned for over 30 years we've been focused on rare disease. Why does that matter, or why should you care? Rare diseases in the ecosystem of being diagnosed and then research processes is very different than more common, bigger population conditions. So having expertise and focus in rare is actually really important and advantageous. When you think about starting a rare disease clinical trial, patients are few, experts are few. You have to think from a global perspective. There are very few centers of excellence. We have expertise in mobilizing those resources. We also have expertise in bringing natural history and real-world evidence to the table from a rare disease perspective. We have a bold ambition to serve patients in 100 countries by the end of 2030. How can we do that? Not to confuse things, but to add another name. Alexion was acquired by a big company called AstraZeneca about 3 years ago. With the backing of AstraZeneca and being part of this bigger organization, we are able to think about global from a whole new perspective and being in over 100 countries by 2030. Right now, we are helping patients in about 70 countries. We have about 5,000 employees around the globe focused on rare. Maybe, Blandine, we can say 5,040 since we brought Amulet into the fold. We have 6 approved medicines for 7 different rare diseases. And those rare diseases run the gamut from neurology to rare bone to hematology and nephrology. So I want to talk a little bit about how we work and really hope that what you can see from us is a demonstration that we are truly invested in building trusted, long-term, transparent relationships with the communities within which we work. We believe creating a partnership with patients, and when I say patients, we mean patients and caregivers, must be demonstrated by how we engage. So we started a project about 6 years ago to define patient centricity. It's a big buzzword, I'm sure you've heard it, but we wanted everyone within our organization to be aligned to what that means. And it's rooted in partnering to deeply understand the experiences that we hear from patients, and most importantly, incorporating those insights into decision-making at every stage, from drug discovery, so the very early phases, through commercialization or late-stage drug development. We think about this from a perspective of 4 key principles. We want to be curious. We have to be willing to ask, learn, and plan with all of you at the center of what we do. And deliberative, meaningfully engaged. This isn't just about reading about a story or seeing a video. That's all important, but how do we meaningfully also engage and set the stage to listen and learn? We co-create, so we have a lot of different ways we involve patients and caregivers from all through drug development to develop innovative strategies and solutions all along what we call the journey, which is that pre-diagnosis experience all the way through. And then we want to generate valuable impact for patients and all of our stakeholders, including being able to show measurable metrics so that we are accountable for doing this in the right way. So I've said patients are at the center of what we do. Why? It sounds so obvious. I don't think anybody is going to stand up and say patient centricity doesn't matter. But why is instilling commitment-driven behaviors and actions really important and the foundation for building trust? We want to set the standard for patient centricity. We want everybody working on behalf of hypoparathyroidism to be working for the same goals, enhancing that this is a journey, and within pharma, we have to shift our mindset. Listening to patients and acting on the insights is critical, and establishing the cultural norm of how we work within our organization really comes from being championed at the top. So who are we, and how do we work together? We listen first. And I'll talk about a few of the frameworks we've built to show this. We work to understand patient needs to improve patient centricity in clinical trials. This includes bringing in patient input to protocol design all the way through to understanding the burden of participating in a study. To any of you that is in a clinical trial and your family members, thank you. It is so important for you to be recognized as driving scientific advancement no matter the outcome. Your time, your commitment, your attention to detail in the study is what's going to drive change for everyone that comes behind you diagnosed with this condition. We deploy tools for insight and rapid response to meet stakeholder needs. Some of that's diagnostics, some of that is better testing, some of that is better disease understanding. So different ways that happens. We're really committed to increasing partnership with patient advocacy organizations and community so that we understand what you need. This isn't about us pushing what we think is important out. It's really about bringing your voice in and recognizing that patient advocacy organizations operate independently and represent each and every patient. So we want to respect that and work together. So to enable patient centricity, and this is an area that I'm really, really proud of when thinking about who is Alexion, we work for a company. We have responsibility for physicians and reimbursers or payers, regulatory groups, investors. We work for a business. So how do you enable patient centricity to make it real? One of the things we did is develop and implement a set of frameworks and tools to coordinate engagement so that when we bring insights in, they can be turned into data internally to be used appropriately. So for example, we built 2 dedicated patient advocacy areas of expertise. One is called STAR and one is called LEAP. STAR stands for Solutions to Accelerate Results for Patients. STAR sounded weird, so we just call it STAR. This helps us to map out what we hear from you as the patient journey or lived experience and identify those moments that matter are most critical. And I can tell you in my first meeting with Patty and Michelle, I took notes and I wrote in big bold letters, not just about calcium. And so it's really those insights that you may not hear in a scientific piece of literature, but you hear from the patient community. How do we meld the two? LEAP is something we're super proud of. I'll talk about that in a minute. All of this helps inform our drug development decision-making. We developed a program called Patient Friction Coefficient, which is about understanding the burden of participating in a trial. And on the right, and this is a little insider baseball, but I wanted to show you, we built PICO, and this is called our Patient Engagement Center of Excellence. So as any of you work with us or get to know us, our goal with PICO was really to set for our organization a way for us to ensure that anybody that engages with us at an individual level or as a patient group has what we call an exquisite experience. So we really want to make sure we're meeting your needs. If you work with us on a project for which you're contracted, we're not sending you a 40-page legal document. We're sending you a 2-page agreement that meets your needs, has clear communication, and represents what you need to know about this engagement. So that's insider baseball. That sounds like it doesn't matter, but it's all part of the way we work and how we want to make sure your experience with Alexion is. So LEAP, this is really a fun program. It stands for Learn, Evolve, Activate, Deliver for Patients. It's a behavioral simulation that all of our employees go through, starting with onboarding, new hire orientation. So within the first couple days of being an employee at our company,
People are immersed in this learning experience that is visual and sensory and puts people in the middle of a patient experience. And we have several different LEAP programs, either focused on a specific disease or other areas, for example, choosing whether or not to be in a clinical trial. We do this, and if you can imagine, particularly having gone mostly virtual with these, there are things like ambulance sirens in the background, people wearing white coats, visual demonstration of what that experience likes. It takes people out of their day-to-day job and puts them in a setting of, oh wait, this is what it feels like. This is what it means. This is how I need to think about it. So all of these different functions within our company work together to ultimately deliver meaningful medicines and outcomes. But somebody working in finance every day doesn't get to come to a meeting like this. So how do we put them in that space to understand from that perspective what it feels like? We then take all of the observations that people share with us from these patient journeys and distill these insights into opportunities for impact. We have also done LEAP sessions with several of our external partners that help us deliver medicines. So think suppliers, think people that do manufacturing, because we really think it's an important way for people to share in that lived experience. Our mission is to transform the lives of people affected by rare diseases through the development and delivery of innovative medicines as well as supportive technologies. Maureen in this picture has a rare, very rare liver disease called LAL-D. She and her sister have both been diagnosed with LAL-D. They had the opportunity to participate in a clinical trial and are now young adults. Maureen's a nurse, partly because of her healthcare experience, right? She really spent a lot of time in the hospital, and that drove her to be a nurse. Her mom advocates just viciously for both of these girls. Her younger sister's in college and is navigating, how do I get infusions where I'm going to college? The learning doesn't end, so we really do spend a lot of time to understand all of these life experiences. I wanted to talk quickly about one of the terms you might have seen on the slide called patient friction coefficient. And with that program, we actually bring people in to look at what we're asking in a clinical trial, what questions need to be answered, how many visits are there, and kind of assess what we're expecting of people. I talked to someone last night who mentioned having a trial, her trial work was coordinated in one part of the country, but she had to be with her mom in the middle of the country, and how do you navigate that going back and forth? We try to answer those questions before we put a final protocol in. And if you think about it, we often enroll studies with people, let's say ages 18 to 65. Arguably, a 64-year-old is going to have a different experience than a 19-year-old, no matter the condition. So how do we think about all of those different people that are going to be in these studies and meet the needs of most on the front end? The other thing we do is really work with our clinical sites and the clinical research coordinators to look at this from the same perspective. And any question that comes in from a potential participant in on a study needs to be answered and asked and brought back to us so that together we can come up with a solution and not just make assumptions. So we're trying to drive change from that way as well. What I hope you hear is that Amulet and Alexion are one team. We're not making any changes to the work that Amulet was doing. We actually see this as an opportunity to even come in and do more by combining the companies and working together. We have an opportunity to really think from a global perspective how more patients can be helped in the future, how we can learn more about this very challenging condition, and how we can get to know each and every one of you. So thank you.
All right, thank you, Wendy. Who has questions for Wendy? Anything from Amulet, Alexion, anything she presented? All right, Michelle, I think you have a few.
The only one I have on here, whoops, of course, my thing shut off on me just as I was about to speak. Is there anything about the transition that affects the drug development process?
No, actually, Amlet did such a fantastic job of creating the early clinical trial development pathway, and so that is all ongoing and expected to move at the same pace and with the same timelines as planned from the beginning. And we do have a table. If anyone has specific questions, please come talk to us.
Absolutely. And you know, actually, Michelle and I got to go to the Gaithersburg office last week, and we met with Martha, who was amazing, and guided us through, took us into a lab. The only lab I've ever seen is how to mix somebody's hair color and put this beautiful color on them. And
that might be a more important lab for some of us.
And Michelle was like all geeking out about all the lab stuff. So I was like, wow, this is really cool. But it was so nice because I believe like they had a little bit of people from each department come in and introduce themselves to us. And one guy in particular stuck out. He was from the IT department. And he told the group there, and some of them were like, wow. But what he does, he's the IT guy. He fixes their computers that happen. And he said, you know, we start our monthly meetings off with watching a patient's story. So we get ourselves in the right frame of why we're doing what we're doing. Even though we're fixing somebody's computer, we know at the end of the day, it's for the patients. So it was like, man, alive. The culture that we experienced there for that day last week was pretty exciting. So while it was a little scary when we heard the news and people were like, oh my gosh, I'm in a trial, I'm doing, how is this all gonna happen? And when, you know, it's kind of all flowing. It is flowing behind the scenes. And I have to tell you, probably for the last 3 or 4 years, we've had this amazing support right over there. Blandine has been just wonderful working with us with Amlet. They've included us the whole way through, you know, their journey to get to the clinical trials. So we really appreciate that, and we look forward to
She's not going anywhere.
But no, she's hanging around. Continued that partnership. So any other questions for?
Coming online. They're asking, can you speak at all to how does approval look different for rare diseases versus non-rare diseases?
So there are a lot of unique approval pathways, and I think very simply what I've seen in rare disease is the opportunity to meaningfully incorporate patient experience into the package that goes to regulators for approval is very unique. And the work that the Hypopara Association has done with the patient-focused drug development is massively important because that's what educates regulators about what's really important for this condition. So that, to me, is one of the biggest differences with rare. When you have a big population disease, you can look at numbers and you can assume how it impacts most. When you have a rare disease, that's just not the case. So the experience data is critical.
Good. Yeah. Oh, we got a question in the back.
When you were listing the age band, you went up to age 65. Most of us who are women who were surgically induced, it was in our 40s. But what if somebody's over 65? Are they too old for a trial?
No, and I was just using that as an example. We actually, this is a timely question. We have a clinical trial going on right now where the upper age limit is 90. And I talked to a gentleman this weekend and he said, how did you pick that? And I'm 95 and I want to marry my high school girlfriend. And I'm like, very good question. So what I'm going to do is go back and talk to the team about in a situation like that where there is such a upper age limit, why did we even have one at all? And I don't have an answer, but that's an example of how we continue to take in insights and go back. This gentleman literally is reconnected with his girlfriend from 70 years ago. So it's such an incredible story. So no, there are many, many examples of trials that have a wider berth on both sides. Exactly.
Michelle?
Does Alexion offer any resources for patients who are trying to make a decision about joining a clinical trial?
We do, and if there are people in particular, so where we can have those conversations is more specifically related to our trials. We aren't able to speak to that comparative type decision making, but that's where your website and all the information you have is so much more helpful. But anyone's able to contact us at patientadvocacy@alexion.com, and we will do our best to get them to the right people.
Okay, thank you. right, so we're going to move on to our next presenter. And Dr. Schoback really wanted to be here in person. She was unable to be here today in person, so we're going to move on, and she's going to be online. So let's bring her up. We'll say hi to her and let her get started. Hi, Dr. Schoback.
Hi, good morning.
All right, we're
you.
so happy to see you. Thank you for joining us. Dr. Schoback has been a longtime supporter of the Hypopara community and patients. She always steps up and says, yeah, I'll be there, I'll help. She comes to us from UCSF, so we welcome you, Dr. Schoback. Go ahead.
Thank you, Patty, and thanks again for the opportunity to present today. It's a real pleasure. It's always a joy to be together with the association and all of our patients. And so I know I'm missing a great deal, but I do appreciate the chance to present. So I see my slides there. And so I'm going to tell you that I'm going to speak about a topic that Patty suggested. And so I'll be giving Patty credit in certain places in this slide set. And so we're going to talk about hypoparathyroidism and some of the important comorbidities that one needs to think about with this situation. So let's go ahead with the next slide. So what is a comorbidity? Why are we even having this lecture this morning? So I'd like to talk to you about how understanding some of the comorbidities that we face can help you with managing your hypoparathyroidism. And what are some of them that you may or may not be aware of? So we'll review a few. And this, I think, is one way to sort of influence the way you take care of yourself on a day-to-day basis. So next slide. So when Patty suggested this lecture, she said, I really want you to discuss vitamin D. I want you to talk about what magnesium and potassium are. And I think she gave me the idea that we really want to think about comorbidities because they help us to understand some of the symptoms we're facing, with any condition, really. And she pointed out that some of the symptoms that people face on a day-to-day basis may get confused with hypoparathyroidism, and they may not be due to it, and maybe other tests need to get done. So the point here is to stay informed about your health and not always blame everything on hypoparathyroidism. And I call this advice from Patty. So let's see the next slide. So what is a comorbidity anyway? What am I talking about? So WebMD and other online resources say it's the existence of one or more diseases or conditions within your body at the same time. So it's happening along with your hypoparathyroidism. And I think it's really important because if you understand the comorbidity that people are facing, you can better understand what they're going through in terms of physical and mental health. So you might ask right at the beginning, how is a comorbidity different from a complication? They're definitely not the same. A complication is something that occurs during a disease that's really part of it or a side effect from the treatment of it. And I gave a couple of examples here. So if you pass a kidney stone because of a high urinary calcium in hypoparathyroidism, that's a complication of the disease and the treatment. So that's a complication, not a comorbidity, although it's an important, kidney disease is an important comorbidity, and we'll see that in a moment. If you have low blood pressure and you feel dizziness, those may be complications of treating the high urinary calcium in hypoparathyroidism with a diuretic, for example. So those are complications. Let's look at the next slide. A comorbidity is really something separate. It's another disease that's happening alongside the hypopara. So here are a couple of examples. I thought this would give you sort of a better feel for what I'm trying to talk about this morning. So I had a patient with hypoparathyroidism who complained several times to me about pain and swelling and stiffness in the small joints of her hands. And you know that sometimes tetany really can cause a lot of pain and stiffness and so forth and cramping, affecting the hands. But eventually what we did was test her for rheumatoid arthritis. And when we did all of that testing, it turned out that she actually also had rheumatoid arthritis. And that gave us the opportunity to really treat her for that and help her with that. So her rheumatoid arthritis is a comorbidity that affects how she thinks about the hypoparathyroidism and how it gets treated, and it overlaps with the symptomatology. So that's a comorbidity. Another patient developed chest tightness, and he thought this was due to tetany, with his chest muscles cramping up, and took calcium. But it turned out instead that this was angina, and that comes from, the coronary arteries being narrowed and blocked. And so that was a very important diagnosis to make and distinguish. So the angina, if you will, is a comorbidity in the hypoparathyroidism landscape. So let's take the next slide. So who likely gets these comorbidities? Who should be worrying about them? Well, really anyone, but people as we get older, our health changes, it deteriorates a bit. And so really, as we get older, we need to think more and more about other conditions affecting things like hypoparathyroidism or some other chronic condition that we're facing. So I've listed here a lot of the several really common comorbidities in our population that you need to think about as you're moving forward in your journey with controlling your hypoparathyroidism. Kidney disease, high blood pressure, heart disease, arthritis, like I just told you about my patient, mental health, challenges, diabetes, cancer. All of these things can be very important, and they're common comorbidities in our health journey. Next slide, please. So how can they affect you? So I've put these different bullets together from what I think are important considerations for us. So when I'm taking care of a patient with hypoparathyroidism, I always think to myself, this is hypopara plus blank. What else? What else do I need to take into account when I'm giving medications or giving supplements? And then I also think about the symptomatology. The symptomatology could be from either of the conditions, okay? And sometimes it's very hard to separate. I want to acknowledge that, and we always talk about that in our appointments. And, one condition can influence the way the other behaves and the way the other responds to treatment. So we really need to keep them both in our minds at the same time. And no question, and you all can attest to this, a comorbidity can affect your day-to-day life and make what you have to do for treatment of your health in general much more complex. And then, of course, drug interactions, and I'll talk a bit more about drug interactions in a minute, because some of the drugs that you take for those other conditions or for hypopara can be affected. They each can interact with each other. So that's important, the drug interactions and side effects that can sometimes be additive. So we need to keep a lot of different things in mind in this setting of comorbidity. So next slide, please. So I think you know this, and this is going to get talked about a lot in this conference, and we spend a lot of time talking about numbers and lab tests. But we've got a lot of goals in hypoparathyroidism when we treat it. The first is generally always keeping the calcium within an acceptable range. We want to keep it in general in the low normal range. We want to keep the serum magnesium in the normal range as well. We want to get a calcium and a phosphorus product, and I know other lectures will talk more about this, less than 55. We want normal vitamin D, and we want to avoid that high urinary calcium. And so you'll hear some of the speakers talk about that, and they'll say it's hypercalciuria. So just know that technical term may pop up, but that means a high urinary calcium. And why we want to attack that is because we want to protect your kidneys. We want to protect you from kidney stones. We want to protect you from deteriorating kidney function and so forth. So those are the first steps. Let's go to the next slide. Some of the second steps are to keep that phosphorus low if we're going to get that product in a good range. So we want to watch that phosphorus as well. These are some of the goals that you're going to be working on. Because if the phosphorus and calcium product is high, you can get calcium and phosphate deposits in soft tissues. Well, we don't want them. We don't want the heart, the kidneys, the brain, and the eyes, for example, or our blood vessels to get, deposited with calcium salts that really will impair their function and cause complications of the disease. So these are the goals that we have to treat you and to have you stay well. Next slide. So some of the targets that I've mentioned on those two slides are really important. One of them is vitamin D, another is magnesium, and another is potassium, for example, some of what we call the other electrolytes or body chemistries. And those are usually measured in a renal panel, or they're measured in what's called a basic metabolic panel that you often get, every single time you take lab tests. So these are some of the targets that we're sort of automatically looking at. And I'm trying to bring to your attention that you should also be automatically looking at when you see your lab tests. Now, some of these have reasons that may affect how you feel, but others don't. They're just lab tests that may have an effect on downstream complications, but may not change exactly how you feel. And one of those is phosphate. So we're going to watch the phosphate, but it may not change exactly how you feel on a day-to-day basis. Next slide. So let's take a couple of these in turn. So vitamin D, it's really, really important. We know that our skin can make vitamin D. You can get vitamin D from foods that are supplemented with vitamin D. It's in almost every multivitamin that you buy in the pharmacy. And you can read how much is in that particular multivitamin by looking at the label, and it'll be listed as international units or micrograms. That seems to be more common now. So vitamin D is around us. It's pervasive, right? If you're using sunblock, but you're outdoors, sunblock is going to block most of the vitamin D that your skin could make. So remember that just being outside but wearing sunblock isn't going to allow you to make very much vitamin D. Now, in hypoparathyroidism, it's recommended that the 25-hydroxy, that 25-OH vitamin D, that level be measured and kept track of. Okay, so when you look at your lab test printouts, you may see 25-hydroxy vitamin D in those printouts, and that's the very important metabolite that we are tracking and that you should pay attention to. Next slide. So why is it important? Okay, why is vitamin D so important, and why am I talking so much about the 25-hydroxy vitamin D? Well, that is the building block. That's the source from which our bodies make all the different metabolites of vitamin D and all the different cells. I've only listed, 5 or 6 of them here on this list, but you know how important these tissues and these cells are. These tissues make their own source of vitamin D, as well as getting it from the bloodstream, but they make it right there inside the cell, and they make, for example, 125 vitamin D or calcitriol, and you likely all know about calcitriol. So our bodies make it, but they need to have the building block or the substrate in the form of 25-hydroxy vitamin D. Okay, and so we want to keep that tank full of 25-hydroxy and regular vitamin D so that your body can make all of the vitamin D that it wants to make. Next slide, please. So people often ask, how do I know if I have a low vitamin D? What is it going to make me feel? And that's hard for me to be very specific because it's going to vary from person to person, and it's going to vary depending on the level that's present in your body. So what would it do? What could it do, right? So if the level of vitamin D and 25-hydroxy vitamin D is too low, if you're taking PTH, for example, injectable PTH, it may be less effective, okay? It may not be able to work as well to stimulate the bone or the kidney receptors for PTH. Those are the molecules that respond to PTH when it goes into the bloodstream. And I've listed some of them so you recognize what we're talking about. We're talking about really all the forms of PTH that we have. And then if you develop vitamin D deficiency, and there are lots of reasons for that, I consider this a comorbidity of the condition of hypopara. And why is that? Because significant vitamin D deficiency, when those levels get really low and they stay low for a long time, your muscles can feel weak, your bones can ache just from that alone, and your blood calcium level can go low. And you could even, if it goes on for a long time, you could even break a bone. It's pretty rare, but sometimes that can happen because the bones get thinner as vitamin D deficiency progresses. So it's really, really important to watch that vitamin D level. Now, what should those levels be? Well, In medicine, we don't all agree on everything, of course, but we want the vitamin D 25 hydroxy level to be at least 20 nanograms per mil. And many of us prefer it to be 30 or higher. Okay, so the idea is you want to have a full tank of vitamin D in your body for the body's needs. Next slide. So lots of times people say, do I still need to take vitamin D if I'm taking calcitriol? And my view, and not everyone shares the same view, but my view is yes, because of the reasons I've just given you. And the guidelines for the management of hypopara also say yes. So we want to get enough vitamin D3 or vitamin D2, both are okay, to have that adequate level of 25 hydroxy vitamin D. Okay, so those are the two different forms right there, sort of shown in kind of in real pictures. You know, these are the medications that are supplements that you could take here. Next slide, please. So I said I'd talk a little bit about magnesium. Now, magnesium, it's abbreviated, a capital M and a G, okay, to make it different from milligrams, okay, which is a small m and a small g, okay? So magnesium is really like the cousin of calcium. That's a really, I think, good way to think about it. Every cell in your body needs calcium. Every cell in your body needs magnesium. So it's very, very important. You can see the tissues over on your right that magnesium is really important in, the kidney, the bone, the parathyroid, and also over there on the far right, your heart. Okay, so all of the different molecules, the pumps in the cell membranes, the receptors, the ion transporters, the enzymes, almost all of them need magnesium to function properly, or many, many, many important ones need it. Okay, so it's a critical cofactor, particularly, again, muscle, heart, and brain. So very, very important. A lot like calcium, but different in other ways as well. So that's magnesium. Let's see the next slide, please. So we need parathyroid hormone in our bodies to keep the blood level of magnesium in the right balance. So if you have hypopara, not everybody, but many, many people often need to take some extra magnesium to keep that balance in place. If you have any GI problems, diarrhea, bowel surgery, there's something wrong with the gut in terms of its absorption of nutrients, all of those things, magnesium may get malabsorbed. It's not correctly absorbed in the gut from your food if any of these things are present. And so we recommend that magnesium levels in the blood be checked regularly, okay? And make sure that they're normal, along with your calcium, along with your vitamin D, along with your kidney function and so forth. So if you're not getting that done, it's a good thing to ask for, hey, let's check my magnesium level just to make sure it's okay. I never mind when a patient reminds me, we haven't checked it in a year, I need to get it checked this time. And so we're happy to do it. So many, the low calcium symptoms, the tetany, the muscle cramping, the numbness, all of those things, many of those same symptoms can be caused by having a low magnesium level. So this is really important. If you're having a lot of symptoms that look like they're low calcium and your calcium doesn't look very bad, make sure that magnesium level gets checked because it can also cause tetany. Next slide, please. Now, potassium. Don't talk that much about potassium at the Hypopara meetings, but Patty asked me to mention it, and so I am. It's another very important ion, and it's abbreviated as a capital K with a little plus sign next to it. Very, very important. Every cell in our body needs a good level, a solid level of potassium to function. Again, the same molecules, the receptors, the transporters, the ion pumps and so forth. Very important in things like your muscle, your heart, your brain. And really every cell in the nervous system needs a good level of potassium to have neurotransmitter function and make those things called action potentials. So potassium, really, really important. And if you have diarrhea or there's any kind of absorption issues in the intestine, the potassium levels can fall. So potassium is another very vital ion to watch out for. It's often in our regular kidney panels and our basic metabolic panels, so you don't have to specially ask for it, it'll be there. And it's really important that potassium levels be checked if you're taking medications like diuretics, like furosemide or Lasix or chlorthalidone or hydrochlorothiazide diuretics, because they can waste the potassium through the urine and the level can drop. And many times you don't know it because you may not feel anything that you can separate from your hypoparathyroidism symptoms. So again, some of the same symptoms that low calcium and low magnesium can cause, like tetany, low potassium can cause the same things. Or you could feel just general weakness or general fatigue. So people often say, I feel drained when the potassium is low. And if it's let go, it can lead to altered heart function. So very, very important electrolyte or ion to watch on those kidney panel tests when they come back. Next slide, please. So I wanted to mention, before we talk about a couple of specific comorbidities, I wanted to talk about just briefly some of the medications and the classes of medications that are important to know about because they interact with hypoparathyroidism. So I've already mentioned the diuretics. They can increase the loss of calcium through the urine. That's Lasix. The thiazide diuretics can decrease that loss. The diuretics can also lower the potassium level. They can also lower the magnesium level. So very, very important if you're taking any diuretic to make sure that those levels are followed closely. If you're given prednisone and you're taking calcitriol, prednisone can block the ability of calcitriol to work properly. So you can get hypocalcemia, low blood calcium, if you're taking prednisone. And I'll talk a little bit more about the bisphosphonates that we use to treat osteoporosis. If you're taking one of those, and I've listed 4 of them here, that can lead to hypocalcemia. Very commonly, people take medicines in the class of proton pump inhibitors that are listed there, like omeprazole. That can both lower the magnesium and can lower the blood calcium level. And then chemotherapies, and there's many more than what's listed here. But just keep in mind that if you're being given that kind of treatment, you want your oncologist to know that you have hypoparathyroidism, and these levels need to be watched very closely because they can change. Okay, so just keep these drugs in mind. Next slide, please. So I've listed here some of the most common comorbidities that I think of as an internist when I take care of all patients. But these top 4 ones, I've decided that they are important for us to talk about in a little bit more detail this morning. And so we'll start first with thyroid disease. We'll talk a little bit about osteoporosis. We'll talk about pregnancy. It's not a disease, but it can be a condition that we really need to pay close attention to in hypopara, and then chronic kidney disease and kidney stones. Let's take the next slide, please. So thyroid disease, I consider it the #1 comorbidity that generally I am dealing with in people with hypoparathyroidism. You know that you have to be very careful and thoughtful and rigorous about how you take your thyroid hormone replacement if you have hypothyroidism, right? You need to take it on an empty stomach. You need to wait at least 30 minutes, maybe 60 minutes if you can before you eat. And you know that if you're taking a proton pump inhibitor or an antacid or an H2 blocker for reflux, that can interfere with the absorption of many calcium preparations. You know that this is something that really does play a big role in how you manage any other condition because it needs this very careful taking of the thyroid hormone supplements. And then you know if you're dealing with both hypopara and hypothyroidism, that calcium supplements interfere with the absorption of thyroxine. And so calcium may look great on the blood tests, but thyroid hormone levels may not look right because the calcium is interfering with the absorption of thyroid hormone. So very important to sort of keep in mind how these 2 conditions interact and the medications can interact with each other. Next slide. So if you're not taking enough thyroid hormone, the labs will show hypothyroidism, okay? And that will mean that the TSH level will be high, okay? It's generally above the upper limit of normal in people who are hypothyroid. The free T4, which is the measurement of how much thyroid hormone your body has in it, is usually going to be low or low normal. It's not always, frankly, low, but that TSH is our key measurement, okay? And if that's above the normal range, then we know that we've got to make an adjustment in general. So what about the signs and symptoms? How do you know? How do you know that this is important in your body? If you're hypothyroid and the numbers confirm it and the TSH level is high, 20, 30, something quite significant, you may feel muscle weakness, you may feel cramps in your muscles, you may have low energy, you may be sleepy, you may gain weight. All of these things can be caused by the hypothyroidism, so that needs to be addressed. But clearly, some of these symptoms, you're looking at them now and you're saying, that's the same as hypoparathyroidism. How do I distinguish them? It's not easy, okay? But that's why we have blood tests, and that's why we think about, optimizing everything, because we know that the two definitely work together and it's difficult to separate them. So this is a really, hypothyroidism and thyroid hormone replacement is a really important comorbidity that needs great care in people with hypopara. Next slide, please. So I wanted to talk just a little bit about the bone, and many women who are postmenopausal need to pay close attention to this because osteoporosis and osteopenia tend to occur at great rates in women postmenopause. Now, we diagnose osteoporosis. We can diagnose it by having a fragility fracture if you just fall down and don't have a lot of trauma and something breaks. But we also can diagnose osteoporosis or osteopenia by a DEXA scan. And that scan measures bone mineral density. It'll measure it in the spine or the hip, and it compares you to a control population. For women, it'll be young women. For men, it'll be young men. And when you look at the DEXA report, if you've had this test done, you'll see T-scores on there, and you might even see Z-scores. So the T-scores we use for women who are over the age of 50, postmenopausal. And if that T-score is either equal to or below, that means a higher number, below -2.5, that's a definition of osteoporosis. And if it's between -1 and -2.49, it's osteopenia. I know this is a lot of information, and I've got another slide that shows this in a little bit maybe easier way to grasp. But this is an important way that we make the distinction between osteopenia and osteoporosis and grade it. Okay, let's look at the next slide, please. And this is if you have never had a DEXA scan or don't know what I'm referring to, here is the simple way that we measure bone mineral density by this DEXA scan. It's an X-ray based study, and it quantifies bone mineral density. Let's take a look at the next slide. Okay, so you can see the bell-shaped curve in the top part of this slide, and it shows you sort of what do these T-scores that I've just mentioned to you, what do they mean? So the little green arrow going to your left all the way up to the red arrow is where the bone density is when you have osteopenia. So between -1 and -2.5. And then numbers that are lower than or worse than -2.5 are osteoporosis. And so that's just how we have decided as a field to grade bone mineral density and have a common language, if you will, for talking about bone mineral density. We usually talk in T-scores. Okay, and this is what they are. Next slide, please. Well, why is any of this important? So, and again, we're mostly talking about women who are in their late 40s, early 50s, and beyond. It's important because if you're going to use a PTH analog, really any of the analogs, teriparatide, natpara, TransCon PTH, that you'll hear more about, the bone density often goes down in that first year or two when you are taking those medications, when you start them, okay? And that can lead to if you're already low, think about, being in the osteopenia category or the osteoporosis category. If you're already low, that's going to probably go down a little bit. That bone mineral density is going to go down a little bit during the initiation of that kind of therapy. So we don't really have a lot of guidance about how to do this in postmenopausal women. We are mainly using it as a treatment for osteoporosis, but you have to realize that one of the comorbid conditions that we need to pay attention to is what is the bone status of that person, not just women, but women and men, but predominantly women. Okay, so we need to know what the DEXA scan shows, and we need to follow that, okay? And so our goal when we use these medications to improve and treat hypoparathyroidism is to make sure that the bone density is as stable as possible, that you don't make osteopenia become osteoporosis, and that if there's osteoporosis present, that it doesn't progress, if you can possibly help that. So that's why this is a really, I think, important comorbid condition, if you will, using that word again, in thinking about the treatment of hypoparathyroidism. So next slide, please. So that's important, the initiation of therapy for hypoparathyroidism. But the other reason it's important is that many of the medications that we use for osteoporosis, okay, either you make the diagnosis by a DEXA scan or the person has had a fracture, many of these medications can affect calcium metabolism in our body. So it's really important to know, what's going on with the bone. So the bisphosphonates, there are 4 of them. They were in that little table. They can directly affect what's going on with your hypopara if they get started. For example, you can develop hypocalcemia. You can be fine with your hypopara, start one of these medications, and because it affects bone resorption, the breakdown of bone and the delivery of calcium to the bloodstream, you can get hypocalcemia when you're on one of these medications. I've highlighted in the middle of the slide the medicine for osteoporosis called denosumab. That's given by injection. That can also lower the blood calcium and sometimes quite dramatically. So you'd have to be very careful if you were to be receiving that if you have hypoparathyroidism. And then the other medications that we sometimes use, the Evenity, the teriparatide, abaloparatide, some of these other medications can also affect the treatment of hypoparathyroidism. And we don't have a lot of experience to go by. We don't have a lot of published series in the literature and so forth. So knowing your bone status, whether you have osteoporosis, whether you have osteopenia, whether the bone is normal, really important in our treatment of hypoparathyroidism. Next slide. Pregnancy. We are going to go quickly through pregnancy, but this, I just want to remind you, it's a condition, it's not a disease, and that in pregnancy, if we take a look at the middle part of this figure where it shows pregnancy compared to normal bone and mineral metabolism, more calcium is moved through the body, more calcium is taken in, those arrows get darker and bigger, and that calcium goes to the skeleton of the infant to mineralize it, okay? And if you're a mom with hypopara, that's going to have a big effect on your calcium and your vitamin D status. Let's take a look at the next slide, please. These are some of we're not going to go into detail here, but these are some of the changes that occur in calcium and PTH and vitamin D during pregnancy. And I'll point out to you in the upper left, you can see that the blood calcium level goes down in pregnancy because the albumin level changes. So the total calcium may go down, and the ionized calcium you can see in the second panel on your left, it's very stable, it's very normal. But it needs to be carefully watched in hypoparathyroidism because the flexibility of the body is not the same without PTH. And you can see over on your far right, the calcitriol level in normal pregnancy goes way high. So that means that if you're taking calcitriol, we need to know, you need to adjust that calcitriol that you're taking and that calcium that you're taking because of these changes that occur in pregnancy. Next slide. What we're looking at here is just a little cartoon that sort of diagrams all the different tissues that change in the calcium metabolism changes that occur in pregnancy. So we know that the requirements of for calcium in the mom go up because her body has to meet the needs of the growing baby. So we need to monitor the blood levels in pregnant women with hypoparathyroidism at least every 3 to 4 weeks and sometimes every week to make sure that they stay stable. We have to adjust the calcium supplements and we have to adjust the calcitriol to make sure those levels stay stable. Usually aren't allowed to continue PTH analogs because they haven't been tested in pregnancy. And hydrochlorothiazide, if you're taking that, generally is stopped, certainly in the first trimester of pregnancy. So lots of changes often take place. Next slide, please. And then with lactation, let's say everything went very smoothly with lactation, the calcium levels need to be again monitored closely, often weekly, okay? Because the requirements for calcium change because the placenta and the breast during pregnancy both make PTH-related protein, and blood calcium levels can go high even if you have hypoparathyroidism. So you need to watch, those levels need to be watched closely. And then the baby needs to be monitored clinically because with these fluctuations in the mom's calcium and her supplements, that can affect the functionality, if you will, of the baby's parathyroid gland. So the baby needs to be watched. So this is a really important condition. If you're going to become pregnant and you have hypopara, and you really need to be under the care of someone with great experience with this condition so that everything goes successfully. So next slide. The last thing I wanted to talk about was the kidney. Can you just advance that slide so we can just see the picture of the kidney in here? So you can see it right there, sort of almost in the center of this slide. The kidney is really, really important in the maintenance of serum calcium. So anything in the normal parathyroid person or in someone with hypopara. And so we want that kidney to be functioning perfectly. Next slide. Next slide. Okay, so there's lots of things that the kidney does in our bodies. It maintains calcium balance, it maintains phosphorus balance, and it makes 125 vitamin D, or calcitriol, okay? And those things need to still take place in our bodies. But we know that kidney stones can be a complication, right, of hypoparathyroidism. Now, if you have a history of kidney stones and you become hypoparathyroid from a surgical experience and so forth, those stones may definitely get worse. They may get more frequent, okay, depending on how your hypoparathyroidism is treated. Because both the calcium supplements and the calcitriol that you're taking can raise that urinary calcium, and that can worsen the kidney stone situation, okay? And also, you know, dehydration can worsen the kidney stone situation. So knowing, if your doctor knows that you have a history of kidney stones before even the hypoparathyroidism developed, that's a really, really important piece of information to make sure that they know about. Now, if you've never had a kidney stone, you may eventually get one with hypoparathyroidism, again, because of the treatments. What can you do? You want to make sure your fluid intake is as robust as possible. You want to make sure that the foods that you eat are in keeping with a diet that's healthy for kidney stones. You want to avoid oxalate, for example. Very important to see a dietitian or a nutritionist for advice on management. And it's very important to look at different salts in the 24-hour urine collection. I've listed them here. So the idea here is to try to, you know, avoid having more kidney stones because they can cause urinary tract infections, they can require operations, and they can produce damage to the kidneys. So very important piece of history to share with your healthcare provider. Next slide. Chronic kidney disease. Now, let me just demystify, I hope, a few of these things. We have 5 stages of chronic kidney disease, and they're shown here on the right side of the slide, stage 1 through 5, okay? And we often call chronic kidney disease CKD. You may hear us say that, and that's just another abbreviation that you should know about. But chronic kidney disease is very important. And we measure kidney function with a thing that we call eGFR, or estimated glomerular filtration rate. That's a measure of kidney function along with the serum creatinine. Okay, so when you look at your lab test and you see that there, you know that's a look at your kidney function, and you can see the different stages on this slide. When you get down to stage 5 on the bottom, where the estimated GFR is less than 15, that is late, or we often say end stage, and oftentimes people in that stage of chronic kidney disease go on to dialysis. Next slide, please. And these are I have 2 slides in here, and I'm not going to go into details because of time constraints, but I've listed, these are important studies looking at big managed care data sets telling us that people with hypoparathyroidism really need to pay attention to their kidneys because complications can occur. And in this slide, which is looking at changes in glomerular filtration rate or kidney function, you can see that those people with hypopara, and I've identified the curves here, have a greater rate of all of the progression to chronic kidney disease. Let's take the next slide. And this is just to show you that the presence of kidney stones are about 3-fold higher in people with hypopara, and that's what this study showed. And on your right, the development of a kidney stone over 5 years of follow-up in this big cohort of people was about 3 times higher. So definitely the kidney is a very important concern, and the presence of kidney stones and the development of them during the treatment of hypopara is a very real phenomenon. Next slide, please. So what can you do to keep an eye on this on your kidneys? So watch the function, the parameters of function, which are going to be printed out on your lab tests. Make sure your blood pressure is in good control. Take your medications for high blood pressure. Monitor your blood pressure. If you have diabetes, you want to address that. You want to follow your A1C for your diabetes. Make sure that it's as good as it possibly can be. If weight is an issue, you want to work on your weight, okay? And we have medications, we have diet, we have lifestyle. You want to probably ask for a nutrition referral because of all the things we've talked about with regard to kidney stones. That's very, very helpful. Watch the amounts of calcium and calcitriol that you're taking. Take what you're prescribed. And the same with the PTH analogs if you're taking any of them. And you want to get regular lab checks, okay? And remember I said phosphorus is something that we don't feel really much from phosphorus, but watch that level as well. So there's lots of different things we're following here. You want to make sure that you stay well hydrated to help keep your kidneys as happy as possible and help to prevent kidney stones. And if there is something wrong with kidney function, be proactive. Ask to see a nephrologist. That's a kidney specialist, because you may get some insights into things that you weren't even thinking about doing, and it can be super, super helpful. Okay, so next slide. Just to summarize, make sure that your healthcare provider knows about any other conditions, even if they might not be active right now. Let them know about any other conditions or diagnoses that you have, so that he or she can best treat your hypopara. And even if it's in what I call the medical past, let them know, okay? And we've only looked at a couple of conditions that I thought would be the most important to share this morning. And then stay on top of who's prescribing what for you. You might be seeing 3 or 4 different doctors, and it might be left to you to keep a very accurate, up-to-date medical list. So do that and bring that to the appointment so nobody is in the dark about what medications you're taking. And I've suggested that you watch your thyroid and your kidney function very closely. Keep an eye on that potassium level. Keep an eye on the magnesium level. Ask for it if we forgot to order it. Watch your calcium, of course, and your vitamin D, and then the measures of kidney function that we have. And really just, stay in the game here. Keep track of these things, keep an eye on them. And I think this is really the best way for us to make sure that we work together to keep you guys as healthy as possible and happy. Next slide. Thank you. Thanks for the invite, and thanks for your attention.
All right. Thank you, Dr. Shovat. It's wonderful. We're going to do some Q&A now. I know we've had a lot of them come online, and let's start online, and then we're going to go back there with Bob. Go ahead.
Can you take your magnesium and calcium supplements together?
Yes, you can. And many calcium supplements have magnesium compounded right into the pill itself, and there shouldn't be a problem. You do want to make sure that the amount of calcium you're taking at a time isn't excessive, that your body can absorb it, but it's okay to take them together.
Okay, Bob? If you could stand up and just say who you are.
My name is Adrian. My question is from a caregiver perspective for somebody who was post-surgical hypopara, right? One, I hope we can get a copy of those slides because I loved them. But two, for the most part, we will have 15 to 30 minutes to speak to a doctor, maybe once every couple of months. Is there a list, maybe a 1 or 2 pager that we can prepare ourselves with ahead of the visit of questions to answer, certain things to look for on blood tests so that we can arm ourselves? And I'm kind of looking at it to be maybe even like a flow chart type of basis. So what questions would I ask if I'm talking to a nephrologist? What questions would I ask if I'm talking to a kidney doctor? What questions would I ask when I'm talking to my primary care physician? A lot of that gets mixed up. My hat goes off for those who are suffering because it is emotional. My wife has a hard time keeping up with it. I'm trying to be better with being empathetic, but not knowing what questions to answer. So how can caregivers arm themselves without becoming a doctor?
Well, that's I really appreciate every single word that you said there, because yes, and I see people clapping. I do too. And actually, Patty suggested this talk, but as I prepared it, I really thought to myself, in today's world, it is unbelievably important that caregivers and patients, but caregivers and family members and so forth, help out with this, because it is a big job. It's a big job for me as an endocrinologist, taking care of people with hypoparathyroidism, to look at what the cardiologist did to control the blood pressure, 3 days ago or 2 weeks ago. So I share with you the challenge of keeping track of all of this, and we've got to do it together. That's the only way that we're going to succeed. Many times you'll get what's called an after-visit summary from your doctor or your appointment with your healthcare provider. Hold on to those things, read them, bring them to the appointments. Make sure that med list, these sound like simple things, but honestly, we could spend 10 minutes trying to figure out whether they started hydrochlorothiazide or they stopped it sometimes based on what's going on. And so we want to work together on this. And I wish that I had that 1 to 2 pager that you talked about. Maybe Patty will try to develop it, or maybe someone else has it. But I agree with you. I'm recommending each step of the way, make sure the magnesium is in there, make sure the creatinine is in there, make sure you know that the estimated GFR means kidney function. I'm trying to decode these things because I think we all need to participate in the care of not just hypopara, but any other condition that people have, because medical regimens are so complex. It's a wonderful question, and really I think this, asking me to do this lecture, was Patty's effort to try to get us on the page of, working together cooperatively and following these things along with healthcare providers. You don't have to take our job. That's our job, but we want and need your participation.
Absolutely, and I think it's a great challenge. Actually, I was kind of looking at Dr. Kohlmeyer here for leading the medical advisory team next year. Maybe we can come up with something in cooperation with HPA to really go, what is that one sheeter that people could take? We started a little self-advocacy group, and we've barely touched on that piece of how do you go back and talk to your doctor, or how do you maybe send things through the portal ahead of time to prepare or whatever. It's a good challenge. Thank you for asking that great question. And definitely we'll work in combination with our medical advisors to see what we can come up with. Okay, Michelle, got a question?
Yeah, I've got a lot of them coming in here. Is the D3 that is listed on calcium supplements the same as calcitriol?
No. Oh, I need to wait 2 seconds. Jim. No. Jim said 2 seconds must be waited so that there's no blur of speakers. So no, it's not the same. Calcitriol is 125 dihydroxy vitamin D. So you'll see a 1,25 in front of the technical name for it. And the D3 is just what it says. It's vitamin D, 3, the animal form of vitamin D. So our bodies make vitamin D in the skin when we're exposed to sun. There's a reaction that takes place in our skin. Remember, I mentioned to you about the sunblock blocking that. But that happens if we're exposed to sunlight. We make it or we take it in through our food, and that's plain old vitamin D, vitamin D3. And then it goes to the liver and it becomes 25 OH vitamin D, okay? And that's the one that we measure in the blood test. We typically measure that one. And that's to tell us, is the tank full? Is there enough for the body? Do we have enough? And that's a measure of how much vitamin D our bodies are storing, okay? And then our bodies, the kidney, it's on one of those cartoons, we went quickly, the kidney will make 125 vitamin D or calcitriol. Or if you have hypoparathyroidism, you're often taking calcitriol. So vitamin D3 isn't calcitriol, it's the parent, if you will, one of the parent molecules from which calcitriol is made.
Okay, Michelle.
Is there a particular type of magnesium that is better for us, glycinate or oxide or some other brand or form?
Well, another really good question. The right form of magnesium is the one that you tolerate the best, okay, for you. They all will have magnesium in them. Magnesium oxide is the common one that you'll see that you can buy in the pharmacy and we often prescribe. One, not complication, but one side effect maybe of magnesium is that it may make you have some diarrhea. So it may not effectively treat the low magnesium because you exchange, loose stools and you may lose magnesium that way. So you have to be careful when you do magnesium supplementation. Magnesium, usually I usually will use magnesium oxide because it's the easiest for people to get and take. And many times it doesn't cause severe diarrhea or anything. But if it does, then I use a slow release form of magnesium, magnesium SR. But really any form of magnesium is fine so long as you get enough to bring that level up to, a good part of the normal range.
Okay, Katie?
Sorry, so my name is Kevin. I actually was going to ask a very, very similar question on magnesium, but I was actually going to ask on magnesium citrate versus glycinate. I guess you kind of answered the question on which one you tolerate best, but what do you think about magnesium citrate? Well, okay, so you said it, I couldn't say it better. What you tolerate best is the right one for you. Magnesium citrate or citrate often does have GI, activity. And so people don't necessarily like to, have the loose stools and so forth. And it can interfere with your absorption of, the calcium that you're taking or other things. So whatever works the best for you, and a slow release, an SR form, sustained release form. Often, if your GI tract is sensitive to the magnesium, then go for one of those sustained release forms. And sometimes they have to be prescribed, written. A prescription needs to be written and they need to be ordered by the pharmacy to actually get them. They're not necessarily right on the shelf.
Okay, I'm going to go to Michelle here, and then Bob, we have a question up here.
Okay. The next one I have online is there a limit to how much vitamin D I can take?
So the limit would be safety, of course, okay? Because we want the tank to be full. We want the tank to be in the right place, but we don't want to overfill it, and we don't want to get into vitamin D toxicity, okay? And if you do get vitamin D toxicity, then the blood calcium level can go high, the phosphorus level can go high, and kidney function can be affected. So we definitely don't want to go that high. What the Institute of Medicine says in their guidelines about vitamin D is that up to approximately 4,000 international units per day, generally, they do not see any vitamin D toxicity. But I don't think that applies to hypoparathyroidism. So if you're taking anything in the range of 4,000 a day, I would be very, very careful. And in hypoparathyroidism, you're taking any significant amount of vitamin D, that level should be watched in the blood to make sure that it doesn't go too high. Now, I will mention that many years ago, before calcitriol was widely available, and even in the early years of calcitriol, which is a long, long time ago, many people with hypoparathyroidism took very large doses of vitamin D2 or vitamin D3. And it worked. It was all we had, and it worked. And we did drive those vitamin D levels, those 25 OH vitamin D levels, to pretty high levels, and allowed that form of vitamin D to treat the condition. Okay, we don't do that now. We use calcitriol now, or use PTH analogs, et cetera. But if you're hearkening back to maybe days when people took 50,000 units of vitamin D every day for hypoparathyroidism, I don't want to ignore that. That used to be done, and it was considered the treatment. But today, depending on the regimen that you're taking, if you're taking calcitriol and you're just taking vitamin D in order to keep that tank at like 30 nanograms per mil, the way I talked about it, then you want to be careful that you don't take too much. Because if the levels go higher and higher and higher, you may actually have problems with the blood calcium going too high. So sorry it's such a complicated answer, but I think this is a good situation where you want to ask your healthcare provider to check your 25 level and make sure you're not overdoing it, or any adjustments need to be made.
Okay. Michelle had a follow-up question to that
Yeah, the same person commented back in that they are on 50,000 IUs weekly, like once a week, which would equal out to 7,000 a day. Is that too much? Or if their levels are normal, is it okay?
If their levels, she said something very important. If the levels are normal, is it okay? And I would say, yes, it probably is. And when you say the levels, I assume you mean the 25 OH vitamin D level and the blood calcium and the blood phosphorus level. So in other words, we're not just going to talk about one metabolite in the bloodstream. We're going to talk about all three or even four of those. Or if everything's okay, then that is acceptable. And what I quoted about the guidelines from the Institute of Medicine are for people in the general population where we don't recommend that you're following vitamin D levels. We're looking for, in that population, we're looking for a safe level that anybody can take without monitoring. But in hypopara, we're doing monitoring, so we have the benefit of knowing the exact number.
Okay. Bob?
Hi, my name's Norma. I absolutely concur with what this gentleman said over there. I'm a patient, but my question is really about, sorry, I can't read and stand. My question is about trying to figure out the links between things like the TSH levels for thyroid and calcium, blood pressure and calcium, all these other things, urine pH and calcium, and creating stones. I know it's kind of a confusing way I'm asking this, but it's really about the links between multiple comorbidities, trying to find out which is causing what and trying to tease it out to figure it out. So if I only ask one question, I would say, how are calcium levels related to blood pressure? If one's blood pressure is going high, is that a function of calcium level? And how does urine pH relate to, how does PTH and the absence of it, or if you're on a PTH analog, the presence of it, relate to urine pH and the development of urinary calcium stones?
My goodness, there's a lot of really good questions in there and a lot of very relevant questions. And Patty, I think we're going to have to do another talk on some of these things next time. And it's hard for me to take on all of your questions because they're so thoughtful and they're challenging. I will say that I do believe, and the data are a bit mixed in the medical literature, but I do believe that if your blood calcium level is too high, that is something that can definitely contribute to your blood pressure being too high. Like I said, the literature is a little bit mixed, but calcium we know can activate calcium receptors in various tissues. The vasculature is one of them. And so if you're running a high blood calcium, if it's 10 or 11 or even higher, that could certainly be a contributor to your blood pressure being hard to control or too high. Low blood calcium, I think the relationship of that to blood pressure is not, I don't think there's a big relationship. I could be wrong, but I've never really seen one well spelled out. So I'd watch when being concerned about the blood pressure, I would watch that the blood calcium level stays below the upper limit of normal for sure. Parathyroid hormone analogs definitely also have receptors in the blood vessels. So, your question is relevant to those as well in terms of the control of blood pressure. And you sometimes do see blood pressure go up or even go down in response to some of those injections of parathyroid hormone and its analogs. So those are areas that we watch for when we are using those treatments and we think about as potential areas for side effects. But I don't believe that parathyroid hormone in the treatment that you would be taking it for in hypoparathyroidism, replacing the missing hormone, if you will, is going to be a big contributor to chronic high blood pressure. Okay, so we're giving it as a replacement, if you will, not as like a drug, not as a high level to get a certain effect, or not like what you see in primary hyperparathyroidism, for example, where the levels are chronically high. So there definitely are connections. You've brought up some very important interconnections in physiology, and we just would need another lecture to talk all about them. And the effects of parathyroid hormone on the propensity to form kidney stones and so forth is a big topic. But really, I think even without parathyroid hormone, when you're taking calcium and calcitriol, the risk for forming kidney stones in that big managed care study, we just looked at the data in a high level view. You can see it's about 2 to 3-fold higher. And essentially, none of those patients were taking any PTH analogs. Once you go on PTH analogs, it is very important, I think, to measure the urinary calcium and to look at some of those other urinary metabolites that I mentioned on the slides, the oxalate, the citrate, the uric acid, all those different things to take a look at to see whether any of them are in the range that puts you at risk for kidney stones. And that's pretty easy to do. Not every, doctor or endocrinologist is very comfortable with that, but nephrologists are. And so if you have CKD or are heading towards CKD, or you have kidney stones, it is very legit to ask for a visit with a nephrologist and to talk over concerns about kidney health.
Okay, we have time for one more question. So, Katie?
Hi, I'm Lisa Metzler. My question is in regard to treating osteoporosis along with HPTH. From your slide, it looked like you can take Prolia with the analogs of PTH. You just have to be aware of your calcium or frequent blood tests so your calcium doesn't go down. Am I assuming that's correct?
I have no experience with that. That's why you'll see those 3 stars there.
Yeah.
Prolia is very strong. It is a very strong anti-bone resorbing agent, anti-resorptive. So if you give Prolia, you give it once every 6 months. So you're getting 6 months of a medication in one shot. And you can't take it out of the body once it gets in there. It's a monoclonal antibody. So those are, I listed those drugs there so that if someone is talking, if a healthcare provider is talking to you about Prolia, Evenity, Tymlos, all those things, they need to be very, very comfortable with what they're doing, because those are medications that we commonly use in the treatment of osteoporosis in people with intact parathyroid function, but they can really have a very significant effect on calcium metabolism, and one has to be very, very careful in using them in hypoparathyroid people?
Great question, and actually great segue, because I think that this piece was so important, Dr. Schoback, in asking you to do this, because we can miss stuff, because we can excuse it away to hypopara and move on about our life, but we have to be super, super careful to make sure that we're allowing our clinicians to assess us wholly, not just the one piece of it. And there's different times when you might have different things in your life that are going on, such as the osteoporosis, or if you've got esophagus issues and you may have to take a PPI for a little while, you may just have to adjust your hypopara regimen around that, because this is something that you have to take care of, or you're going through a chemotherapy or having to take steroids or things like that. You might have to adjust in the moment, but knowing that you can go back to your regular regimen after that. But it's just not allowing yourself to miss other things that are going on with you, because we kind of push it back to hypopara. So I appreciate everything that you did today, Dr. Schoback. That was amazing. She listened to every detail.
Thank you.
Thank you so much, and we really enjoyed having you today. You have a great rest of your day. And for the people in the room, if you can just hang for a second, I'm going to allow the people online, you can go and you can have your lunch break, and we'll be back at 1:15 Eastern time. Please try to come back about 1:10 so that we can get a little quiet and get moving in here. And let's see what else. Oh, for the people in the room, we're going to have a lighter lunch today because we have this feast that's coming at 5 p.m. Yes, we're eating early today so that we can get back in the room and ready for the 6 p.m. keynote speaker with Ascendus. So the lunch will be a little lighter as you go out there. Know that. And then we also have some raffles for our patients and caregivers. You had a ticket in the back of your name tag, and Michelle's going to call out a few raffles. You got a microphone? You need a microphone.
Okay, so I'm going to shout out the number, or call out the numbers. I'm not going to shout, I promise. But we have some raffle prizes. We're going to do a few today, and we're going to do some tomorrow as well. So let's see. The first one is, I got it upside down, 027033. Are you in the room? Ooh, yay, come on up.
While she's making her way up front, I also want to remind the people in the room that when you go out, the lunch is going to be in the lobby. You can grab it there. We're going to come back if you choose to. We're going to have a lunch and learn with a couple of our doctors that'll start at 12:35. So if you want to do a lunch and learn, just kind of ask the docs kind of stuff, we'll be able to do that. So our second raffle prize is
027032. That looks like I didn't shake it up very well. They're next to each other. 032, are you in the room? Nobody. Okay, I'm going to draw a different number because I want to give these away. 036 are the last three numbers. 036.
Oh, there we go. Tim.
Yeah.
All right. Very good.
And while Tim's making his way up here, I'm going to give away one more. This is going to be the last one for today. 015.
Who is
015, are you in the room?
Last three numbers.
It's that patient back there. I will bring it to you. Thank you guys for joining us today.
All right, everybody, enjoy your lunch. And if you want to come back to an Ask the Doc session, we'll start at 12:35 in this room. Thank you. All right, welcome back, everybody. We hope you enjoyed that wonderful lunch break and our Ask the Docs in between. So our next presenter, we went back and asked based on some things that we see online and questions people ask and said, you know, we really need to understand this nutrition piece of hypopara, calcium, and all that as well. So we were able to find somebody that comes to us from the NIH, and we talked to her. We had a pre-meeting and talked to her about what our needs are and the different things that are that we need on a daily basis to be able to partner with our supplements as well. And I tell you, she sent over her presentation, and I was like, wow, it's amazing the people listening to me out there and the presentations they're coming up with, because it's really, I think you'll really enjoy the concepts. I'm not going to give it away. She'll be able to share with you, and I think you'll make your own deductions from it. But we're excited to welcome to the table Megan Schoenfeld. She's from the NIH, and she provides clinical services and resources to the NIH team. So welcome, Megan.
Thank you. Hi. Awesome. I'm so happy to be here. I've been at the NIH for 10 years, and some people look familiar in the audience, actually. My clinical interests are endocrine diseases. I support the endocrinologists at NIH with clinical nutrition services. And then I support research, helping providers and investigators collect data on nutrition. And I'm also interested in diabetes and weight management, liver disease, and I think nutrition can sometimes seem overwhelming, so my goal is to always make it as clear and as realistic as possible. So that is the focus on my presentation today, is to make it as user-friendly as able. Okay, so here's an outline of what I was going to go over today based on some of the feedback I received that people are interested in, but then there will be time for questions as well. So we'll go through calcium needs, foods that contain calcium, calcium supplements, other nutrients of concern that people with hypopara are worried about, general healthy diet recommendations, activity, some sample meal plans that I came up with, and some resources. All right, so starting out with calcium, our favorite. Calcium is the most abundant mineral in the body. It is essential for building and maintaining bone health, or bones and teeth, helping us clot blood, regulating our central nervous system, and keeping our muscles working properly. So it does so many things for us. It is found in many foods like dairy products. Naturally occurring in dairy products is added to others like calcium-fortified orange juice or plant-based milks. It is present in some medications like Tums for acid reflux, and it is available as a dietary supplement, which you guys know. And that can be calcium carbonate, calcium citrate. It's stored mostly in our bones, and so throughout our lifetime, our body is pulling calcium it needs from the bones if our blood levels are too low, and over time, if this is happening too much, our bones can become weak. So that's why calcium is important. And then the recommended daily allowance, or the RDA, for adults is generally 1,000 to 1,200, depending on age and gender. Can be as high as 1,300 for young adolescents. And then the food labels, are interesting enough, is based on 1,300. So when you're reading a food label, we'll go over this a little bit, it's based on 1,300. And then calcium is a large mineral, so it's not always easy to break down in the gut. All right, so calcium sources. That should have an S at the end. Despite having probably about 7 people reviewed the slides, there's an S missing on sources. So dairy sources, we've got milk, yogurt, cheese. These are the most, some of the richest calcium sources. But that doesn't mean they're our only sources. We've got our non-dairy sources as well. They could be fortified non-dairy milk, tofu, and soybeans. Almonds, green leafy vegetables like spinach, greens, broccoli, bok choy. Fortified breakfast cereals have some calcium added to them. Fish that contain bones, so if you're a sardine eater, go ahead, that's a great calcium source. Not for me. And then fortified orange juice. All right. Okay, so here's a table. This is from the dietary guidelines. I just screenshotted this table. There's a million calcium tables out there, and that's what can be somewhat frustrating is sometimes you find different milligram amounts depending on where your source is. But this is a great one. It goes through dairy and the fortified plant-based milk alternatives, and then some of the vegetable protein and fruits. So remember, the RDA is based on is typically 1,000 to 1,200, and food labels have the 13. And then there's a link to this table. So things that are interesting on here, I think, are, a lot of the greens are based on cooked. So when you're thinking about the portion that you need to get, say, about 100 from your greens, like turnip greens or something, it's based on cooked. And then tofu is another one that I find a lot of diversity in the amount of calcium, so checking your food label on your tofu if you're a tofu eater. So now on to food labels. So this can be a great way to get your information about calcium. So the new food label will display the milligrams of calcium in the product, which is something in the past 10 years that has changed since I started working with individuals with hypopara. It used to be you just got the percentage, and then you had to know what the percentage was based off of to come up with how many milligrams of calcium. But now, thankfully, someone's looking out for us, and we've got the milligrams of calcium on most food labels. Say you found a product that doesn't have it, it is based on 1,300. So what you would do is say it's a 15% calcium, then you would take 1,300 times 0.15 to come up with the milligrams that item is providing. All right, so many individuals with hypopara are just told to, go out, increase your calcium, just get more calcium. Do it, it should be easy. But I find sometimes it's not as easy as it sounds like it should be. So here's some of my favorite ways to kind of start thinking about getting more calcium. Again, you guys are probably more so an expert in calcium than me, but these are just kind of typical things that I'm telling people. So maybe start the day with calcium. So the day is fresh, let's get some calcium. It could be a glass of milk, both dairy or non-dairy. You could think about putting milk in your coffee or making a latte instead of just coffee with sugar or black coffee. If you're not a milk drinker, you could think about fortified orange juice. If you like orange juice, that can be a great way to start the day. Yogurt, either dairy yogurt or non-dairy yogurt. If it is a non-dairy yogurt, I'd want you to look at the label and just make sure it's something that's got calcium added to it. And then adding cheese to eggs or toast can be a good idea too if you like cheese. So I know these are kind of dairy-focused recommendations, but fortified orange juice, plant-based milks, and plant-based yogurts could be options too. And then maybe having one calcium-containing snack. So thinking about keeping a small snack, whether it's a cheese stick, a yogurt, almonds, and even maybe like a small portion of fortified calcium cereal and some milk could be a good afternoon snack. And then a lot of times people ask, I want to increase my calcium, but I don't want to increase my calories. I want to be mindful of keeping my weight at a healthy range for myself. And these are some of the lowest calorie ways to increase calcium. So almond milk is a very low calorie beverage that is calcium fortified if you like it. So that can be an option. Green leafy vegetables, really making sure you're getting a lot of those can be a good idea. Tofu can be a low calorie protein source and also a great calcium source. Low fat cheese, fat-free milk, or yogurt could also be a great option. You can of course have full fat dairy if you'd like, but if you're thinking about reducing calories in some way, sometimes addressing the fat in dairy can be a good idea. All right. So moving on to supplements. So here are two supplement options. Moving into this, you obviously want to work with your provider to come up with how much calcium you should take, and they may recommend, recommend either calcium carbonate or citrate, and how many milligrams you should take based on your usual intake. Looking at labs, of course, and then medical history. So calcium carbonate is 40% elemental calcium. It's best absorbed with food, and so we encourage you to take it with food. When you look at the food label, you can see on there, a lot of times it'll have the milligrams of calcium for you and the percent daily value. That milligram amount is the elemental amount. So say your physician told you to get 12 1,200 per day. From supplemental calcium, you could do 1 calcium carbonate in the morning and 1 calcium carbonate in the evening. Of course, check with your physician before you start supplements, or your dietitian as well. And then calcium citrate can be absorbed without food. It does not need acid, or it doesn't interact with acid as much, and it is smaller. So it's only 21% elemental calcium. So if you notice on this, for this example, to get 600 milligrams of calcium citrate, you would have to take 4 capsules versus just taking 1 of the calcium carbonate. So there's definitely benefits of either one, and just talking with your physician about which one is best for you. Oh, I had another tip on there, a little note on there that also talked about vitamin D. Some calcium supplements have vitamin D added to them, so you can also get recommendations on that as well. Calcium absorption, I think, can be kind of tricky. This is another question I get is, so the amount of calcium absorbed and used in our body is called calcium bioavailability. Dairy products in general have the highest amount of calcium and moderate amount of bioavailability, making them a good choice if you tolerate them or choose to eat them. Some non-dairy items with high bioavailability and good calcium content are like bok choy, tofu, and calcium-fortified orange juice. So these can be great options for a plant-based eater. And we count calcium based on milligrams present in that item versus the bioavailability. It would get a little stressful to try to come up with the bioavailability for everything and put it on the label. So several factors also impact calcium absorption, including the amount of calcium consumed at that time from either food or supplements, our age, and then compounds found in plants like oxalates. So we know that in large servings of calcium, say over 500 milligrams, that calcium absorption can decrease. And then as we age, we experience pH changes in our gut, and that can also impact calcium absorption. And then oxalates, which are present in plants, they can impact calcium absorption. They bind to calcium in our stomach and intestines and prevent that absorption. So foods, and oxalates are very healthy foods: spinach, sweet potatoes, soy, nuts, chocolate. These are many healthy foods that I want everyone to eat if they like them. And so I think it's really hard to try to figure out what to do about this. So what I usually recommend is to think about, if this is something that concerns you, if you eat a lot of these foods, maybe thinking about just picking one a day to have. So maybe you wouldn't have a day that was, where you had spinach and sweet potatoes and something in the same meal. Maybe you'd pick one or the other, so that you're still getting these healthy foods, maybe not in excessive amounts. I think it's hard because a lot of times hypopara can feel uncontrollable, and so you try to focus on what you can control, and a lot of times diet takes the hit for that. And we try to control our diet as much as we can. Never want people to feel super stressed about their diets, or for it to be a source of anxiety. So I think the bottom line is to try to do the best you can. You really can't control your age. You cannot control a lot of your own body's absorption. And so thinking about eating a variety of calcium sources, anything from dairy if you tolerate and like it, to plant-based, to some of the lower calcium sources like nuts and greens, and then in moderate amounts throughout the day. So I don't want to try to get all your 1,300 milligrams of calcium in the morning. Thinking about breaking it up throughout the day. I think that's the best we can do. All right, so phosphorus is another nutrient that comes up, and it's also impacted by PTH, and it can result in increased levels in the blood. So some individuals may receive recommendations to reduce phosphorus, and these are based on blood levels. We don't want people to reduce phosphorus without being, unnecessarily, because a lot of the foods that are high in phosphorus are protein sources and calcium sources. So these can include dairy, animal proteins, whole grains, beans, nuts. So these are healthy foods. I want people to have them if they can. And then phosphoric acid is added to food as a preservative. So that we may find in like soda, lunch meats, fast foods, processed foods. So if you have been told to follow a low phos diet, here are some of my kind of 3 things to start with. I would start with omitting the empty calorie kind of processed foods. So say you are okay not eating lunch meat, and you can swap it for something that's not processed, maybe like chicken breast, or even like canned tuna would not have phosphoric acid added. Say you can find a soda without phosphoric acid, something clear or a sparkling item, or being careful with packaged baked goods. So these are foods that generally, we can find a substitute for. Things that you'll see on the label are these three additives, so looking for those. If you're flipping over a processed food and you're like, I really love this, let's make sure it doesn't have this in it if I'm trying to be careful of phosphorus. And then controlled protein portions can also be a good tip. So generally 3 to 4 ounces can still meet our protein needs. And since protein, especially animal protein, is such a rich source of phosphorus, being careful of the portion can be a good idea. And then consider plant-based dairy that doesn't have added phosphates. So this could be like soy milk or almond milk. If you have concerns about phosphorus in your blood, discuss it with your physician or dietitian before making changes that are unnecessary if your phosphorus levels are just fine. And then next is sodium. So sodium is another important mineral. And sodium and calcium are great friends in our body. When sodium intake is too high, the body gets rid of it through our urine and it will drag calcium along with it. So sometimes lowering sodium intake can lower urine calcium losses. So say your physician has recommended, let's tighten up sodium a little bit and see if that helps with urinary calcium losses. Just know sodium is found in salt, and salt is added to food for flavor or preservation. The dietary guidelines suggest keeping sodium intake to less than 2,300 milligrams a day. That's quite hard. The general US population eats about 3,400 milligrams of sodium per day, and salt is kind of delicious, so it just happens. According to the CDC, about 40% of the sodium consumed by Americans comes from many of my favorite foods: tacos, pasta, burgers, omelets, chicken dishes, pizza, burritos, yum. So some of these are dairy, some of these are calcium sources. And a lot of these, what I know from this is a lot of these are foods that can be purchased out. So I think that's a lot of where it comes from too, is a restaurant adding more sodium than you would at home. So say you are, thinking about wanting to eat these foods, but in a healthier way, maybe preparing them at home could be a good idea. But here are kind of my top 4 low sodium recommendations. So again, just like the phosphorus, start with the processed foods. Is there a purpose to it? There are many foods that are purposefully processed. And I feel like we get a lot of information about processed foods. And so canned beans is an example I like to use. I don't make beans from dry at home. I don't have time for that. So I buy canned beans. And that's a processed food. But something like chips, which I also love, are not as purposeful as the beans. The beans are a protein source, they're a fiber source, the chips are just delightful. So thinking about, what, do I need this food? So what can I reduce here? So I would keep the canned beans, maybe buy a low sodium version, and decrease the chips a little bit. So what can be omitted? Can there be a reasonable substitute? So say you're looking at salad dressings, for example. Again, salad dressings are something that we could make at home if we wanted to, but is also, we can definitely purchase. So looking at the food label to see, can I get a lower sodium salad dressing that I still like? Cook at home more is another tip, and reduce salt in recipes by half. So say you're making something like macaroni and cheese, it calls for half a teaspoon of salt. Could you, the cheese has sodium, could you reduce the sodium in there, maybe add a little bit of something flavorful like paprika to give it some fun without the salt? Reading food labels is a great idea in comparing products in the grocery store. Salad dressing was a good example of that, where I need salad dressing, I want to eat salad. Can I find a lower sodium option? And then ask for modifications in restaurants if you're eating out several times per week. So say you're eating out once a week, it's okay, don't waste your time asking them to hold this or side that or whatever. But say you have to eat several meals out in a week, maybe thinking about, are there a couple things we could do? Maybe asking if something could be cooked without salt, getting things that are more in their true form. So instead of a mashed potato, thinking of a baked potato, less chances for them to add salt to it. Could I get dressings on the side? Could I get less cheese or less sauce, which is a good sodium source? All right, enough about sodium. So now I want to include a little bit of information about just general healthy eating, because it's a question that comes up as well. So I included information from the dietary guidelines, which are published every 5 years. These are kind of core elements of a healthy eating pattern. So an eating pattern is, the way we eat, a pattern of eating. I try to use that word instead of diet as much as possible, but I still, fail to do it sometimes. But eating pattern just sounds more positive than diet, so I try to do that. So these are 6 things that they are kind of recommending to do to follow a healthy eating pattern. So top is vegetables of all types. Dark green, which we know are calcium sources, red, orange, beans, peas, lentils. Starchy vegetables like potatoes and corn, those are vegetables too. Fruits, especially whole fruit if possible. Grains, at least half of which could be whole grains, so picking whole wheat bread, whole wheat tortillas if you want, brown rice. Dairy, including milk, yogurt, cheese. This includes plant-based options. Our diet should also include some protein foods, and it can be anything from lean meats and poultry and eggs and seafood to some plant-based items like tofu, beans, peas, lentils, soy, other soy products. And then oils, healthy oils, including vegetable oils found in food like seafood and nuts. So these are, if we're thinking about, things that we should include in one day, if we can grab all these things, it would be great. So this is a little bit more about healthy eating patterns. So the dietary guidelines usually kind of highlight several, and I know these say this, Mediterranean diet, but the dietary guidelines typically highlight some of the evidence-based eating patterns, and those are the Mediterranean diet, which could be, is focused on vegetables, plant-based foods, seafood, limiting high-fat foods, and sweets. And then the DASH eating diet, which stands for dietary approaches to stop hypertension. And so it benefits blood pressure, it can lower bad cholesterol, and it really aligns a lot with the Mediterranean diet as well. And then plant-based eating patterns. So that could be anything from lacto-ovo vegetarian, someone that would include eggs, to someone, and milk, to someone that would include, none of those products and would be a vegan. So all of them have benefits. This does not mean you need to overhaul your diet completely and 100% align with all, either of these or any of these. You can start, kind of setting goals that would align with this. So for example, both things, at the top of the Mediterranean diet and DASH are vegetables and fruit and produce. So maybe starting there. Maybe thinking about one meatless meal or one meatless day if you're trying to reduce animal protein. All right. Okay, so some other general healthy eating notes from me, just kind of based on the dietary guidelines, my experience, and then some of these eating patterns. So increasing nutrient-dense foods. So nutrient-dense foods are foods that provide us with vitamins, minerals, fiber that promote health. They have little added sugar, saturated fat, which is animal fat, and sodium. So these foods could be vegetables, fruits, whole grains, lentils, eggs, lean protein. And they're foods with little added sugar or added fat. So these are our nutrient-dense foods. And then decreasing empty calories. So empty calories are foods that give us calories without benefit. So examples could be like soda or my favorite chips or pizza, snacky foods, things that may sometimes bring us joy but not necessarily bring us nutrients. And that's where my next tip is, the 90-10 rule. So thinking about 90% of the time we're eating these nutrient-dense foods that that are good for us, that we also enjoy, and then 10% of the time it's someone's birthday or celebration, or it's a busy day, and you may end up eating more processed foods or more indulgent foods than you typically eat. And then I always want to remind people to avoid eating patterns that encourage avoidance of the whole food group or types of foods, unless they don't tolerate them. So, we don't want to omit all of our carbohydrates or all of our fat. That wouldn't be good. We need carbohydrates for energy. We need fat for satiety and hormones. And so all foods are important in our body. And if we can tolerate them, we should eat them all. Okay. So then I've got some common themes based on dietary guidelines, healthy eating, and then my experience. Produce is important. So fruits, vegetables, these are important foods. If you can make one change with your diet, aside from making sure you're getting enough calcium, thinking about trying to get more produce is a good first, that's where I would start. And then they all focus on fiber. So fiber is in whole grains and produce. It helps us stay full. It can reduce risk of chronic disease, so fiber is important as well. And in general, we don't get as much fiber as we probably should. And then lean protein is encouraged mostly, if we can, at every meal. This could be animal sources or plant sources, so anything from chicken to tofu to beans to, lean cuts of beef. Protein is important. It keeps us full, and it helps maintain our muscle mass. And then empty calories are limited, so things with added sugar, fat, high sodium foods, as much as we can be careful of those, 10% of the time type foods, that would be a great thing. So since my number one tip was increasing fruits and vegetables, I'll go through about seven things I recommend to do. So start with what you like. You don't have to eat anything you don't like. That's the number one rule about nutrition. Don't have to eat anything you don't like. So start with a vegetable you like. Try to increase that more in your diet. Find new ways to make it. Or fruit. Say you don't even like vegetables and you want to start with fruit. That's fine. Try a new vegetable when eating out. So say you don't want to purchase it and cut it and do it at home, but if there's something interesting, try it when you're eating out. Consider doubling the vegetable portions and recipes. So if a soup calls for a vegetable that you do like and you want to double it, go for it. Cut up vegetables in one batch. So say you go to the grocery store, you buy a bunch of fresh vegetables, and you want to cut them all up in one day. It can be faster a lot of times than trying to hack at them throughout the week. If it's within budget, you could also consider buying pre-cut ones. That's just fine too. Frozen are just as good as fresh, and I would even say I would leave canned in there too. Any way you can get a vegetable, if it's canned, fresh, or frozen, I love it. Blend vegetables into sauces, so this could be, taking pasta sauce and putting some squash in there, extra tomatoes, onions, or spinach, and then add beans to anything and pretty much everything. Beans can go with all foods, so those are my vegetable tips. All right. A little bit about physical activity, because this comes up as well and is important. There's something called the Physical Activity Guidelines for Americans. It's in second edition. And I've included some tips from them as well. So they're recommending at least 150 to 300 minutes of moderate intensity aerobic exercise a week, which could be like walking, biking, exercise classes. And then 75 to 150 minutes of vigorous intensity exercise. So these are their recommendations, but they do note that any exercise is of benefit. So say you want to do 20 minutes a week. That is just fine. It's not 150, but it's not 0. So they're okay with that. So getting out there, doing whatever you can. Muscle strengthening exercises are also of importance. So I get asked a lot of times, how can I improve my metabolism? Improving your muscle mass is the only way to improve metabolism. So the stronger you are, the more calories you burn at rest. So getting involved in some sort of strength exercises that you can do a couple days a week is a great idea, where you're working major muscle groups like your arms or legs or your core and back. So kind of the 4 tips that I have based on this are: start with an activity you enjoy and can do without discomfort. So like walking or swimming if you like to swim. Just like eating, you do not have to do an activity that you don't like. And then increase is tolerated. So say you start with 15 minutes after a lunch or something and you want to increase it to 20. You always want to kind of challenge your body with exercise. And then try to be consistent. So say 15 minutes is all you've got, but you're going to consistently commit to that a few times a week. Just start with making a habit to move. And then consider free options, whether that's YouTube or free classes at work, classes within the community, parks, walking trails, rec centers, that sort of thing. Shouldn't have to pay a ton of money for physical activity if we don't have to. Things are expensive enough. Okay, so physical activity for adults, 2 questions we sometimes get are, what if I have pain with exercise? That can be very common. So consider a low impact exercise like swimming, a stationary bike, maybe yoga, maybe some stretching, and kind of increase as tolerated. There is some sort of discomfort that comes with exercise, and I think, thinking about discomfort versus pain, so, if I'm lifting some heavy weights, that's uncomfortable, but it's not painful. So if it's pain, I think there's a line between pain and discomfort. And then consider seated strength exercises. So there's lots of free YouTube videos out there for seated low impact exercises. So starting there, strengthening your arms, strengthening your core in your seat is a great idea. And then if you have a doctor that could, write for a PT referral, if that's something that they're able to do. And then how does exercise impact our calcium levels? So we have research in individuals without Hypopara that are doing very strenuous intense exercise like marathon running, and that impacts calcium. In general, the recommendation of 150 minutes a week will probably just be fine. It would probably not lower calcium levels. But if you have symptoms while exercising, discuss this with your physician as well. All right. Okay, so then the next 3 slides are some sample meal plans that I came up with that are kind of included breakfast, lunch, dinner, and snack. They're about 2,000 calories. You can add seasonings and dressings as desired. And this one has about 1,000 milligrams. So this was a brainstorm of something I created. So breakfast, we're starting the day strong with some eggs and cheese, maybe some vegetables added in there, maybe a piece of fruit for fiber and carbohydrate, and then some calcium-fortified orange juice. So that brings us to about 400. So we've got that done at breakfast. And then lunch, could be a pita, hummus, tomatoes, kale, fat-free cottage cheese. So that's a little bit lower, 250. And then you're going to do a snack, maybe some yogurt with some berries. I picked 2% fat yogurt, but it could be skim, it could be whole milk. It could be a cup of milk if you don't want to drink or want to eat yogurt. And then dinner is a little bit lower with salmon, potatoes, and then the calcium mostly coming from broccoli. So this gives us about 1,000 milligrams. Again, this is just, an example. No one has to definitely eat this way, but it was a good guide, I thought. All right, so then we've got, say, a non-dairy option or a vegan option. So this is all plant-based. So this is, again, breakfast, lunch, dinner. Breakfast is gonna maybe start with a cup of soy milk or other plant-based milk that you like. Some whole grain cereal that's usually fortified with calcium, some chopped walnuts, and a cup of mixed fruit. And then lunch is a little bit lower calcium. So this, and this may not be enough food for somebody. They may want to adjust it. So mixed greens, roasted chickpeas, other chopped vegetables, a preferred salad dressing. So it's kind of a light lunch, actually. Because then we're gonna need a snack after that light lunch. So almonds, dried fruit, some chocolate chips to kind of make a homemade trail mix. And then dinner, most of our calcium is coming from this bok choy and tofu. And so you'd make kind of a stir fry, tofu, brown rice, stir fry vegetables, including bok choy, and then whatever sauces. So this is about 1,000 to 1,100 milligrams. It's a little bit lower protein. So say you're an individual following a plant-based diet, you want to make sure you're getting enough protein. You may need to do a protein drink or increase the chickpeas, increase the tofu to get enough protein. All right, and then my last one is a takeout day. So say you're traveling or you have a busy day and you're gonna eat all your meals out. So this meal is this day is kind of fueled by cheese. So if you don't like cheese, we're gonna have to think about something else. Maybe you grab a calcium fortified orange juice to make sure you're getting enough. So again, cheesy day. So we've got egg sandwich that has cheese. English muffin and an apple. That's something that Starbucks or McDonald's or anybody can have. And then a takeout salad with maybe it has chicken, cheese, vegetables, and some salad dressing, and it's about 4 cups. So that's usually kind of a hearty bowl. And then snack, maybe you're having a granola bar and then a latte. So that's not cheese, but it's dairy. And then at dinner, you're at a Mexican restaurant. You're gonna have some beef enchiladas, rice and beans, and a side salad. So this is, a little over 2,000 calories, a little bit higher calcium. And the day's kind of low in fruits and vegetables, honestly. So sometimes, there's 2 salads, I guess, and a fruit. So maybe it's not. But sometimes this just shows, some days are lower fruits and vegetables, some days are higher, and you could eat any of these days. All right, I'm definitely gonna have enough time for a lot of questions. So, my closing thoughts is that change, whether it's diet, addressing issues with hypopara or general healthy eating patterns or exercise, change can be overwhelming. So thinking about, not overhauling everything overnight, picking 1 or 2 things to work on at a time. And maybe that's calcium, or maybe that's vegetables, or maybe that's exercise. And, really honing in on those habits for a few weeks, making sure they are becoming habits and that they're not too hard, and then moving on to something else so that you're not picking things, that they're unattainable or that are too much at once. And then thinking about priorities. So, I went over a bunch of things, and what's a priority for somebody is maybe not a priority for other people. So really thinking about what is something that is a priority for your life. right. And then I think I've got 15 minutes for questions, which was great. These are some resources. Oh, sorry. The ODS, so Office of Dietary Supplements is an NIH group, and they have fact sheets about all sorts of nutrients, including calcium, so that is a great one. The Dietary Guidelines Calcium Fact Sheet, the Dietary Guidelines in general, that has a lot of information about general healthy eating. MyPlate.gov, which is a website that can, I don't even have a picture of it, I should. But the idea is to fill half your plate with produce, a quarter of the plate with grains, and a quarter of the plate with protein, and the information from the Mediterranean diet and DASH diets. So, all right, now we've got questions.
Now we're ready for questions.
Yes.
Thank you so much.
Yeah,
What a great
thank you, guys.
presentation.
Thank you.
You know, I think it's so important that we really pay attention to this so that we can partner our supplements. We know as hypopara patients, we're not going to be able to get everything through our diet. We have to have our supplements as well. But man, it can really partner. I recently went a little bit low myself, and I was actually starting to have some symptoms. And I was like, damn, I don't want to take another calcium. So I was like, let me figure this out. I got cottage cheese, I got almond milk, I got ravioli for dinner. And I tell you, I was at 8.3, and within a couple days, I was back to 9.2, and I was feeling great. And I didn't have to take extra calcium. So it's a partnership and understanding what your body knows. And sometimes, you know, it might not be a cheesy day or a cheesy week, and you go, oh my gosh, I haven't had cheese all in a month. So really paying attention sometimes to our diet when we're having those ebbs and flows that go through us will help. I loved also where you talked about, like, add more of what you like. Like, right? If it's good for you and you like it, add more, because that'll really help as well. And then, of course, the old exercise for some people that don't like exercise, and find one little thing that you do like and just add a little bit more to that. So that can really help as well. So let's take some questions from the audience, and we'll go with Bob first, and then we'll go to Michelle.
Hello. I was just going to ask if there's any foods specific to hypoparathyroidism that we should avoid. I know that I saw a few years back that something, I forgot the reasoning, I don't even know if it's true, but cauliflower is better to avoid, but I was going to see what you thought of that.
Yeah, great question. And we get this too. And I think it's very individual. So, you know, say you're having a lot of urinary calcium losses, maybe high sodium, or if your phosphorus levels are high, maybe, you know, decreasing the phos. But there's no like one food that you would need to avoid. Sometimes oxalates are something that you will read about that to be careful of. And it's more so not necessarily not having them, but maybe not having them, you know, a lot of them in one day. I don't know, cauliflower off the top of my head, I don't know if it's high in oxalate. So I don't know where that one maybe came from. But you're good with cauliflower, that's for sure. And there's no like one food that people need to avoid. Great question.
All right, Dr. Manson?
Yeah, Megan, thank you for the excellent practical advice. Can you drill down a little more on the question of phosphate and dairy? So I often find myself encouraging dairy, as you do, but then I also know that there's a lot of phosphate in there, which we typically want to avoid in hypoparathyroidism. And then we kind of find a middle ground, take dairy, but not too much.
Yes.
And, so tell me what you think about it.
And it's hard because, you know, in nutrition, whether it's about phosphorus or sugar or whatever, we always say this word moderation, like eat it in moderation. But what does that actually look like? So I think knowing actual levels in the blood of phosphorus can be helpful. And so say phosphorus levels are high, you're consuming 3 dairy products a day, maybe subbing for one of the, if you're comfortable with it, subbing for a plant-based milk that's not fortified with dairy. Not fortified, doesn't have any added phosphorus. So soy milk and almond milk are 2 milks that can work. And then maybe doing a little bit more of the other plant-based calcium sources like nuts, greens. And we know these aren't going to add up to robust numbers. And so maybe if it's a balance of cutting down on dairy foods altogether and increasing a supplement. And that's like a conversation that I feel like is super individualized, where you've done all you can with your diet, you've cut down to maybe one animal dairy product a day, you've been careful with your phosphorus portions, you've looked for other phosphorus sources outside of the very important calcium sources, and then maybe it's a supplement thing where you need to increase the supplemental calcium a little bit more. Which is an unfortunate answer because we want to, I know it's overwhelming to take all these supplements. So,
All right, Michelle.
I have one online that is asking, do you have any recommendations on how to find a dietitian, specifically maybe a pediatric dietitian, and how do you make sure that they understand Hypopara?
That is such a good question. So there's a website called eatright.org, and it is going to, on that website, I think in one of the top corners, it'll say find a dietitian. And so you can search by your zip code and find a dietitian. So that'll give you a list. And then it may take a little bit of, digging on their websites, if they have websites, giving them a call to make sure they understand Hypopara. Another place to start is with your physician, maybe an endocrinologist or primary care physician, and seeing if they've referred to different dietitians.
On the second part of that question, she was asking about pediatric. Does it matter if they're pediatric? Do you guys specialize like that?
We do a little bit, yeah. Usually if starting at, if there's a local like children's hospital or something, that could be a good place to start for a pediatric dietitian, and seeing what kind of clinics they have there could be a good idea for pediatric. I forgot to address that one. So eatright.org, pediatric dietitian, it may be a local pediatric hospital, asking a primary care or endocrinologist as well, especially if they're a peds endocrinologist. Peds endocrinologists work really closely with dietitians a lot of times, so that can be a good place to start.
All right, we have a question back there.
Hi, Bill from Baltimore. I'm a caregiver. First, thank you for holding this immediately after lunch, because the deli meat was delicious, and I would have not done it otherwise. Quick follow-up to the doctor's question regarding foods that are high calcium, low phosphorus, and low sodium. Is there any sort of a helpful Venn diagram of sorts that shows relationships between different foods?
Right.
Something that we could all find and use as a helpful guide.
Yeah.
And the second question, which is not related at all, is there's been a trend towards intermittent fasting as a dietary method. Has there been any research into how that, coupled with hypoparathyroidism, could interact?
Yeah, these are great questions. So for the high calcium, low phos, low sodium, a lot of kidney diets are focused that way. And so resources from NIDDK that are focused on kidney health could be a good resource there. But as far as like an actual diagram I have of foods that are high calcium, low phos, low sodium, let me think. Like the green leafy vegetables are one, but they're kind of low, and they're not super high in calcium, but they're still a source. Plant-based milks would be, if someone is up for plant-based milks, that would be a good way to go, because even tofu is going to have some phosphorus in it too. So, but I would start with, I'm trying to think of NIDDK is a good place to start for kidney, kind of a kidney-focused diet, because that's kind of the low phosphorus and sodium. And then your question about intermittent fasting. So there's a lot of studies about intermittent fasting, nothing specific to intermittent fasting and hypopara. What I would think is that it would be hard to spread your calcium throughout the day from food if you have an eating window that is narrow, like 8 hours or something like that. So we all fast overnight, and a lot of times the 12-hour fast is of benefit, and we don't all need to do intermittent fasting. And at least in my understanding and what I've read, is that some people seem to really do well with it, and their bodies like it, and some people don't. And I would think hypopara is one where, if you're trying to get 300 milligrams of calcium spread throughout the day, intermittent fasting may not be the correct diet. But if you can, or if you wanted to include like a plant-based milk is a breakfast, like in a coffee, but not necessarily have it be a meal, that could be a strategy for trialing intermittent fasting. Always recommend to, if there's something you read about that you're interested in trying and it seems safe, so intermittent fasting could be one of those things. And the time-restricted eating is what I'm really more talking about, where you would have an eating window of 8 hours, not necessarily every other day fasting. I would think every other day fasting or a few fastings a week or something would not be something I'd recommend in hypopara.
Okay, Bob?
Yeah, Lynn Kohlmeyer, thank you so much. I tend not to trust slow-release calcium in my hypopara patients. Can you tell me a little bit more about that, especially if they're not on parathyroid hormone replacement?
You said the slow-release calcium?
Slow-release, I just don't trust it. Should I?
This is a great question, and I don't know if I'm the right person to answer it. Now, while I do have a great experience with hypoparathyroidism patients at NIH, I don't necessarily get to follow up with them closely after supplement recommendations are made. So I'm sorry, I don't feel like I can answer the slow release one. I'm sorry. It might be a better question for somebody that gets to like follow people more closely.
Yeah, one more, Bob.
Hi, I didn't hear you talk much about eggs, and I wonder if eggs are a source of calcium, if you can have too many eggs and that can give you too much calcium. And also, you mentioned sodium, too much sodium will end up with high urinary calcium, but will it also result in high blood serum calcium? And if you have any suggestions for lowering your sodium beyond eating a lot of chips.
I know, so sorry. So eggs are not a great source of calcium, but they go well with cheese, which is a good source of calcium. So I do like eggs. Eggs are a great protein source, and so they're important for muscle mass. As far as the egg limit, I feel like in the past 20 years we've gone kind of eggs are good, eggs are bad, eggs are whatever. The egg yolk contains saturated fat. That is considered an unhealthy fat, but egg yolks also come with a lot of vitamins and minerals. So I like egg yolks actually, and so I like to think about how many egg yolks are you eating a week? Are you eating 10 egg yolks a week and you're also eating sausage and you're also eating bacon and other high saturated fat foods? Maybe you need to be careful of that. But if you're more so a pretty low lean protein eater, egg yolks could be just fine. If you are worried about, you say your cholesterol's been a little bit high and you want it to be mindful, you could do, buy a carton of egg whites, buy a container of full real eggs, and kind of mix them together if making a scrambled egg. So I love eggs. Not a source of calcium. And then your sodium question. So sodium is hidden in a lot of processed foods. So salad dressings, cheese, lunch meats, anything that comes in a package can be at risk for having sodium added to it. So just checking food labels. As far as sodium, high sodium diets making calcium levels in the blood high, I don't think that usually happens. It's more so the sodium is bringing calcium with it out of your urine. And so that's something more individual where you're, if you're doing a 24-hour urine and your physician knows that high sodium and high calcium levels losses through your urine, they would maybe recommend to tighten up how much sodium you're getting, so reducing added salt, reading food labels, maybe eating out less, or all ways to address sodium.
Okay, we're out of time, but thank you so much, Megan, for a great presentation.
This was great. Thank you so much. Thank you.
All right, that was fun. And yeah, we purposely placed it after lunch. All right, so our next presenter, we all know and love. He's been a great supporter of the association, of us patients. And this year, it's so cool because we actually get to talk about options and how do we transition into options. We haven't got to do that before, so we're really excited about that. So we'd like to welcome the chief of the endocrine unit at Mass General, also the associate professor of medicine at Harvard. Please welcome Dr. Michael Manstack.
Thank you so much for the very kind introduction, for having me here. And also thank you, the audience on Zoom, to join. That's wonderful. And congratulations, everyone, on this wonderful conference that's so lively and incredibly interesting because of you, your questions, your experience that you share. You make this conference what it is. So, and as nice as Patty is, she gave me actually a tough question to answer, and that is, if you switch from one PTH to another, how do you do this, right? And so from one to another, strategies for switching PTH therapies. Let me just try to get forward. Oh, here we go. And the next slide is coming, I hope. Wait, here we go. So I work at Mass General Hospital, huge history of PTH-related research. Idiopathic hypoparathyroidism was for the first time described, actually, by Fuller Albright. The PTH amino acid sequence, the gene, the receptor, all of this was discovered there. So heavy burden standing off the shoulders of giants. And the next slide, it's not easy to advance them, shows you what we are talking about. So this snake is the amino acid sequence of human parathyroid hormone, a peptide hormone of 84 amino acids. That's kind of the key ingredient here that is missing if you have hypoparathyroidism, produced by the parathyroids and does this wonderful work. We have discovered that the first 34 amino acids contain what we know is the action of PTH. And that is a drug that's used for osteoporosis that many of you know. It's called Forteo, PTH 1 to 34, because it contains the first 34 amino acids. It's approved for osteoporosis. And then came Netpara, PTH 1 to 84, the entire molecule that was or is approved for hypoparathyroidism. And I don't know where to, here we go. And so the issues are that Forteo has never been approved for hypoparathyroidism and is relatively short acting. So if you take it as a subcutaneous injection, you typically have to inject several times a day. And Netpara, which was approved 10 years ago or so, it has been recalled, and the production, as you know, is going to be discontinued at the end of this calendar year. And so, fortunately, I don't know if I have to wait or click. Here we go. So the first two options, one is really difficult to obtain, and the other one will not be available as soon. We have two long-acting PTH analogs and others actually in the pipeline, and you will hear about them. As we know, pelopactariparatide, or Yorvipath, has been approved, and eniboparatide is in phase 3 trials. They are different than the short-acting ones in that they work over more than 24 hours. They're also daily injectable, as many of you know, and many of you have participated in or are participating in these clinical trials. So let's see, here we go. So this is Yorvipath, the structure, taken from the prescriber information that is available online. And you see the snake with the amino acids, the 34 amino acids, the same one that Forteo has, but this is a prodrug that is connected to the left side to what is called MPEG, polyethylene glycol, through a linker, the transcon linker, that once you inject this prodrug that is inactive, the linker will release the PTH 1 to 34 in kind of a pump-like continuous way, and that works over many days, and that's why the advantage over the short-acting PTH is that you have a PTH action throughout the day. And here you see from two different studies the drug blood levels of the PTHs. So on the left side you see PTH blood levels over 24 hours. And even if it's very small, you can see that the levels actually go down to almost zero after 12 hours. Compared to the right side, Yorvipath, TransCon PTH, has drug levels that are actually pretty constant over 24 hours. So this is a huge difference between the two. And many of you are familiar with the results of the phase 3 trial of TransCon PTH, and I'm sure there are other talks during this meeting. You see on the left upper side, the serum calcium is elevated, into normal range. Despite that, actually, the urinary calcium on the right upper side drops. These are the tile-colored figure in the group on TransCon PTH. And the lower figures show that the quality of life is actually higher in the group that was randomized to TransCon PTH. Just a slide about enoboparatide. The phase 2 trial data were published, and they show in a small group of patients with hypoparathyroidism very encouraging results. You see here on the left lower side in green, the 24-hour urine calcium, the mean calcium goes down into the normal range. And on the right side, you see those patients who started with a high urinary calcium all end up actually with 24-hour urine calciums in the normal range. So it is very exciting to have actually potentially more than one drug available at one point. And so here is the question. If I switch from either Forteo to the currently available and approved drug Yorvipath or Natpara to Yorvipath, how should we transition? And a similar question will be or might be also coming up if enoboparatide is approved in the future. So first, let's look at the available data. Can you go back one slide? 2 slides? 1 slide? Yeah. No, go forward 1 slide. Stop here. So here you see a summary of the available data. You see the interesting figures, and all the papers are actually written there on the bottom. So I could end here. So there's no data, right? And I'm not only saying that, I wanted to emphasize that what I'm telling you is background about how these PTHs work and what I would recommend. But first of all, there's no data. Secondly, it has to be individualized, right? We know this very well. Excellent, thank you. So good for whoever controls the slides to hit it there. Next slide. One little side remark is what will happen when you are on PTH over a long time and then you simply stop it, right? Many of you know that this is not a good idea, and but some people actually are doing fine if you just take again calcium calcitriol as you were taking before the PTH. So I've had patients in the past who had done this, and some are doing fine. Others require much higher doses of the calcium and calcitriol. And I'm not saying, instead of 0.5 micrograms, you need 0.75 or something. No, maybe 3 micrograms or something, right? I mean, enormous amounts. There are many, many problems and questions about this. One is we do not know who will be affected with these higher requirements. So we cannot say, you were on a higher dose of PTH, maybe you need this, or you've been on longer it, or you're younger or older. We just don't know. Or bone turnover markers is one thing that we look at, maybe those with higher bone turnover markers. Nothing really has panned out so far. Secondly, it typically doesn't show up the next day. So, many of you who had been on PTH might have forgotten one day or not able to inject. Yes, you might have a lower calcium the next day, but typically no crash, right? This takes a little longer, 2 or 3 days or so. And then one of the another huge problems is, so those who have higher requirements of calcium and calcitriol, when you crank up the calcium and calcitriol until the calcium levels are acceptable, we don't know how long this higher requirement will last. Will it last a few days, a few weeks, a few months? It is important for many reasons, one of which is if you no longer need it, but you're still on it, you will get hypercalcemic. Right? And so saying, oh, check in a month, well, maybe that's a little too long, right? Check in a week, sure, but it is a really, really difficult problem. And hopefully none of you have to go through this. And also we are all well aware of the almost PTSD that we developed after this Hypopara not being available, right? And fortunately it has been available until now. We are not quite sure why this is the case, this whole thing with the higher requirements, but we think it's due to the hungry bone syndrome. So next slide. It's a little hard to see, and you don't need to see everything, and I don't have a pointer, so it's a little hard. This is a publication by Dr. Gaffney and colleagues from the NIH who summarized the experience of 8 patients who were on 1 to 34 over many months and then stopped. And so each of these columns is one patient, and if you just concentrate on the left column, on the upper row, you see the elemental calcium that is needed. There's a tiny little dot below the 2,000. That's what the patient was on before. The gray bar is the transition, the tapering of the PTH, and you see the calcium requirements went up to like more than 5,000 milligrams. I don't know if you can see it, it's an enormous amount. The next row for this left column is the calcitriol. The pre-PTH dose was 0.5, and during this hungry bone syndrome, it was 2.5 or more. Right? So you get the sense. Because it's so hard to read, actually, we'll just skip the rest, but remember this has been published. Next slide, please. And so let's talk about the bones. So bones are not as dry as they appear. They're not kind of a dead thing that makes us walk, but it's a very lively organ. It is almost like when you look from the space on Earth, you think, okay, it's a nice little blue ball, but then you kind of get closer and you see tons of structures, people running around, all busy being at a conference or running around. And so it's similar actually in the bone, right? And so on the left side, you see a bone, which has the bone marrow inside. There's the so-called epiphysis on both sides, which is the growth plate that makes us grow with chondrocytes that know exactly how long they want to be, and then they close and we no longer grow. There are bone-forming osteoblasts. There are bone-eating osteoclasts that are always working, like a bridge that's being repaired. Somebody crabs it off, the next one comes in and puts stuff over. And then there are the osteocytes in the middle of the bone, which kind of are the conductor. They say, do a little more here, do a little more there, oh no, slow down. And so all this is going on, and all this is also under the control of PTH. So it not only gets our calcium levels up, it does actually a lot to the bones. Next slide. Thank you. So this is a section of a bone that was stained with a stain called trichome. And the red one is the so-called osteoid. What is osteoid? That is newly formed bone that consists of proteins and all kinds of structures, which has not been mineralized yet, meaning calcium and phosphate has not been put in. And remember that the bones are the richest organ of calcium actually in our body, right? It's like an ocean, it has a ton of calcium. And so next slide. PTH does a lot of things that we just said, and so if it is stopped, there is less bone resorption, but still bone formation going on, and osteoid is being formed, and this unmineralized bone, osteoid, wants to be mineralized, meaning getting calcium in. And that is as if the bones are hungry for calcium, right? It's like a sponge that's dry and can actually absorb a lot of water. And so this rapid uptake of huge amounts of calcium into this hungry bone lets the blood calcium drop low, and therefore the doses of calcium calcitriol have to be increased. Next slide. So this is the hungry bone. Next slide, please. And now I want to talk about the fundamental difference between the short and the long-acting PTH molecules. And so we know that Forteo and Hypopara are shorter acting, and Yorvipath and enoboparatide longer acting. And that leads to a few things. One is for Yorvipath and long-acting PTH analogs, it takes longer to achieve the full effect, right? So you need a few days of daily injections until you have the full effect. It's a little different from Forteo or Hypopara. It kind of works the first day already, more or less at maximum. And it also takes longer to stop, right? So if you were to stop it, it will take a few days actually to calm down. So it's a little bit, and we can have the next slide, like a motorboat versus an ocean liner. So a motorboat, like the short-acting PTH, is very quick, right? You change the course, it's very quick. Next slide. But the ocean liner, you change the course, well, you have to wait a few days until the course is changed, right? And so that has several implications. One is if you change the dose of Yorvipath, typically you want to wait. And what the prescriber information says is like 7 to 10 days. You don't want to say, my calcium's not high enough, next day I go up with the dose. You should not do this, right? That is different from Forteo and Hypopara. And I know that some of you who are used to these short-acting and are used to kind of reacting to what is needed, you have to kind of relearn a little bit how to do with these new medications. Next slide, please. And so here now I put some graphics together, and I hope that you can understand them actually. So these arrows here are the daily subcutaneous injections. In blue, that is a short-acting PTH. So you have the first arrow to inject the PTH, and the calcium, here in blue, actually goes up pretty quickly. And when you stop it, it goes down quickly. Versus in the bottom, in the red, the long-acting PTH, you inject, and you have to have daily injections until you get the full effect, right? I hope that this is visible. Great, next slide. And so here is now some practical considerations for Yorvipath. One is how to do the transition. And this is model number 1. So in blue is the short-acting PTH. Let's say Hypopara, daily subcutaneous injections. You inject on Saturday, you inject on Sunday, and then on Monday, you no longer inject Hypopara, but you start with the Yorvipath, and Monday, Tuesday, etc., right? That is possible. The issue here is that to have the full effect of Yorvipath, it will take several days. And by the way, this is not to scale, so don't take every day literally here. This is just to demonstrate. And so you might have a period at the transition where you're more likely to be hypocalcemic. And during that time, there are several things you want to do. One, you want to have calcium, and if your physician agrees, calcitriol at the ready. And the second one is, of course, checking calcium. How often? Well, as often as possible and practical. So you want to have a standing order from your physician, so you don't have to call or wait and stuff, but you just go to the lab, right? And I know that this is easier said than done, because sometimes the results take much longer than you want, but at least you have some values. So this is model number 1 for the transition, which is fine to do, yet you have to be very careful about this time of the overlap to be ready that you might have hypocalcemia. Next slide. So model number 2 is with overlap. And again, this is not to scale, right? It's just as an example. So what it means is you have Hypopara here in blue, Saturday, Sunday, Monday, and you start on Monday, the Yorvipath, you inject both Natpara and Yorvipath, both in the morning. Not in the same syringe, two different spots. And what the potential advantage here is that a possible hypocalcemic episode, as you see depicted in Model 1, might be reduced in this Model 2, right? You could say, well, 1 day overlap, why not 2 days overlap or 3, right? It might be too much and you might become hypercalcemic. Now, some of you I know are very engineering-like. You might say, well, why not decreasing the dose and overlapping? Great idea. There's no experience about this, but I wouldn't be too complicated, right? So like 1 day overlap actually sounds another reasonable option to me. Which one to choose? Well, you have to work with your physician, and it depends also on how easy your calcium levels fluctuate, how high it was, or it is actually. If you have a robust calcium level, you are less likely to develop hypocalcemic symptoms, right? So these are this is kind of the main message I wanted to leave you with. Next slide. Yeah, so this was the overlap. Now comes the second part, and that is the dose of the Yorvipath, right? So I assumed like the first dose, as you know, it's 18 micrograms, is the dose that you will end up, but it might not be. It might be too low or too high, right? And so that is then very similar to somebody who starts on Yorvipath, right? You also have to check your calcium at least every 7 to 10 days after a change. You don't want to switch the dose unless absolutely necessary before about a week, right? And then there are these kind of theoretical scenarios. So here, the dose of the Yorvipath was exactly the right one, the first one, the 18. Next slide. Obviously here, you made a nice transition, but the dose is too low, right? So you have to increase the dose after a week of Yorvipath in red. And the next slide, so this 18 micrograms was too high, so you have to lower that at one point, right? Next slide, please. And so just to repeat, everybody's requirements are different, individualized. Next. No published data or recommendations yet on the transition. There was an abstract at a conference from Dr. Sigelkopf in Germany, where Yorvipath had been approved much earlier, and so they have some experience, and there's a case series that she will soon publish. Measure calcium with albumin to adjust it frequently, especially during the first weeks. Next. A preferred day of the start of the transition is a Monday. You know why, right? It's always Fridays that something happens, and then the labs are not available, the physicians are gone, and et cetera, right? So I'd start on a Monday. And yeah, so we talked about the two issues. One is the transition itself, and the other one is the finding the right dose of Yorvipath. Next. And again, because it's long-acting and needs some time to build up, we don't want to change the dose earlier than 7 days. Next. Yeah, and so for most people, the adjustments might be done within the first few months, right, of the Yorvipath. Okay. Now, now come a few tables, and I'm not 100% sure if we should go through the details. It's also, first of all, there are lots of data, and then they're also relatively small, and I know when you're sitting in the back, it's really hard to see. But the message here is the following. There are so-called prescribing information that you can see online, which have very detailed tables and recommendations as to how to adjust the dose. This is made for someone who is starting from scratch, so not on a PTH analog before, but there are, of course, similarities. And so this is what you do with calcium and calcitriol, if somebody has been on calcium calcitriol, depending on their starting albumin-corrected serum calcium, right? So more than 8.3, between 7.8 and 8.3, and more than 7.8. And then depending on the current dose of calcitriol, so let's take the first row. If your calcium is more than 8.3, or equal to 8.3, and you're on a relatively high dose of calcitriol, more than 1 microgram, then you want to reduce the calcitriol dose by at least 50% the day that you start your Yorvipath, and you maintain the calcium dosage. This is different from somebody who is on less than 1 microgram or 1 microgram. There you can actually discontinue it, maintain the serum calcium, which can then, the calcium supplementations, which can later be reduced. And so you see that for every scenario, there is kind of a recommendation here in this table when you start it. Next slide. Now, this and subsequent slides are the follow-up titration of the Yorvipath and active vitamin D and calcium. And so if, like a week later, albumin-corrected serum calcium is less than 8.3, and you have waited 7 days, then you want to increase the dose of Yorvipath by 3 micrograms, leaving the calcium and calcitriol supplementation unchanged because your calcium is too low, right? Makes sense. Next slide. If your albumin-adjusted calcium is between 8.3 and 10.6, which is a reasonable target range, and you have waited 7 days, and you're still on active vitamin D, then you decrease or discontinue the active vitamin D and increase your Yorvipath by 3 micrograms. If you're not taking active vitamin D but calcium and a high amount of supplemental calcium, you discontinue the calcium and increase the Yorvipath, right? And so you can find yourself through this somewhat complicated looking, but actually a good guideline that you can look at. And obviously, it is your physician and you who will decide what actually to be done, because there are all kinds of scenarios that might not be reflected in these relatively simple recommendations. Next slide. Yeah, and this is when the calcium is too high. Obviously, then you want to get rid of calcium and calcitriol. And if you are no longer on calcium calcitriol and it's too high, then you have to lower the dose of the Yorvipath, right? Which makes sense. Next slide. Good. So in summary, it's really exciting to see new drugs being developed and being approved. As we have seen from Natpara, it's really a good idea to have more than one drug available on the market. When you switch from a short-acting PTH to Yorvipath or other long-acting ones, you want to individualize, you want to follow the guidance of your physician. And I realize that sometimes you might be the guidance, you might know much more about these very specific situations, and you want to be gentle with your physician. And at the end, physicians always feel good if they think they have been the decision maker. A short overlap between these two drugs, like for a day or so, I think is okay. Frequent checking, titrate Yorvipath slowly, and don't be afraid. You can do it. The EAP, the EAP for Yorvipath, the unpublished personal communication results are very positive, right? So people have been able to do the transition, and so will you. Thank you.
All right, we're going to take some questions. Thank you so much. And let's go Michelle, and then we'll get a microphone over there.
For someone who is only supplementing and not on any PTH right now, do you recommend they go ahead and start Forteo now while waiting for Yorvipath to come to market, or just wait for Yorvipath?
Yeah, that's a good question. It depends a little bit on your situation. Do you want to start Forteo now and then switch to Yorvipath once it's available? It's a decision you have to make. I'm sure you can do this. Just remember, though, that transitions, some people have a very easy time, others need more time together with their physician, right? Also, you don't want to have the physician worry about you too much for the transition, finally finding the right dose, and then you want to transition again, right? So there are advantages, I think, to waiting. But if you cannot wait, fine, go ahead.
Okay. Katie?
I don't know if this is the right time to ask this, but I don't see a more appropriate slot in the agenda. So this is my question. It's fear-based. I had Natpara taken away from me, and my life shrunk. You know, I got my legs cut. Now I'm back on a drug, and it's working. But there are multiple. There's Yorvipath. There's Calypso. There's one where you inject once a week that they're working on. There's one where you can take pills. And maybe I don't understand the financial component of this, but I thought at one point, and it seems like every month there's like 5 new people that are added to the Hypopara group. So I don't know how many of us there are, but and one of these drugs I know won't work for me. So my fear is that there's going to be a bloodbath between all these companies and there won't be enough patients. And I know too that it was available when I had my surgery. I think a medical student developed it, but it hadn't gone through all the tests. And now there's something where they're still working on it where they can there's like a blue light where they can see your parathyroid, so they might not accidentally surgically make as many of us. But I'm just wondering that at some point there won't be enough of us to divide over all the drugs, and then some of them are just going to fall by the wayside, and I might get stuck with the one that doesn't work well for me. So how can they all make money on that? That's my fear, that I get my legs cut off again, basically.
Well, listen, I don't have any answers.
I know you don't. I know there's a venture capital person in the world in this room. I don't know. I mean, I don't think they'd be funding these drugs if they didn't think they're all going to work, or I don't know. I just worried. That's the fear that I have.
I understand, but Liz, we can see if somebody else has a more nuanced position on this. But in general, I actually mean it. I think it's really good to have more than one drug, right? And you know that nowadays rare diseases are a field where there's a lot of investment and a lot of enthusiasm and a lot of motivation actually for treatment for diseases that are way rarer than hypoparathyroidism, right? So if we say we have, about 100,000, or we heard this morning maybe even more patients around, this is not at all an ultra rare disease. And so I am personally not worried at all. And I know insulin is not the best comparison for type 1 diabetes, but you know that over the 100 years that we've had insulins, they have developed from a very crude pig insulin. There was nothing else available to now, and even as an endocrinologist, they have to keep up with the names of different long-actings, short-actings, intermediate-actings insulins, right? And I know that this market is much higher, but I see it actually as a really fantastic time that drugs are developed, even much longer acting drugs. Well, we'll see how they fare. I think it's more optimistic.
That's part of our PTSD reaction, right? Like after Natpara. So, but I'm personally believe it will be perfectly fine. These guys are ready to make us some drugs. Very good.
I'm Kendra. I'm a caregiver for Sissy. But the question I have is, she's on Natpara, so we have to swap. We have no choice. So what we've been hearing is that it could take a year or longer for it to really take effect, and that it comes with a lot of pain. I don't know if that's really a question for you or if that's somebody that's swapping, but is that something that we're going to have to kind of be looking into? Or, what is it that we need to kind of watch with her?
What do you mean with pain?
They're saying like the bone pain's like excruciating to swap the medicines.
Mm-hmm. I'm not really the best person to answer that. It's the first time I hear about this, so somebody else needs to explain that. But the transition has been done by many people, right? So not sure that there are big barriers. Of course, the physician has to work with you, right? And so it's not easy. As you know, physicians have no time, as was said today several times. You come a list with many different things, right? It's overwhelming not only to you, to your physician also. So you have to be, of course, working with the physician and make it actually easy and being a little optimistic also about this, right? And having, from all the different questions you have, kind of concentrate on one or two main questions so that they don't get lost, right? And for the transition, it's how do we make the transition? Here's what I hear other people do, check calcium every day or every 2 days or something, right? And we would be happy to do this. What do you think, kind of thing?
Michelle, let's go online and then we'll go right back there.
Real quick before I give one from online to what she just asked, I think the bone pain from what we see is coming more from patients who were coming from standard of care to the URV path. And then there are people in Germany and stuff that have transitioned from the straight from the NatPara to the URV path successfully. So as he said, there is already cases where I don't believe it takes a year. They've transitioned and it's been fairly quick. So online, they are asking, there's actually 3 people, wow, that are all on the NatPara pump. And hold on, let me go back to this. Is it different transitioning, basically they're saying from the pump then versus if you were just taking the injection?
That's an excellent question. Yes, I did not mention it, the pump. So as many of you know, there is the theoretical advantage of having an insulin pump with PTH, Forteo, or NatPara, and giving this under the skin like an insulin-dependent diabetic, where you have pulses of PTH coming all the time, almost like the normal parathyroids, right? And so this has been done. This is not FDA approved, but worldwide there have been many physicians and patients who have been doing that. I have several patients on the pump with pretty good results, yet it's very involved, right? You have to know about the pump, the mechanics. It's not always you slap on the pump and then you can forget about it. Not at all, right? There are different pumps. The ones that we use, you have to change something every 3 days. Mix the insulin with sterilely with sodium chloride or water. So it's not that easy. Plus, you have to have a physician who feels comfortable doing that, and hopefully a nurse also who can help, who feels comfortable with that. And so overall, there are very few patients on it. But how to transition is a good question. I would suggest an overlap of about 1 day, similar to what I said at this model number 2. And you can even lower the rate accordingly to the measured serum calcium. What I mean by that is on day 1, you continue the pump and inject the long-acting PTH. On day 2, you will lower the pump rate while measuring the calcium, and on day 3, you might get rid of the pump or if you have symptoms, you continue it a little bit, right? So similar to what I say, have calcium and calcitriol ready. Here you have your pump that you can actually direct.
Okay, Bob?
Two questions. One, I know, and I forgot the specific data points. We kind of chuckled at them where there was not a lot of data available, maybe towards when people will come off, what they experience. Do you have a time cycle of when more data would become available for some of those points that we kind of glanced over? And if someone would like to become a part of a trial, is it geography dependent? Like, do you have to be in a certain area in order to be available for the trial?
Yeah, so the first question is about data available for when PTH is withdrawn?
Yeah, I had it in my brain and it
the white slide.
Me, but the white slide,
the
right?
White slide, excellent.
So
yes, so, right, so this is a very good question. Will we ever have data on the transition available, right? So while I'm an optimist, I don't think there will ever be a clinical trial, a rigorous trial being done. It will all be people do it, and then we ask questions. How did you do it? How was the calcium, etc. So case reports, case series, meaning somebody says, yep, I have, here we have observed 10 patients, they did A, B, and C, and this is the result. This is good data to have. It's not the most validated and strongest data. So if we are lucky, we'll have that. And this one physician I mentioned, she told me that she submitted a paper describing her experience, actually.
Right, and so with that, I couldn't see the legend on some of the earlier bar graphs, but one was, I believe, quality of life was one of the things on there. Was that measurement related to that? Because I'm like, how did you measure or gauge quality of life improvement from one to the other?
This was not a transition from PTH to another PTH. That was a group that received, in this case, Yorvipath, versus a group that did not receive Yorvipath, but was on calcium and calcitriol. And the ones on PTH, on this PTH track, had higher quality of life measures in several instruments.
Okay.
There was a clinical trial, a phase 3 clinical trial.
Okay, and then just my last one was with trial availability, is that geography dependent?
Yep. So for all clinical trials, or for most clinical trials that are multi-center trials like the ones that we talked about, it's an advantage to live close by a study site. You know, there is clinicaltrials.gov, a website that contains most clinical trials and their geography. And so you can either go there or you can just ask directly a contact person through that website. I live X, Y, and Z. Is there a clinical trial available? There are some clinical trials where you can actually fly to the site, even if you live far away. But that really depends on the trial.
And we'll have a segment tomorrow on clinical trials where we'll talk about that from a patient perspective. Question over here.
Hi, Dr. Mention. For patients who are in standard therapy for hypopara with calcitriol and monitoring and do reasonably well, but occasionally have breakthroughs that require hospitalizations or emergency room visits, given the risk factors, the complications, the comorbidities of hypopara, are there recommendations for switching patients from the standard therapies over to a PTH analog?
Yeah,
like
this is an excellent question. The question of kind of who should be actually on PTH treatment is one that the answer shifts over time. The answer was different 10 years ago from now, and I'm sure in the next few years will be different also. In that we have better drugs available now, we get more comfortable about them, we know how well they work, and so overall I think there's more a trend of recommending to consider PTH treatment earlier than we had in the past. The official recommendation from the Hypopara guidelines is first-line treatment is calcium calcitriol, with the additional sentence in patients who are not well controlled, you should consider PTH. And the label for Yorvipath does not say available for patients who have not well controlled hypopara, but it's for all patients with hypopara who are not immediately post-op and who are adults, right, and not pregnant. So I think I would consider PTH treatment for most patients. There are some who are really well controlled, don't seem to have any problems. They should know about it, but they might not need it. And we also learn with rare diseases like hypopara, sometimes when you see a patient for 10 or 15 minutes and you ask if everything is okay, and you wait for the little nod, you might never find out what the problems are, right? And so, I'm sure there are many people who can talk better about this, but I have people who on PTH feel so much better, even things that they didn't realize was possible, right? So it's not a very straight answer, but.
covered right now, all of them under clinical trials, or they have to go through insurance? And if so, will the insurance put up barriers in terms of prior authorization, having to go through standard treatment before you get to a PTH?
Yep. The question is about, the question is about insurance coverage, right? What is the experience? So your VPath is FDA approved, but not available outside of the EAP program yet. And so I have no experience with how the insurance handles, and I'm sure people here will contribute more to what I'm answering today or tomorrow or in discussions. But typically, if a drug is approved, it goes through prior authorization, typically specialty pharmacies, et cetera. And yes, there can be hurdles. Some insurance have no questions, others have tons of questions. The physician might have to intervene, letters have to be written, sometimes even a telephone call, rarely, with a physician working for the insurance, all these things. They are worse in drugs that are not FDA approved, like Forteo, right? And it had been approved in the past for 2 years in osteoporosis. So even if you got it for Hypopara, after 2 years, they said, oh, that's it. And so you had to intervene and talk to the insurance, et cetera, right? With FDA-approved drugs, I hope it will be easier and more straightforward.
Okay, we're going to go to just one more online question, and then we're probably out of time.
Okay, real quick too, I want to let you know that if you have more questions about coverage and programs and patient assistance, please attend the Your VPath meeting this evening, because they are going to have someone there to discuss that piece of it, the insurance piece of it. There is someone online asking, so if your calcium levels are normal, you're on standard of care and your calcium levels are normal, but you're still very symptomatic, would PTH be the answer?
Wow. If this is the last question, it will be tough for me to answer.
Sorry.
No, that is fine. Michelle can also, if you want, contribute, some experience about this. The question will boil down to two things. One is apart from your calcium that seems to be normal, are there other things that are not normal, right? We heard about magnesium, we heard about phosphate, also the swings in calcium, right? If you measure calcium once every 3 months, well, you will never know what the calcium will be at 2 o'clock, 5 o'clock, 10 o'clock, et cetera, right? And then the second, this is one, and that is relatively straightforward to explain, hard to implement. This second possible hypothesis is, well, even if your calcium level and everything else that we measure is fine, maybe it's the lack of PTH that makes you having symptoms. I know that there have been lots of talks and even seminars about this, right? I personally need to be more convinced about this with data. For instance, what is your calcium level measured every hour over 24 hours, right? Because then we can see if it is actually relatively stable and you still have symptoms, well, it must be something else. But if you see kinds of up and downs, well, then maybe that actually is the reason.
Yes, and just to add to that, yeah, you and I had a very long talk about this. Basically, I want patients to understand that that test you had once every 3 months is a moment in time. And what that test showed was what you were for that moment. You may not be that 30 minutes later, 4 hours later, 6 hours later. So that data is very important. But I will also say from personal experience that I had symptoms I didn't even know I had until PTH took them away. And we need to be very cognizant of the fact that this is a PTH disorder, not a calcium disorder. So what is the harm in replacing the hormone I am missing?
And just to add this, that's the beauty of the conference, right? You learn, you come with certain thinking, this is how it is, but then you hear actually the real experience. And so I really appreciate it. Thank you.
All right. Well, thank you, Dr. Manstaff. Great thing. All right. We are going to take a break, and we will be back at 3:10, ready to go. Have a good break. Welcome back, everybody. Hope you had a great break. So I'm excited to announce our newest kid on the block to join us today. Michelle and I went out to their offices out in San Francisco this past year, and what an honor. We got to speak to their entire organization and really just share what hypoparathyroidism is about, and again, to help them understand their why. And I mean, they couldn't quit raising their hand with the different questions, so it was really very exciting. So we appreciated that opportunity. Today, speaking for Septerna, we're going to have board-certified cardiologist, Chief Medical Officer at Septerna, Dr. Jay Kim.
Thank you. Thank you, Patty, Michelle, Bob, and the Hypoparathyroidism Association for the kind invitation for Septerna to come here today. My name is Jay Kim, Chief Medical Officer of Septerna, and I'd also like to introduce you to Julie Wilson. Julie, you want to stand up? She heads up product strategy and and patient advocacy at Septerna. I'm having a lot of luck here. Oops. Let me, I have to disclose I am an employee. I own stock in Septerna. So who are we? Septerna is focused on discovering and developing therapies targeted to G protein coupled receptors. We hope to usher in a new era of GPCR targeted therapies. We're founded by preeminent scientific leaders in this field. Our scientific advisors include Bob Lefkowitz, who won the Nobel Prize for his GPCR-related work, and we're headquartered in South San Francisco, California. Our innovation is based on our native complex platform, which I'll describe to you in just a little bit, and it is the engine to make these innovations happen, moving ideas from disease-modifying therapies from possibility to reality. Our first program is SEP-786, which is an oral small molecule agonist of the PTH1 receptor for the treatment of hypoparathyroidism. So why is targeting G protein coupled receptors so hard? Well, it's in the small molecule drug innovation area, there have been so many new developments that help us develop medicines for patients in need. But these innovations have largely been inaccessible to people trying to develop therapies for GPCRs. So really the root of it is because GPCRs are complicated. You can't just have that receptor protein by itself. It needs to be a part of a complex for it to be functioning. It's kind of like saying, I want to, improve an engine, but just taking a part of it, right? So the G protein coupled receptors are these complicated 7 transmembrane protein receptors that requires what it binds to, called the ligand, and also its associated G proteins. And all of these within what's called a lipid bilayer, or part of a cell membrane. So Septerna has been able to isolate and make these complexes and have them wholly functional, and they represent the biologic activity of the fully functioning unit. And by doing so, we can take these functional complexes and we actually create high resolution structures, which serves as kind of like a roadmap to identify novel binding pockets for chemicals and new drugs, and enables a smart structure-based design. We can also apply these to screen, and here I'm going to emulate my inner Carl Sagan, billions upon billions of chemicals and physiochemical interactions, and we can apply what are called in silico or computationally based drug searches, looking at billions of structures, and also DNA encoded libraries. So these are really industrial workflows, high throughput processes, so we can identify great drugs to what the roadmap had revealed itself, in the form of these native complexes. And then we could use structure-based design and optimization. With these candidates, we can identify what are the best drug-like features. And, at Septerna, we've had just incredible luck using this process in identifying new drugs, and it often takes less than a year from the time that we've gone from native complexes to a drug that may be worthy to test in humans. So, the first disease that we decided to tackle was hypoparathyroidism. Now, the people in this room could teach me a thing or two about hypoparathyroidism. So, it's not worth your time for me to go over these. But what is just an incredible learning, and also observation from all of you, if you look at your little cards there, that we're in a veritable renaissance of innovative therapies for this disease. And I think, Liz, you mentioned a question about, are we going to suffer because of all these drugs? Actually, having developed many therapeutics in rare and non-rare indications, there has yet to be a disease that did not benefit from people developing options for patients. And here, every drug that comes to become available for patients adds to therapeutic options. Here at Septerna, what we are working towards is providing a therapeutic option for hypoparathyroid patients in the form of an oral small molecule therapy that is an agonist to the PTH1 receptor that could take the form of a tablet that's taken once or twice a day. So how do we do this? Now, I think I forgot who I was talking with before, but maybe it was you, Sissy. I'm not too sure, but yeah, I forget. But I think someone asked me, "Oh, wait, do you work on that drug that was licensed from AstraZeneca or something?" But I was like, "No. Well, we're working on 100%, full-blooded." In-house Septerna innovation, where we are developing these drugs from scratch. And here for the investigational drug we're developing for hypoparathyroidism, it started with with this native complex that we talked about. Now, one of the things is why we targeted this receptor and this disease as our first candidate was it has been known to be notoriously difficult. Industry has been trying to develop small molecule drugs to do just this. And with the native complex platform, we've identified multiple hits and potential binding pockets that have heretofore never been worked on before. And with that, we applied the native complex structure-based drug design, as we had mentioned, and in about a year or so, we've optimized a candidate for great drug-like properties, and it led to an investigational drug that we called SCP-786. And we actually ran it through a battery of tests, one of which was a fairly well-established animal model of surgical hypoparathyroidism. It's when you take rats, and it's called the thyroid parathyroidectomy model, where they remove the parathyroid glands, and they develop hypoparathyroidism with chronically reduced calcium, and we treated with our agonist SCP-786. And on the right panel, you see the effect on serum calcium after single doses. And what you see is really what we consider drug-like effects. That means a dose-dependent increase in serum calcium, and we're able to normalize serum calcium within the normal range with single doses, and also to see how much we could push the pharmacology. We made a comparator to a long-acting parathyroid hormone peptide, and to push the doses all the way up until it's above normal calcemic range until you reach the plateau effect. So in this single dose animal study, so to speak, we're able to show the full range of pharmacology with this small molecule up to what is achievable with parathyroid hormone peptides. and with multiple dosing, that is sustained dosing twice a day, and we chose twice a day because in rats, the half-life was only 4 hours for the drug, and that means the amount of time it takes for half the concentrations to go away. Rats have this notoriously fast metabolism, so they chew up drugs very quickly. But we dose these rats twice a day over 28 days, and here in these little blue triangles, and you see this gray bar indicating what's a normal calcium range in rat, and that we were able to achieve sustained calcium control in these rats. But not only that, that sustained calcium control was achieved by its effect of our drug on the target organs. That is to say, we evaluated bone turnover markers, and to show that an increase in bone turnover markers, and also the effect on the kidney, we're able to see a decrease in serum phosphate due to phosphate excretion, and also an increase in active 125 vitamin D production that comes from the kidneys. So not only did we show a normalization of serum calcium with our investigational drug, but also that was achieved by its effect on the receptors on its target organs in the bone and kidney. So heading into human studies, there was a thorough evaluation in preclinical and non-clinical studies. And for my part, these were confidence-inspiring. The drug's metabolism and drug behavior, called pharmacokinetics, we evaluated these features in mice, rats, dogs, and monkeys. And the totality of this evidence suggests that the predicted human pharmacokinetics is such that SCP-786 would most feasibly be dosed once or twice a day. Also, we ran it through the usual battery of what's called GLP toxicology studies or toxicity studies. And it's a requisite part of drug development that we dose animals to excessively high doses as high as feasible, to make sure what happens in that setting so that we can navigate such things in humans. And what I'm very happy to say is that the toxicity studies showed that our drug was generally well tolerated after 28 days of continuous dosing. Now, the only thing that was really observed was what's called excessive pharmacology, which is when you have an on-target effect, the intended effect of your drug, but when pushed to excessively high levels, you saw higher effects. So high PTH-related activity is what we saw in toxicology studies. What is very reassuring is that we haven't seen the kind of what we say off-target effects, or the kind of things small molecule drugs sometimes have these liabilities that have an effect on the liver or other organs that are unintended, and our toxicity studies did not show any of those. So with this highly reassuring non-clinical evidence, first, good behavior in animal toxicity studies, and also animal proof of mechanism to show that we can actually address the surgical hypoparathyroidism in these animals. We went ahead and proceeded, and we just recently initiated our phase 1 human clinical trial that's initially in healthy volunteers. Yay. That's in healthy volunteers, and to evaluate single and multiple doses with the primary evaluation of its safety, and also the pharmacokinetic behavior, and also the pharmacology, the effect of this drug on serum calciums and other markers. And we anticipate sharing this information mid-next year. So this is also, and just as Patty had mentioned and Julie facilitated this visit, it is our plan for the full life cycle of drug development with SCP-786 to be conducted with patient focus, or more appropriately, with focus on people living with hyperparathyroidism and their caregivers. And also We are looking forward to a fruitful collaboration with the HypoPARAthyroidism Association. And having developed multiple therapeutics in rare disease in the past, I can't tell you just how much the entire process is enriched by, by sharing the journey with people living with the disease and their caregivers. And at the outset, we're learning as much as we can about the unmet need and disease burden directly from talking with you. And we also expect and will be reaching out to you for your help in design of our clinical studies and with your input. And after the conduct of these studies, we expect to talk with you again and gather some feedback about how we could have done it better. But also, what's especially important is to get your feedback with the results of the data in hand to say, how do we interpret this benefit risk, of this therapeutic? And it helps us in terms of how we propose the eventual, approvals of the drug to be taken forward to patients, for real access, and then also to partner with patients and the healthcare for the advocacy groups with optimizing access to the drug and also with ongoing evidence generation. Advance. Thank you. So hypoparathyroidism is a beginning for us, and we are really intent on making it successful for you, the patients and the caregivers. But on top of that, it's just a part of our journey. We've started with hypoparathyroidism, but we have a deep pipeline of additional therapeutics across different disease areas, including immunology and inflammation, and other areas of endocrinology, including Graves' disease and thyroid eye disease, and also metabolic disorders. So with that, thank you so much for having us here today, and happy to take your questions. And we also, Julie and I are here, and we look forward to chatting with you in the hallways. So
Okay,
Julie, you want to come up?
questions? We'll take one here first.
Hello, doctor. I have a couple of quick questions that might not be that scientifically wonderful because I'm just a layman. The first question that I had is, Septerna has started with trying to battle hypoparathyroidism. What was the motivating factor to choose that for Septerna? And my second question was, using this process, if it is affecting the ability to regulate calcium, what effect does it have on other, I don't know what you would call them, but things like phosphorus and magnesium and other such parts that come along with this problem?
Oh, that's a great question, and please don't excuse yourself because your question was amazing. And so first you asked why hypo-PTH, and the other is what do we think our investigational drug might address for the disease, right? Well, first, why hypo-PTH? One, because it had a long track history of being difficult to target for a small molecule. The other is, as a rare disease, it's something that as a small company, can take the journey from beginning to end on our own. So we wanted to have, really our flagship initial disease that we target is something that we could take ownership for. Now the other, in terms of what we are targeting for the therapeutic value of our drug, we actually designed the drug to hit a part of the receptor in such a way that we reciprocate the entire biology of parathyroid hormone. So the way we're dosing it, the way we'll target it, the way we're going to try to match the pharmacokinetics is really is with the intent to replete the function of parathyroid hormone. To replicate the physiology and action of PTH in every respect. In every respect. That's our hope now. And I think, we have aspirations, and the design of the molecule is such that we hope the evidence will bear out that it could.
Hi, I'm Caroline. I had a question about, you said every aspect. So how are you going to manage variation in activity levels?
Well, that's a great question. Caroline, yeah, how do we manage the variability in activity levels? And well, that's one of the advantages of an oral small molecule therapy. As I had mentioned, with our pharmacokinetic studies, we think that we could dose this drug once or twice a day, and we'll see how the human data bears out, if our predictions are correct or not. But what that also means is that we can hit steady state activity in a couple days. So with this drug, we can actually, I think that listening to you and listening to many of you, there are different types of demands. And I was talking with Dr. Khan earlier as well. Some people like to exercise in the mornings, and where it places a greater burden on their systems. So one, it's a part of the journey of this drug to talk more with what patients' unmet needs are, and to see if there's a way of dosing this drug that might meet you with those unmet needs. So I'm sorry I don't have a declarative answer because the drug is still under development, but I think it's really in partnership with you and our dialogue that enriches this drug development, evidence generation. But maybe, Julie, you want to comment a little bit about maybe how, about our approaches in partnering with patients?
Yeah, so I think Patty already brought up our initial. We had just pretty much opened our doors not long after that. we were all scientists at the time. We're not anymore, but at the time, and when I say scientists, I mean biologists and chemists, not development scientists and statisticians, et cetera. And we brought them in because we really wanted our scientists to understand what patients go through. What is the patient experience? Why are we in the lab working so hard trying to find this drug? Needle in a haystack, I think you can kind of tell from how he talked about the process. And these guys came in and, like you said, our scientists were wowed. They wanted to know more, and I still get asked questions about it. We need to do it again, guys, so we're due.
Yeah. So we'd be happy to. Yes, and one of your scientists stopped us at ASBMR, and they remembered us from that talk and said, oh my gosh, I have so many questions still. And I was like, okay. But maybe you guys are the perfect example. There was a question earlier today about, the whole clinical trial process. You guys are our company that's come in the earliest in the game for us. And a lot of patients don't understand. So the question I'm referring to is the one that was, what did you mean by clinical trial versus phase 1, 2, 3? You're the first time we've been this involved and had somebody in front of patients that is just heading into phase 1, and you were just in preclinical. Maybe could you talk about how that timeline works and not too much detail, but just a high level of how that works and how it is going into a phase 1 and what it looks like. What is your anticipated phase 2?
Yes, well, yeah, you might not be talking with the ideal person for this because I generally see the rules and try to see if there's ways I can break them.
I'm perfectly okay with that.
Well, what I mean by that, that could come across in a really bad way. But what I mean by that is, I've been in rare disease, drug development for a while, and what I've discovered are that really every day counts, every day, and that when you can bring a meaningful therapeutic to people living with disease and their caregivers, with that in mind, that every day counts, you think about ways that you can innovate along the way. So I actually don't think of it in terms of phase 1, 2, and 3, because I've leapfrogged phases all the time, right? It's all about evidence. What questions are you answering? And so maybe just to share with you, from a drug developer's standpoint, the purpose of drug development is to understand the dose or exposure relationship with benefit and risk. That's what you're characterizing. So when we say phase 1, that is, Usually, when you dose the drug for the first time in people, in humans, and you could decide whether, depending on the situation, whether it's healthy people or people living with disease, and it's very situation dependent. But that's when you first evaluate the safety of the drug as you push the doses. And when you see a dose-like effect, that's when you say, you've got a drug. That's what defines a drug. It's a dose response. Anything could be a drug, right? But if it doesn't have a dose response, it really isn't one, So that's when you say, hallelujah, we have a drug, and then that's where the journey starts. And then you start building up your evidence for a justification of how you dose that drug going into what we call a pivotal or registration study, right? Whether or not you need a phase 2, it's all dependent upon the situation. There's actually no regulatory definition for phase 2. It's if you need something in between to help fulfill that evidence requirement before you go into a pivotal trial, right? In ultra rare diseases, sometimes you can just have one phase of development, keep amending a phase 1 from first in human all through pivotal, and then make that your registrational study, right? So that's why, for me, there's no rules, right? It's about evidence and how you can most quickly get adequate evidence to get your drug to move forward. And also, what is confidence inspiring for health authorities to review the package and say, oh, this drug is safe and has an adequate benefit risk to give to patients, right? And it's called, for the US parlance, it's preponderance of evidence of efficacy, right? So yeah, for me, so there are kind of set definitions of phase 1, 2, and 3. And sometimes when you're trying to figure out what the best way to get the therapeutic to patients as quickly as possible, those lines get blurred. But that might be a bit more complicated an answer than you asked for.
No, I think that it helps them understand. Personally, I think that's great. As a follow-up to that, can you tell our patients, if I might have missed it because I had to step out for 2 seconds, but do you have an idea of what this phase that you're in right now, because you guys are getting ready to dose your first human, or you have just dosed it in Australia? Did I understand that correctly?
That is correct.
You did dose your first human in Australia. What does this current timeline that you're in, what does that look like? Is this a 1 month, a 1 year, a 5 year? Because patients don't know. How long do these things take?
Oh, yeah. Well, so there's a limit to what I can disclose at this time, but what I can say is that we are definitely in the first in human study in phase 1 of development, and we are evaluating what the safety and pharmacology is of the therapeutic and in single and multiple doses, and that we will be sharing those results mid next year. And I think we'll be better prepared at that time to share what the rest of our program might look like.
Okay, and then one more real quick that just came in online. It says, how long, I don't even know if I understand this, how long is the intracellular action of this drug?
Well, how long is it intracellular action? Wow, this is complicated biology. Well, I think so. I'm interpreting that question as so a drug's effect, right, is evaluated by both what's called pharmacokinetics, or the concentration, how the concentration of the drug behaves in blood, like how the concentration rises and falls after you've taken it by mouth, right? And then there's the effect of that drug. Sometimes the effect of the drug can be longer lived. That is, the effect on the cell itself can have, longer lived actions on calcium, right? And so I think, in terms of what we've seen in animals is that the effect on calcium is a bit longer than what's in the blood, but not too much longer. So I think what that helps is that we can actually use how we dose the drug by mouth as a good indicator of how we're achieving steady state and so forth.
It's a great question, though, you asked about the timing of the phases. I mean, there is a standard 1, 2, 3. A lot of drugs do, the majority, I think. And the time, though, really differs. So if you think of something like osteoporosis, where you're trying to measure whether a drug keeps the bone from breaking down over time, those trials are very, very long. And then hypopara, wouldn't you put that on the shorter end of time in general?
Yeah, maybe to help you walk through the journey of what it's like to develop these type of therapeutics. So you kind of usually classify them as, one, drugs that are intended to treat those that are immediately life-threatening, right? Versus those that are used to treat chronic conditions that are not immediately life-threatening. I raise that point because if you're treating a chronic illness, that I would classify hypoparathyroidism as a part of the evidence that you have to say is that your drug is safe and it works for at least a year for however many patients that is acceptable to the health authorities, that is FDA and EMA, right, and other health authorities where you want the drug to be available. So usually one requirement in that drug development process is to say that, okay, we took X number of patients with the disease and we treated them continuously for a year, and then that's used to fulfill that minimum criteria for safety for a chronic drug. So we have to kind of figure out where that falls in, and so that tends to be the, quote, limiting part, is that you have to at minimum satisfy that part in addition to what might be required timeframes to show efficacy. Because you can say it doesn't take very long to show that you're feeling symptomatic benefit from hypoparathyroidism. So there are all these, they're called statutory requirements for when you're developing drugs, and that tends to be one that we think about a lot in advance, is how can we build in that 1 year of safety, and that's the sliding part of that timeline. I don't know if that answers your question, but
It definitely answered my question. I want to make sure, is there any more from the audience? Okay. Yeah.
I'm wondering why you picked Australia.
Liz, it's up to you to ask the hard questions. No, it's actually there are many great places to do phase 1 first-in-human trials. We conduct them in what's called professional phase 1 units, and especially for small molecule drugs, you have to have a very, very careful time course, and it's like it's almost like being in like NASA, right? They have these like time clocks everywhere, and everybody has on a very regimented, blood collection and markers and blood pressure, all these things, and with small molecule drugs, they tend to require a very precise schedule to do these, and it has to be done in what's called a professional phase 1 unit. Usually, average clinical trial centers really don't have the precision to conduct these studies. So there are many of these, really good ones in the U.S., in the U.K., Australia, and Australia tends to be one of those units that can conduct these trials very well. That I've conducted, phase 1s at this particular unit before. So for these phase 1 units, it tends to be, there are multiple, reasons for selecting which unit. The primary reason is it's a unit that that we have good experience with, and they produce high quality information. And the other is it just happens to be some features of how Australian submissions work, that it can actually start a study 2 months earlier than one that is conducted in the United States. So, we wouldn't cut any corners or anything, but I think it's a combination of being able to get the study started earlier, and also, because of the high quality information they can provide.
All righty, well, thank you so much. It's so great to have you guys here. All right, so we're going to get set up for our next piece here, and we get to do another round of Ask the Docs. So we will have Dr. Rubin, Dr. Kohlmeyer, and Dr. Manstadt. if you want to come on up. We've got some questions for you. Thank you so much. So we've got some questions that we've been collecting online for you guys. And then we'll also take questions from the room and online. There you go. I know. I was twisting on it earlier. Or do you want to start with yours? All right, so let's go ahead and get a few questions. Whoop. Get a few questions going from online first, and then we'll go to the audience. And this is just open. They'll answer what they can. Certainly don't disclose any personal information about your medical history, as we would with any of them. And things that they may not be able to answer, they'll let you know that they can't answer them. Okay.
Okay, the first question from online, we'll start with a fairly simple, what I think is a simple one. Is it better to lower your calcium intake and increase your vitamin D in order to bring your levels up?
With vitamin D, you mean
They're on
probably.
standard of care, it sounds like, and they want to know, is it better to lower their calcium and increase vitamin D rather than increasing the calcium?
Yeah, it's a good question, and we can actually fill the rest of the night with this, with the answer of this question. But so the relationship between the amount of calcitriol and calcium is a hotly debated topic, and there are strong opinions for one versus the other. The United States, by the way, has a reputation of giving the physicians giving too much calcium versus calcitriol. Some European colleagues say, well, I only give calcitriol because my patients take enough calcium through the diet. I myself like to not exceed 500 milligrams 3 times a day or 600 milligrams 3 times a day of calcium. The recommended daily dose of calcium for non-hypopara patients, or everybody basically, is about 1,000 to 1,200. We heard this today. And so I personally try not to go higher than 500 3 times a day and then increase the calcitriol accordingly. And if somebody is on 6 grams of calcium a day, I mean, this is really, really hard. I don't know how people do this. And so I would increase the calcitriol. Now, having said that, you don't want to have no calcium or 500 milligrams of calcium or very little of a total amount from the diet and calcium tablets, right? So you want to have at least around 1,000.
I would add to that one advantage of calcium over calcitriol could be the binding of phosphorus. So especially if one takes calcium while they're eating a meal, that would help to bind up some of the phosphate in the diet and minimize the levels of that.
It's a great question, though, because I remember being taught that it was more calcium. I trained in the U.S., and then I'm talking to other providers and realizing, don't be as afraid as a provider to increase active D. We just don't want to overtreat. We feel like if we're using calcium to adjust it more, it's safer, but that's not true. You can take too much calcium and you can take too much active D. So whatever we decide, what's most important is to get your labs frequently and to make sure you have the lab slips so you don't have to go through this rigmarole to get your labs if we make an adjustment. And that's one of the take-home messages, is to have that lab slip when you're traveling, like to a meeting, and you want to get your labs, that you can do that.
And just to add a funny little story that some of you might have heard from last year, one of my patients got up and said, Dr. Manstead, you're responsible for me gaining 20 pounds. You said I should take calcium with meals, so I added a meal to every calcium that I took.
I do remember that.
So you want to take the calcium with your normal meals.
Oh, that's funny. That's funny. Michelle, one more, and then we'll go to the room.
Okay, there's so many coming in. I'm sorry. I'm having to pick and choose here. Are there bone marker turnover tests we should be getting done besides a DEXA?
I don't think that it's something that should be part of standard clinical care. We know that people with hypoparathyroidism tend to have low bone turnover because one of the normal actions of parathyroid hormone is to stimulate bone to do its natural replacement. So in the absence of parathyroid hormone, the bone is a little bit slowed down or paused. So we kind of expect that bone turnover is going to be low. So I don't know what would really be gained from that in a usual hypoparathyroid patient. On the other hand, if somebody does have a bone mineral density test, also known as a DEXA, and they're having bone loss in that, which would be usually indicating that something other than hypoparathyroidism is hurting or affecting the bone, in that case, you would investigate what a potential cause of bone loss would be, and maybe looking at a marker of bone turnover would be appropriate in that case. But in the usual hypoparathyroid person, I don't think it's something we regularly need to do.
I completely agree. Clinical trials are a little different. There you want to measure all kinds of things, including bone turnover markers, when you use PTH-like products. And this is part of the evaluation of a new drug, but that is different from normal clinical care.
Okay, Bob.
Thank you for your time here today. When it comes to issues like diabetes, there was a notable difference once we were able to do at-home glucose monitoring. Has there been any progress in developing systems for at-home monitoring of calcium, phosphorus, magnesium, and other such activities? And if so, what stage are they in, and what expectations could we have?
I was hoping you brought us an update on that.
Okay. Well, we heard at last year's conference this wonderful talk by a scientist from Virginia who is a chemist who is actually developing a, hopefully at one point, home measurement of blood calcium. And I'm always positively surprised and astonished about the success, because that sounds easy. This is hard to do in an academic setting. And that person in his group actually have made progress, has published about it, is trying to get grants, and it boils down to getting some money for the next step, actually. So if anybody is good in fundraising, this is one of a good way of doing that.
I actually have last year is that it's a lot harder than a blood sugar measurement, because you're like, why? You know, why not? So that was really informative last year.
I actually have an update on that. So I'm working with a company in California. We already have continuous metabolic monitoring. We're already doing human trials, and it's using interstitial fluid just like the glucose one is. And we're leapfrogged years past academia because you guys take too long. Sorry, guys. So we already have that. So if anyone actually has access to venture capital money, see me. But we are already doing human trials. So we already have a continuous metabolic monitor that fits under the skin where you can monitor these electrolytes continuously. Yeah, that's our commercial product. It's going to look like a patch, just like the diabetic one. Wow. Yeah. Yeah, it's already in use.
Yeah,
So.
we don't take it personal because we are not involved in
know,
development.
no, I know.
But it would be nice if you can talk more about this development, because it interests everybody.
No, yeah. No, I know. I was just playing a joke because Lynn and I are always making jokes about academia versus private practice. So, the continuous glucose monitors, they use the fluid that kind of bathes your cells outside of the blood, right? It's like the lymphatic fluid. So like if any of you have scraped your knee as a child and sometimes it just bled clear fluid instead of blood, that's the fluid we're talking about. And that's what the glucose monitors are using, is that fluid underneath the skin. And that fluid underneath the skin is rich in information. It is communicating with your blood supply, communicating with your tissue. And so when you analyze that data, it is lagging a little bit behind the blood, but it is still the same information that's in the blood. And so we take that fluid and we can view it under certain patented sensors that will actually read whatever we target. So we are targeting hormones first, but you can target other things as well. And that's what we're in development. I was trying to figure out which ones we're going to target first based on who gives us money. So you give us money, we'll target your whatever you want to target. And so that's the device. And currently it's looks like an insulin pump, but we're designing it to be shrunk down into a patch device. So we're already using it. It's actually an approved device for use in research and in clinical trials. It's been around for a long time, the methodology, how you do it. But what we have done is we have patents on the way you read it, the way you sense the information, the way that information is captured and then relayed. So
we have some complementary studies going on at Columbia, also using what you described, the interstitial fluid. So I've partnered with a bioengineer at Columbia, and he's developed, it is like a little patch. I guess you would say it's like tiny Velcro. It doesn't hurt, but you wear it, and it samples this interstitial fluid, which is, like you said, reflective of the blood calcium levels. So we had one NIH grant, and we now have a paper in revision. Basically, we used hypoparathyroid rats and put this little sensor patch on them and did things like gave them calcium or gave them normal saline fluid in order to see their calcium levels fluctuate, and it does seem to work. So we've actually just applied to the NIH for the next level of testing, which would include some human participants as well. So it's still not ready for people quite yet, but I think for so many of you, it would just be a game changer to know, am I high, am I low, and to know it in real time, not 3 days later and not just an isolated snapshot. So I think that's really key.
That's fantastic. And Dr. Rubin, is that measuring ionized calcium or total calcium?
It's ionized.
Can I be your first patient? I'll volunteer.
We wouldn't have trouble getting volunteers. So.
Hi, doctors. My name is John Colleen. I'm a surgical patient. And just a quick question about the analogs. Do they have an effect on the incidence of kidney stones? Have you got any information on that? That's it. Thank you.
Well, Yorvipath has been shown to decrease urine calcium in a significant and sustained manner. It appears out to nearly 4 years now. So to my knowledge, none of the companies have the data on kidney stones or kidney calcification. We can extrapolate that from the reduction seen in urinary calcium levels that it's likely that kidney stones, kidney calcification, or kidney function would all have good outcomes from that, but that hasn't directly been proven yet.
And that'll be a really important point when somebody goes to their provider and says, you know, I know my calcium looks okay on paper. You don't feel as well as we want you to, and we want to protect your kidney. So that's going to be a really huge point. And I think we have enough data to push that forward in the real world. But when we follow people longer and we see their creatinine improving, their kidney function, and they're making less stones, then we'll be able to confirm it even further.
Hi, my name is Liz. I'm a post-surgery patient, 10 years. I got a question about calcitriol. So I was on Natpara before, but I'm on very high dosage of calcitriol, and I was taking 8 pills per day at 0.5 micrograms or whatever. And everybody I know is saying that's too high, and I've talked to my endo, and she doesn't want to put me on anything else, and she basically told me to go to another doctor. And I've had her for about 7 years now. I'm worried about my kidneys. I haven't had kidney stones yet, but I just want an opinion on what I should be doing.
And I know we're not supposed to and allowed to give individual advice. So the way I would answer that, but I'd love to know everybody's opinion, is that depending on your urine calcium, your kidney function, and your calcium in your blood, whatever you need is important to continue. But I like her recommendation to see somebody who is a hypoparathyroid expert, maybe has more patients, so that, you know, you obviously know so much about hypopara, and it would be very reassuring to make sure that that's really a high amount needed.
Yeah, I agree with that. And the only thing to add is 4 micrograms that you seem to be on of calcitriol is really a very, very high dose. And so that makes people very nervous. It would make me nervous, simply because, let's say, you're not absorbing it well, and then a week later you will absorb it well, then that would actually be dangerous because you can develop hypercalcemia. But that is typical for development and relationship with your doctor if you both know about these risks or the unusual high doses, and that's what you need, and exactly it's what you need.
Hey, so my name is Kevin. I am idiopathic caused hypoparathyroidism, but I was just going to ask what the big difference is between calcitriol, which I know is active vitamin D, and the D3 that we also take. And since you were suggesting to take the higher doses of calcitriol, what's the recommended high dosage you recommend?
Well, first of all, we cannot recommend anything for you in particular, but what typically is done, the calcitriol dose is found by changing the dose and measuring the calcium and albumin and everything else together, right? And so this is being done depending on the dose in certain steps, like 0.25 micrograms, and then you wait typically 3 to 5 days earliest to remeasure the calcium and go from there. So that's the general plan. There's no particular level. It's like insulin. How much insulin should I take? It depends, right? And so we just heard the example of a very high dose. So some people need more, some need less.
And then the difference from D3 is what we were talking about before. That's not active D, and without parathyroid function, idiopathic or post-surgical, you can't turn that D2 or D3 into 125 or active D. And I really like using the term active D. You guys know calcitriol and rocaltrol, but to a lot of other people, it sounds like calcium. So I really like saying active D for the 125 dihydroxyvitamin D. That's the prescription calcitriol. But I think this is a good point, and we're going to say it a couple times this weekend. When you switch from conventional treatment to parathyroid hormone, you really need to keep your 25 hydroxyvitamin D level adequate. You know, maybe 30 to 60. We'll see where people like it, and that's what takes D2 or D3, because you don't want to. You want to protect your skin. So I know you like to get sun, but you want to put on sunblock and take your vitamin D, because that's what you need for the parathyroid hormone to turn it into active D. And I know you've already heard that, but that's a huge point, because we have people that go on parathyroid hormone and they're doing great, and then all of a sudden they're not, and they forgot to take their D2 or D3. We know it's fat soluble, so you could probably forget it for 2 months and be okay, but that's a huge point.
Okay, Michelle, let's do some online.
I have one that just came in that asks, if you have calcifications, they didn't specify where they are. Is there any of the newer drugs that show that they can be reversed?
I think that would be our hope and wish. To my knowledge, there isn't any information showing that calcifications can be reversed. I think the hope would be that they could at least be halted, and maybe in an aspirational hope to be reversed. You know, we have our natural history study at Columbia, which I'll talk more about tomorrow, but that is part of what we're following, namely how calcifications progress over time. Can we predict who will be at risk for calcifications worsening? And we also have patients on PTH analogs to see, can the calcifications possibly be halted or reversed? But to the best of my knowledge, there isn't any evidence of calcifications reversing.
It'll be interesting if there's studies in the future to look at that, because in heart disease, we have meds that reverse calcifications. And so you wonder that, you're treating your parathyroid status, but then if you have calcifications from before, could you be on one of those medications?
And this is for adults, right? In children, it's a little different. There are calcifications that can go away.
Michelle, could you? Yeah, I'm sorry. There's so many. I'm just trying to read them all. Again, multiple people are asking, and I know this question was asked earlier today, but the presenter at that time did not know the answer. It says, does Hypopara affect the immune system in any way?
So I think there is some evidence that infections can be increased in hypoparathyroidism. It's thought to possibly be related to lower levels of the 125 dihydroxyvitamin D, or the active vitamin D. But data from Denmark, where they really have the richest data anywhere because everyone there is in the healthcare system, has shown that there is something of an increased risk in infections for people with hypoparathyroidism.
I'm thinking about moving into all the PTH drugs that we have that are coming to the market. Some people might say that if you're well controlled, you may not need to move to that. So from your perspective, what would be well controlled?
I think everybody needs a trial of parathyroid hormone replacement because well-controlled might be accommodation. You guys are tough, and you may be doing a lot, but if you look back, depending on how long you've had hypopara, you were doing more before, and idiopathic or genetic, you don't know what it was like before. So, I want people to a trial to protect their kidneys, what we were talking about. But I think that is going to be easy for you with your provider to make a case that a trial of parathyroid hormone would be important.
Yeah, the question of well-controlled, I was part with many of my colleagues in several committees and meetings to discuss that question. What is the definition of well-controlled? And we could not come up with anything really tangible because there are at least several areas that play a role. One is the symptoms, of course. So if somebody has daily symptoms, and what are symptoms is also a matter of discussion, you would say it's not well-controlled. But what about somebody who doesn't have any symptoms but has a calcium crash once a year and has almost PTSD from that because it came without you knowing it comes, right? I mean, you could argue this is not well controlled. So these are symptoms. The other thing is findings, like if somebody has no symptoms, calcium levels is fine, yet there's calcifications in the kidney. You would also call this as non-controlled. And then another question is if somebody is on 4 micrograms of calcitriol and calcium, whatever the numbers are, is that well controlled? Well, maybe, but this is really a borderline-ish, right? And so there are many, many instances where you can argue, well, this is not really well controlled.
Yeah, and something that Michelle said earlier really resonated with me, which was that I didn't know that these things were even issues until I got on parathyroid hormone therapy. I can't tell you how many patients in my office say to me, well, it's probably just that I'm getting old, so I can't remember things, and how can I know if it's just like normal aging or not? So, I think maybe even just trying PTH to answer that question would be enormously helpful to people who really aren't sure if they're well controlled or not.
This is a good time to share something really quick. I have a 73-year-old gentleman who's genetic, idiopathic. You look back in his records, his calcium's been low for about 15 years, but not really low enough for anyone to, and make a long story short, his magnesium was low. Finally got him into the clinic. He said he'd had a seizure 2 days earlier, didn't call 911, he's a farmer. And it turns out his symptom, he's, working away, and his symptoms are, feels a little anorexic. He's just not really sure, little stomach symptoms. And, it's just unbelievable how something like that can go that long. And I know that he's going to feel so much better on parathyroid. So I was just shocked that it can be a story like that.
I think Dr. Kim wanted to add something.
Maybe a question. I'll just holler. I was just wondering, just expanding on that question, if a patient's calcium is in the normal range and no other abnormalities in analytes, can there be residual symptoms of parathyroid hormone deficiency?
That's what I asked earlier.
We had that today already. Yeah. Somebody else should answer.
Yes.
It's also possible that that person might just not have a parathyroid reserve, so they might do some extreme exercise or have a viral illness and, can be fine, but with that extra stressor, the lack of PTH, would be revealed that they didn't have that buffer.
So Dr. Rubin, on what you just said, is there any evidence of, because amongst patients, we've had this conversation many times, is there a difference between those of us who have zero PTH, on standard of care, but our PTH is measuring 0, and those who have some, whether it be 10, 14, 15, is that what you're saying? Is if I don't have any to begin with, I have nothing to pull from. And so I may be having symptoms even if my standard of care got my number up to 8.5.
I can say anecdotally among my patients, it does seem to make a difference that I do have some patients who have detectable PTH, and it seems that maybe they do have some partial parathyroid residual function. But on the other hand, some of my patients who do have some low PTH levels seem to be as symptomatic and have the full other panel of biochemical abnormalities. So I do see sometimes that it makes a difference, but not always.
And what I ask the primary care providers in my community is if they're seeing a patient or the rheumatologist, a lot of patients see providers and they can't get an explanation for their symptoms. I say, look at their calcium. If it's less than 9, totally in the normal range, add a parathyroid hormone. This is just my clinical recommendation. And if it's less than 20, call me. Because I think that I think we all know that there are undiagnosed partial parathyroid deficiency.
Okay, we got a lot of questions in the room. We're going to go back to the room.
Hi, my name is Sarah, and I just wanted to know, is there a difference between the serum calcium and the tissue calcium? So what's in the serum might be, and are the different organs, does it matter?
Well, the main regulation is, first of all, through the serum calcium. The tissue calcium might have a little lag time behind this, but I don't think we know enough about differences between different tissues of calcium.
Yeah, we'll go this way and then that way. Yeah.
Hello. I think I asked a version of this question to Dr. Schoenbach about the osteoporosis treatment with hypoparathyroidism. I would like your opinion, or those type of things, or what's recommended, or do you not know? So.
Yes. So it's a very important question because many people who have hypoparathyroidism can be early postmenopausal women, which is the population that's most vulnerable to bone loss. Fortunately, I think a silver lining of hypoparathyroidism is that bone tends to be thicker and denser, but let's say it's not. One option that could be appealing is to use Forteo, that is FDA approved for osteoporosis, and it would at the same time replace missing PTH. So I think that's a good option. That's one of the so-called anabolic or bone-building therapies. The other therapies that Dr. Schoenbach also included were the so-called anti-resorptives that more block the cells in the bone that chew away bone, the bone chewers, which makes sense because we don't want bone to be chewed up in osteoporosis in women who are losing bone. But the problem is that preventing that chewing of bone also prevents calcium from being released into the blood. So we have to be very careful if we're going to use one of those medicines, and those are things you might have heard of, like Fosamax or alendronate, or one of the things that I think you asked about was Prolia or denosumab. So the way those drugs work is by diverting calcium away from the blood into the bone, essentially, so it could worsen hypocalcemia. So I think they really need to be used with a lot of caution in a person who has osteoporosis. I have used them, but you really need careful monitoring.
And Dr. Rubin, would you consider measuring bone turnover markers in patients with hypoparathyroidism on conventional therapy who have osteoporosis and you're deciding upon the drug?
Yeah, I think that's a great idea because it could really help to inform you which way to go. Does the patient already have low bone turnover or is having normal bone turnover?
And the other thing I'd add to that, because men can have osteoporosis too and hypopara, but let's say earlier postmenopausal woman, if she had symptoms starting estrogen, which is a anti-resorptive agent, so we'd have to watch calcium, but that would help symptoms too and prevent the osteoporosis kind of long term, or a weaker anti-resorptive like raloxifene, Evista's been out 25 years, so it still could have the same effect of lowering calcium. In the future, if hypopara patients are on parathyroid hormone replacement, we could think, if it's working well, that we have a new baseline, and then we can treat carefully with all treatments we otherwise would.
And you might encounter people who tell you you cannot have bisphosphonates, which is Fosamax reclassed, or other medications if you have hypoparathyroidism. You hear this often, and I would argue that, as exactly what Dr. Rubin and Dr. Schobek said today, you can. If you have hypoparathyroidism and you're on calcium calcitriol, you can have Fosamax or reclass or other medications. But first of all, contraindications have to be ruled out. You have to know about the medication, and the person who gives it to you, you really have to feel comfortable with it and know how to check your calcium and to increase calcitriol or whatever you're on, if needed.
My doctor wanted me to ask you that question, or as many physicians. She wanted all the opinions she could get.
Hey,
So now you've got 5 different opinions.
there you go. All right.
Yeah.
Katie's.
It's me.
Mm-hmm.
Today, several times was mentioned calcification, kidney calcifications. Looks like this topic is worries many people, and I'm not very informed in these aspects. What is safer for kidneys? What is safer for kidneys? Calcium with vitamin D, let it be increased dosage, or calcium with calcitriol. Looks like in description of calcitriol, it is said that side effect can be also calcinosis. So what is, for example, I have my example. I could reach normal calcium level with calcium and vitamin D alone, let it be like 3,000 units, and it keeps like at normal level. And I'm not sure, would it be better with calcitriol, which I tried, but I had skin reaction for calcitriol, like allergy. And what is actually safer for kidneys? What combination? Calcium with calcitriol or with vitamin D alone?
Well, I think in general, being able to use calcitriol would be helpful because the regular vitamin D has a long half-life. So I don't know of data about this, but theoretically having that hanging around for longer maybe could lead to a higher risk of high urinary calcium, whereas calcitriol is there and gone. I mean, that could be worse for hypocalcemia, but maybe would not increase the risk of a high urine calcium, maybe as much. But your case, I guess, sounds special because you haven't been able to tolerate the calcitriol. So yeah, it might be that in that case, figuring out the best possible regimen with calcium and parent vitamin D is what's necessary. The other thing to think about is hydrochlorothiazide, which is a water pill that helps to lower urine calcium levels and to raise blood calcium levels. So sometimes that could be a helpful thing to add into the picture.
Okay, Bob?
What can be also, one second question, what may be symptoms of vitamin D toxic effect? Like today, Dr. Schobach mentioned like about 3 up to 4,000 units could be considered safe. And what would be toxic effect of high dose?
Right. So I think when she said up to 4,000 units is safe, that's true. But I think most people really aren't on that high a dose usually. I mean, of course, everyone's different and could have low levels of absorption. But vitamin D toxicity really would lead to hypercalcemia and hypercalciuria. The urine calcium would probably rise first, but then the blood calcium would rise. And the symptoms are those of a high blood calcium. So someone could feel nauseous, constipated, lethargic, increased urination, increased thirst, headache. So it's really the hypercalcemia set of symptoms with vitamin D toxicity.
And usually the vitamin D level, is over 200. A lot of times the reference ranges in anything aren't accurate. You got to be careful looking at the reference ranges in your labs. It's better to ask your provider, is this really accurate? Because sometimes it'll be 10 to 150. We know we don't want vitamin D 10. Thank goodness it's not that low on the reference ranges anymore. But 150 is high. I mean, we kind of like it 30 to 60 for vitamin D levels. But if people take 50,000 a day and don't have hypoparathyroidism, they can definitely become toxic, maybe somewhere over 10,000 units of D3 a day. But you're a different situation. If you're allergic to the active D, it'll be great to get on parathyroid hormone replacement if you can, and then maybe you won't need either calcium, aside from your diet, and active D.
Thank you. Yeah.
Okay, we're going to go to Bob. We can take one more in the room, and then we're going to take one or two online, and then we'll be finished.
Thank you. Hello again. In our community, we often hear the question, I can't find a provider in my area. There isn't an endocrinologist who actually knows about this condition. And I know in my own journey, I've had to go through several endocrinologists who have even had on their website and their profile that they've dealt with this condition, but then once I get in there, they really haven't. They've maybe had a 20-minute seminar in med school once. So my question to you is, what advice would you give patients who are newly diagnosed or looking to find a new provider in their area, as far as questions that they can ask in their first appointment, and that intake appointment with that new endocrinologist that might give them some insight into whether this doctor is actually knowledgeable and cares about this condition, since it is rare?
I liked what you said, Michael, where, be kind, be respectful to your provider, but also be firm. And I think this is one of our missions of the Medical Advisory Board, is to put together some questions. And there's that fine line, because you're very knowledgeable and you want to go in and be proactive. On the other hand, you don't want to kind of shut the door before you even give somebody a chance. I'm hoping that we'll be able to have more virtual subspecialties in all of endocrine, because there aren't very many of us anymore. Hopefully there'll be more in the future. But so that, there'll be some virtual endocrinologists that can help your endocrinologist. This doesn't really exist too much yet. But then to go to the big universities, even if it's only every couple years, and see people that do the trials, that's what I would love if happened.
Yeah, and asking how many patients with hypoparathyroidism does the provider see is a question you can ask. It depends on how you ask it, and if it's the first question, might not go too well. But then there are, of course, physicians who might see certain diseases rarely, but are really good physicians and really care about it, and others who might see more patients and don't really have a deep interest, right? So that's another nuance that you might have to figure out. And I remember Jim Sanders, I think, he and the primary care physician where he lived were working very well together, right, and developed an amazing relationship. Bob.
Yeah, that was Dr. Barry Bennett, and that guy was phenomenal. And I was just going to add to this conversation. I live in a very small town up in northwest North Dakota, and we don't have, number one, we don't even have endocrinologists. All we have is a PCP, and I travel to the Mayo Clinic once a year with my daughters for just, to follow-up appointments and whatnot. But as we went through the pediatrics, we actually went to 2 or 3 of the pediatricians in the area, and like Dr. Manstedt was saying, a lot of it was finding somebody that cared enough to want to learn, and that's what made Dr. Bennett so special, is that he did want to learn, and he took the time to talk with other doctors and do his own research, and then develop that. Even though he wasn't an endocrinologist, but he was able to not master it, but develop a pretty good understanding of how to treat this disease. And now I have my current PCP for my daughters. Now he just retired, unfortunately, and we found another one. But he's willing to learn. He's willing to reach out to Dr. Tebben over at the Mayo Clinic and talk to him. You just gotta remember that the doctors work for you first and foremost. It's not the other way around. And if you're not happy with them or what they're doing, then sometimes you're just going to have to cut the cord and leave, find someone else. But you can find them.
Very good. Michelle? Before I ask this last question, I do want to add to that as well and say, yes, I agree with both Bob and Dr. Manstedt. And I think the key is you don't need to necessarily be looking for an endocrinologist. You need to be looking for a provider who is willing to go learn with you and listen to you. And that's much more important. If they're willing to listen to you, you'll get much farther than worrying about whether or not they've ever seen a hypopara patient. They don't have to see one if they're willing to work with you. So on that note, we have a question here that is asking about K2, and is K2 necessary for calcium absorption? And you're all looking puzzled. We get asked this question a lot on social media.
I think there are a lot of things that are over the counter and added to calcium that really don't have the science. Now, there was some interesting vitamin K data 20 years ago in the Nurses' Health Study, but it was never validated. And so, especially because many of you are taking more than 3 calciums a day, it's important that you don't buy something that has a lot of other things in it. And, you never know whether something's really in what you buy over the counter. And so you don't want to buy the best deal calcium because it might not even be in there, and that's tricky. Any other vitamin K?
I don't know if the origin of that is because one of the bone building associated proteins called osteocalcin, it needs vitamin K for it to be like fully activated or carboxylated. But even if that's the biologic basis behind the question about vitamin K, I don't think there's really solid evidence to support using it.
Okay. And we're actually gonna give you guys one more, and we want to hear from each one of you on this, if you can. This is going to be a sort of a Patty and I question that we've pondered based off of things we've seen on social media. Do the doctors have a perspective on what you think a crash is? We know that patients have a different definition of what a crash is, and as we start to go into PTH therapies, do we need to be so cognizant of the number? Does the number matter as much anymore, or is it all about how you feel?
I'll start. I think that's one of the main messages this weekend is to be able to describe your symptoms, because it's almost it's like pain. People have different thresholds of pain. And so, that score of, what is it out of 10? I think that helps, for pain. And so, we've got several different scores for hypopara symptoms, and we try to simplify them. And last year I kind of presented one that we used with HPES. But crash, to me, and I really ask my patients how they define it, but to me, it's where you can't stay home. You can't drive. You don't necessarily need to call 911, but someone needs to get you into urgent care or the ER for IV calcium or fluid. So to me, that's how I define a crash. It's a 10 plus. So if 10 is the worst symptoms, then it's a 10 plus. And how I define with my patients' help, a 9 out of 10 is you're not necessarily going to the ER, but you're hoping it's very, very rare and it's very, very serious. And it takes a long time to get better. And anywhere from a 3 to a 6 is where I think most of my hypopara patients live, and it could just be for a few minutes, it could be for a few hours, depending on how active they are. But the bottom line is everybody's so different, but if you can write that down, try to simplify it, and really give it to your provider, because you're coming in looking good, and they don't really understand at all what you're going through. So I think that symptom discussion is really important.
Yeah, my understanding of crashes mainly come from one patient who really described it very well, and unfortunately I had to see her also in one of these situations. She wakes up in the morning, feels like she's hypocalcemic, has symptoms, numbness, tingling, and takes calcium and is getting worse. And she feels something is coming. Her whole face gets numb. It's like a mask, and she knows this is going to be bad. A general feeling of doom, basically. And then the hands curl, and she takes calcium like crazy, but it doesn't help. And she has to go to the ER to get ionized calcium, right? So a relatively sudden, doesn't have to be minutes, it can be even a day or so, of severe symptoms of hypocalcemia that are not stoppable easily by some calcium that patients typically take when you have symptoms. And that's just horrible. And takes away your entire control. It comes randomly without any reason, or we try to make sense of that. And even in the ER, they take always or often quite some time, especially busy ERs in cities, to get this calcium running. And I was there, and I told them now, and they said, "Oh, we ordered it," and So it is really. A very serious and terrible condition. And the calcium is low. Of course, which level of lowness, that is very different from patient to patient, and we heard this today. I have also a patient at 6.5, no symptoms, right? And others might have these severe symptoms at 7 or so. So that's kind of how I see crashes.
Yeah, I echo that. I think it's absolutely terrifying for the person who experiences it. And I think it's a constellation of physical symptoms that could be different for each person. So it's kind of like a clinical diagnosis, and I think the low calcium level helps to confirm it, but I don't think there's anything like a cutoff that we could use for it.
Okay, and just real quick though, the second half of that question was, as we go into PTH therapy and people's numbers maybe are still a little below normal, at the edge of normal, but they're no longer symptomatic, do the numbers matter as much anymore? Or just is there not enough evidence to know that yet?
I think the numbers matter, but I think the range is going to be wider, and we're going to be able to ask you, where do you feel? Where can you do the most? Do you feel better at 9.5 rather than 8.5? Or are you okay close to 10? I mean, that's scary to be up at 10, but if your kidneys are good and your urine calcium's less than 200 milligrams a day, we're going to have that flexibility. I think the crisis versus crash, when we're just getting back to that because it's related to the numbers, is that it's also individual, and if somebody's using the word crisis because they're afraid that it's going to get worse, that's okay, just as long as you communicate that to us, to your providers. And that way we can make sure that we don't end up with a 10+ severity of a crash in the hospital.
Yeah, and if the serum calcium is 8.5, lowish, or 8, and there's no symptom and no objective impairment of muscle strength, etc., I'd be fine with it.
Yeah, I don't know that the PTH analogs fully disconnect symptoms from the numbers. I think you would still use both pieces of information to decide what's going on.
Excellent. Okay, and I promised Katie she could have her own question here before we end.
Thank you, Patty. Hi, doctors. And I apologize in advance for this difficult question, but I haven't had the mic all day, and so I saved this one just for you. So, from my own journey and experience, many of us, as you know, have had thyroid cancer or something with the thyroid where it's been removed or partially removed, and so that's a common comorbidity that we deal with. Adjusting simultaneously at times, or at least in my situation, to being, post-surgically hypothyroid and hypoparathyroid. And so I remember personally dealing with a lot of symptoms that overlapped between the two, and it was difficult at times to dissect the differences. And so I was wondering, perhaps for those in the room or online with us that might be newly diagnosed or going through a similar circumstance, how do you all approach making that determination in how to treat people with both of those difficulties? And what can we as patients become aware of, and how can we describe our symptoms from each of those things in a way that's helpful to you?
I can start with that. It's an excellent point, and because calcium is so variable in your everyday, not just how much you're trying to take in, but your levels, you're going to need your thyroid checked at least every 6 weeks to 10 weeks, in my opinion, unless you're not making any changes, which is rare, in your calcium. And I know you try to separate your calcium and your thyroid by 4 hours, but to me, your calcium's number one. Maybe not when you're on parathyroid hormone replacement, you can take your calcium later, but I want your calcium by your bed. I don't care about the thyroid. Of course, I do thyroid dose before your calcium. Maybe you could take the thyroid later at night, depending on how late you take calcium. But I think my patients like their TSH to be between 1 and 3, and if you measure it regularly enough, I think that when your TSH is stable enough, then you're going to be the one that helps us differentiate between your thyroid and your hypopara symptoms, because they do overlap. I mean, when somebody's TSH is 30, very hypothyroid, the most clinical sign is this unbelievable chill, kind of cold. It's not dry skin or hair or fatigue or constipation, because those symptoms are everywhere anyway, but it's this chill. And then if you're over-replaced because you went on parathyroid hormone, you're not on very much calcium, and you haven't dropped your thyroid dose yet, you can be anxious and hot and tachycardic, and that's dangerous for no matter how old or young we are. So it's such a huge, important point.
Well, I typically tell people about the TSH as really a very, very good marker of thyroid replacement and sufficiency, and that this is really the finest marker that we have. It's so sensitive to smallest changes. And I also tell people that is generated in your brain by cells that monitor the thyroid hormone levels. So it's your individual body's response to the levothyroxine or Synthroid that you're getting and telling us whether this is the right dose or not. I know life is more complicated, and so is medicine, and there are always exceptions to that, but as long as the TSH is in this range that we target, like 1 to 3 or so, the symptoms are unlikely to be from the thyroid.
Yeah, I think we want to approach both of the two problems optimally and really range, our goal is to have perfect levels in both, so not to overlook the thyroid either. and target for it to be normal.
All right, well, let's give it up for these fabulous experts. Thank you so much. All right, well, we're going to get things wrapped up here as they make their way back. So, have you guys had a great day? Absolutely. Man, wow. 8 hours of learning about Hypopara. We should all feel super educated at this point with it. We'll have a really great day again tomorrow. Tonight, for those of you that are online, we will see you back here at 6 o'clock. We're going to start promptly at 6 o'clock. Again, it's only going to be live streamed. It's not going to be recorded. So if you're online, please be back then. For the people in the room, we will have a little break. The food will be available out there at 5 p.m. Help yourself, enjoy yourself, have a great feast, and then be back in the seats in here about 5:55 so that we can get started. Thank you for a wonderful day, and we'll see you in a little bit.